showing that when you lie down on your back, the spinal cord goes closer to the lead and you feel more stimulation. While when you sit or bend forward, the spinal cord goes away and you feel less stimulation. When you cough, because of the expansion, the stimulation is pretty high. So accelerometer was put in the IPG. So the IPG knows if the patient is standing upright or horizontal, and takes a little bit more when you program it. You got to program it in 3 different positions, but it's very, very doable. And the 6 weeks crossover study showed better and sustained pain relief. This study was done by Michael Nagy and Michael Stanton Hicks. And this is how the amplitude changes. So in open loop SCS, nothing changes if you move the position. But in closed loop stimulation or position responsive stimulation, the amplitude goes down when there is increased pressure inside the spinal cord. There is actual open loop stimulator also available for spinal cord stimulation, which is recently come in market. This is a ECAP. Evoked compound action potentials. Evoked compound action potentials are one of the biomarkers for the pain. So they sense the ECAPs from the spinal cord, and if they notice a train of ECAPs, they will deliver the stimulation. Otherwise, they will not deliver the stimulation. And this is just one of the things that out of these multiple contacts, some are selected for sensing, and then some are selected for delivering the stimulation. Normally you guard the sensing contact with the stimulating contacts. This is the stimulation parameters they are given for different. Normally there is a little bit of baseline stimulation, but when the ECAP events come in a train, the stimulation goes high up. Why can't we use the stimulation on external parameters to close the loop? So this was one of our projects at WVU, where we use heart rate variability, cognitive analysis, sleep, functionality, and made that into an app, and that app will deliver the stimulation. So app controls the spinal cord stimulator, and when these started going completely out of range, it delivered the stimulation. So you can have not biomarkers, but external markers, the surrogate markers, which can make the stimulation start. So this was one of our studies, and in this we use TMS, TDCS, SCS, all those things for closing the loop of the stimulation. We use this in addiction more than pain, but pain and addiction are like cousin brothers. So in addiction, we could sense that when the HRV changes, the relapse is imminent to happen. So we used to start stimulation. It was DBS, nucleus accumbens. Same thing in pain. Some of our pain patients, we kept them on demand stimulation based on the HRV data in their app. And HRV changes, then only the app controls the battery to deliver the stimulation. So you can close the loop in various ways. It doesn't have to be extremely complex lab-based way. You can just do it on external surrogate parameters as well. But I think closed loop stimulation is for future, like body heat powered batteries are for future. I think these are sustainable technologies. In a country like ours, if you have a stimulator which will last for rest of your life, people will always go for it, then change it every 15 years. Thank you.
Thank you very much. That was an excellent talk. I think you're absolutely right. There's no biomarker for pain. All of these are surrogate markers, and although the ECAP-based system is there, It
Yeah.
still is not a true closed loop. That's why they call it a smart loop rather than a closed loop.
Right.
You're right, there could be some external cues that can be taken to close the loop, but as of now, we don't have a true closed loop in pain.
Right.
Any questions?
Excellent talk.
Thank you.
It's an excellent talk, Milind. So, as far as I know, in VNS, only the higher model offers
Auto stim.
some kind of closed loop mechanism by tagging it with the heart rate.
Okay, yeah.
Right.
So you have atrial tachycardia,
Yeah.
so it becomes a closed loop.
Yeah.
So that may not work out for a closed loop for pain. Tachycardia is more commonly associated with epilepsy than pain.
Right. Right.
And if I'm right, I have done some literature review. I don't have experience of VNS in pain, but all the studies of VNS in pain is more for non-invasive VNS. So are you aware of any invasive VNS which has been done for pain?
Oh, Cyberonics and now Levanoma, they will put in VNS for even baldness at some point. Not to criticize a company.
But have they, are the studies done, invasive VNS?
No. I don't think there are any invasive VNS studies. I mean, the first VNS I did was in Arizona with Sherman. That was the first trial. That was in 1996 or 97. That's when it got approved. Then it got approved for depression, and we did bunch of those, like 70 of those. And then the insurance companies stopped paying for it. Then I did it for right heart failure. Then I done VNS for obesity, and we done VNS for a lot of other things. But I don't really see the physiological basis for that. I mean, antidromic stimulation, the vagal pathway, parasympathetic pathway is completely different than medial and lateral sensory pain pathways. So, medial sensory pain pathways goes to locus coeruleus and all those things. And lateral pain pathways, we all know the spinothalamic tracts. Even the associative pain areas like anterior cingulate or prefrontal cortex, all these things are not in vagal distribution at all. So maybe hypothalamic neuromodulation it does, but no, I mean, I haven't seen a trial for VNS for pain. Thank you.
Thank you very much, sir. We again now invite Dr. Milind, sir, for his talk.
That's me, I think. That's me, and then.
Oh, sorry, Dr. Grace, sir, for his talk.
हाँ आएगा सर.
Okay, I don't know why it's still.
Everyone can type their questions in the application.
It seems to be split. So as soon as they sort out, I'll be talking on the facial pain management spectrum. So we'll discuss various facial pain management treatment modalities that I use in my practice. We get huge number of complex facial pain, so it's really important to know which treatment you have to use for which kind of patients. So the conditions that I come across are trigeminal neuralgia type 1 and type 2. We have various trigeminal neuralgia mimics such as the trigeminal autonomic epiphalgias, the post-herpetic neuropathic pain, post-traumatic or post-dental extraction neuropathic pain. And if you don't know what your condition you're dealing with, you then label it as, it used to be called as atypical facial pain, but we now label it as persistent idiopathic facial pain. And the treatment procedures that we're going to discuss are the MVD, the percutaneous ganglion level procedures mentioned there, the spinopalatal ganglion block, great occipital nerve block, PENS procedure or percutaneous electrical nerve stimulation. We have peripheral nerve field stimulation, And very rarely we do things like Gasserian ganglion stimulation or nucleus codalis DRES lesioning. So most common phenotype that we see is trigeminal neuralgia. I don't go into detail here, but it's very important to get a good history, making sure that patient is getting lancinating electrical shock-like pain lasting few seconds to minutes, with typical cutaneous triggers such as eating, drinking, brushing the teeth, or touching the face. And the attacks are pretty much similar, and they're pain-free between the attacks in classical type 1 neuralgia. Of course, if they've had neuralgia for several years, it can get converted to type 2. They should not have any neurological disorder, and it should not be attributable to any other disorder. So that's typical trigeminal neuralgia. Then you have the classical mimics. You have the autonomic cephalalgias, which is quite prevalent in Western population. We see a lot of patients with cluster headache, which is very typical attacks of frontoorbital pain with autonomic symptoms such as red eye, watering from the eyes, watering from the nose, partial ptosis, or swelling of the cheek, etc. Some patients have slightly prolonged attacks, and they fall into category of the chronic paroxysmal hemicrania. For all these complex headaches, we always give them a trial of indomethacin, and if they respond very well to indomethacin, it is chronic paroxysmal hemicrania. That's how you make that diagnosis. Then you have the SUNCT or SUNA syndromes, which are short-lasting unilateral neuralgiform headache with conjunctival tearing or autonomic symptoms. They can mimic trigeminal neuralgia as well. Post-herpetic neuropathic pain, very common again there. They don't have to have the rashes on the face. If they've had shingles affecting any part of the body, they're prone to get neuropathic type of pain in future. The thing to distinguish from neuralgia is that they get slightly continuous pain, burning pain with some allodynia. They can get some shock-like pain as well. They get pins and needles and tingling as well. So that's, and if they've had shingle or even multiple cold sores, then you make a diagnosis of post-herpetic neuropathic pain. Some patients have had blunt trauma or post-dental extraction. They can get trigeminal neuropathic pain. And persistent idiopathic facial pain is not uncommon, where you don't know what the cause is. So for typical trigeminal neuralgia, you start off with medical management, and then when it fails, or if they're getting so much side effects that they're not able to stay on the drugs, that's when you move to the surgical option. There are peripheral procedures which some of the maxillofacial surgeons do, such as the cryolesioning or peripheral blocks. They don't last long. Then there are percutaneous ganglion level procedures. There's a gamma knife treatment and microvascular decompression. So how do I decide which one to go for? Majority of the patients who are young, less than 75 to 80-year-old, we would offer them microvascular decompression if you're able to demonstrate a good trigeminal neurovascular conflict on the MR scan, both the Fiesta or CIS images and MR angiogram. If I don't see a vessel there, or it's a vessel very close to the nerve but not convincingly pressing on the nerve, then I would still offer them MVD. And at surgery, if I don't see anything, then I would do what is called as internal neurolysis. In the past, we used to do partial sensory rhizotomy, but now we have given up on that. We do internal neurolysis, where I would split the nerve into 4 to 6 filaments, the portio major, so you have to protect the portio minor there. So that's what we would do. And this is all slides from the classical MVD, where you have a artery pressing on the nerve, you separate it, put a Teflon, and they get fantastic pain relief. 80 to 90% are pain-free at 10 years. So a typical trigeminal neuralgia, there's no problem with decision making at all there. Whereas those patients who are not fit for surgery, or they don't want surgery, or they've got so much of comorbidity that the anesthetists will say no to microvascular decompression. Or patients with multiple sclerosis, again, it's very common in England. So we see a lot of MS patients with trigeminal neuralgia. So those are the ones we would offer percutaneous ganglion level procedures. So we offer all 3: glycerol rhizotomy, radiofrequency, or balloon compression. And we did more than 1,000 of these procedures. And when we analyzed and published in stereotactic and functional neurosurgery, our results with balloon compression was much better than glycerol or radiofrequency. And it's much better tolerated. So our go-to procedure, if you have to consider a percutaneous procedure, would be a balloon compression. All this involves inserting a needle using classical Hartle's technique, which is all well described. But what is, so once you see the foramen ovale, and this is a trick which is not mentioned in any of the textbook, which I learned with experience, is that when you see the foramen ovale, you have the superior rim, the inferior rim, your medial and lateral end. And it's really important to know where to target depending on what you're doing. Whatever you're doing, never go for the superior rim. So that's a no-go area. Because if you target the superior rim, the needle generally goes into the subtemporal region, and you won't get good outcome there. So you have to target the inferior rim, and depending on which procedure you're doing, you have to target either the medial end or the lateral end of the foramen ovale. And that's because if you see this classical Roton depiction, the Meckel's cave with CSF in it is posteromedial to the ganglion. So the ganglion is the lateral structure, and the CSF in the Meckel's cave is medial. So depending on what you're doing, you have to target different areas. So if you're doing radiofrequency coagulation, where you're putting the needle in the ganglion itself, and because the ganglion is lateral, you have to go to the lateral inferior rim. Or if you're doing absolute alcohol injection within the ganglion, again target the same place. If you're doing a balloon compression, you have to be in the medial inferior rim, because you are actually inflating the balloon in the Meckel's cave and not in the ganglion. Same thing with glycerol, you're depositing the glycerol within the CSF in Meckel's cave. You need access to angiography suite, or you can still do it in theater if you have a C-arm. We would do, that's how we would do that. If I'm doing it in theater, classically insert the needle in the medial inferior rim of the foramen ovale, and then you start inflating the balloon. You should get, if you're in subtemporal region, you'll get cylindrical shaped balloon, which is not effective at all. You should get a pear-shaped balloon, or even a dumbbell shape, but I would avoid dumbbell shape because there's a risk of fourth nerve paralysis with that. So aim for a nice classical pear-shaped balloon, and so you leave the balloon inflated for 1 minute, deflate for 1 minute. So like that, we typically do 3 cycles. Patient wakes up with a numb face, and they're completely pain-free, and you can taper and stop your pain medication. So the success rate is very high, 90% initial pain relief. The recurrence rate over 5 years and 10 years is 20 and 30%. And if you see the Kaplan-Meier curve, it's pretty good with balloon compression. So they get reasonably good pain relief, but it definitely comes back, and you can repeat these procedures. Some of the patients have had these procedures 5 to 10 times as well, but there's always a risk of anesthesia dolorosa. You need to be aware of that. The more number of times you do, you have the risk of anesthesia dolorosa there. So this is the classical pear-shaped balloon in the first, this one. You should avoid the dumbbell shaped. You should never get, if you're getting cylindrical or oval shaped, you need to reposition the needle and aim for that medial inferior rim to get, invariably you'll get a nice pear shape with that. And in the literature, when they analyzed different shape, you can see that with oval and cylindrical shaped balloons, it doesn't work. You have to get a pear-shaped balloon. So it's a well-tolerated procedure. You don't have to wake them up for intra-op testing. You don't have to sit them up if you're like you're doing for glycerol. You don't need expensive kits. It takes me 10-15 minutes to do a procedure. And it's good for multiple division because it does not require multiple lesions. You just need one single balloon to cause damage. Of course, you have slightly higher incidence of transient masseter weakness, which is hardly noticeable. So it's a very good treatment for trigeminal neuralgia. But those patients who are not having trigeminal neuralgia, what do you do? So one of the treatment that is very good is transfacial sphenopalatine ganglion block, which involves injecting long-acting local anesthetic and a steroid into this parasympathetic ganglion. So it's used for various syndromes. How do you locate your pterygomaxillary fissure? It looks like an inverted flower vase. If you follow your hard palette and draw a perpendicular, and you can see a triangle behind that, that's your pterygomaxillary fissure. You have to, of course, line your C-arm to make sure that both the pterygomaxillary fissures are crisp and you can see single rather than a blurred image. And when you do a AP view after inserting the needle, it should be touching the lateral wall of the nose. So that's when you know you are in the pterygopalatine fossa, and then you inject the drug. So they all get some numbness in the roof of mouth, and they get pain relief anywhere from a couple of weeks to maximum I've seen is 6 months, but generally 3 to 6 weeks pain relief will last. There's something that can be repeated. It's more used to tide over the crisis rather than a curative option. And these are all a very good indication for this idiopathic facial pain, post-herpetic neuropathic pain. Cluster headache is fantastic indication. In fact, we used to have a spinopalatine ganglion stimulator. Unfortunately, the company went bust, so you no longer have those hardware. Sankt-Suna syndrome, hemicrania, or post-traumatic neuropathic pain, they are good indication for SPG block as well. Then there's a thing called PENS procedure, which is an outpatient clinic procedure really. So you insert needle-like electrodes across the pain areas and then stimulate at alternating frequency for half an hour, and then remove the needle and the patient goes home. Again, they get a couple of weeks to maximum 9 months pain relief with these, and something that can be repeated. These are all the standard indication for these occipital neuralgia, migraine, trigeminal neuropathic pain, various type of atypical facial pain. You can do for supraorbital nerve, you can do for infraorbital nerve, you can do for auriculotemporal nerve, greater occipital nerve. So different nerves can be targeted by this procedure. A lot of facial pain patients have actually occipital neuralgia because the pain can still spread to the face. So you should be able to do this greater occipital nerve block. We do Doppler guided, so we are much more targeted. And you'll be surprised that a lot of facial pain patients respond well to the greater occipital nerve block. Some rare cases I've done nerve stimulators like here. Then there is an example of a Gasserian ganglion stimulator which I implanted through the cheek. A nucleus cordalis DRES for anesthesia dolorosa could be considered. It's similar to doing a DRES lesioning for your brachial plexus avulsion injury pain. So these are all the things that we do, and if everything fails, we have a famous cathedral next to where I live, and there is this thing called toothache man. So the legend is that patients who suffer from facial pain would go to this church and pray in front of this toothache man to get pain relief. And in 13th century, dental caries was not prevalent. So all these patients actually had trigeminal neuralgia, and they would go to toothache man. So I would send them to that cathedral. Thanks.
Thank you very much, sir. The house is open for questions.
I always tell them they actually go and come actually. I went there to see that toothache man as well.
So you go above the coronoid process, right?
So yeah, it is in the sigmoid notch of the mandible, below the zygoma. So that's where you enter the.
So when we were doing this, the company which made was
Pulsante, yeah.
autonomic technologies. So we used to go above the maxilla.
Yeah.
Much simpler, easier for non-blocked people,
Exactly.
and you end up straight away going between those two pterygoid plates.
With the pulsante, you had to secure it to the maxillary buttress, so that's why you had to go from the face what you're describing.
Right. And then there was that little chewing gum size battery that will
Exactly.
buttress here on the maxilla. Very neat concept. Somehow there was some issues. Joe Taper was involved in it, but they could not market it. So company is still there, but they completely stopped the production.
They have stopped, yeah.
And the second thing I was saying, the Gasserian ganglion stimulators, we have done at least 10 of those. 9 of those came down over the next year or two because the action of the mouth pulls it down. So we are thinking of putting in the sacral neuromodulation leads, which have tines on it. So they will stay in the Gasserian ganglion. because putting it from here, just like you.
So
put-
what we did was, we inserted from the cheek, but
Right.
then I got my max-fax surgeon to make incision in the labial fold, and then retrieve the electrode inside, and we put a plate on the maxillary
Plate on
buttress, so it was nicely secured there, it didn't migrate, yeah.
Because that area is so small that a sacral neuromodulation lead will do very well. I mean, just a small.
But the only problem is it has got tines in it, so
Yeah, so it
Right.
will stay there forever. It will not come out.
removing that will be difficult,
Right.
yeah.
Thank you, nice talk.
Yeah, thank you. Yeah.
Thank you for the talk. How do you recognize if you go for a trigeminal ganglion block? How do you recognize if you're with a balloon inside the ganglion? And what happens if you inflate the balloon inside the ganglion on the lateral side and not on the medial CSF side?
Well, I mean, you must still get the pear-shaped balloon, and you get pear-shaped because the balloon expands in the Meckel's cave as well as ganglion, and if you inflate it further, it tries to come out of the porous trigeminus, which is the mouth, osteodural kind of ring there. That's why then it gets compressed, and then it might come out as a balloon in the dumbbell in the posterior fossa. But the chances of, if you go lateral or if you go superior rim, the chances of it going to subtemporal is pretty high, and might get cylindrical or odd-shaped balloon. So that's why it's always better to go to the medial side and the inferior rim, so that it stays nicely in the Meckel's cave, and also it's very abuts the petrous ridge rather than go subtemporal.
Okay, thank you.
Thank you very much. We now have one more talk. Milind sir, please. His talk will be on evidence-based patient selection and outcomes in pain neuromodulation.
Okay. So, this is, Ramesh gave me this talk, evidence-based neuromodulation and outcomes in pain neuromodulation. Now, as far as the evidence is concerned, in spinal cord stimulation, there is some evidence. In DBS for pain, there is no class 1, class 2 or class 3 or any kind of evidence. And other interventions that we do in pain has very little evidence. So we'll talk about other procedures later on when my talks are there, but this is primarily on spinal cord stimulation. These are my COIs. So how many of you treat chronic pain? Okay, a lot of you. So first thing you need to remember that acute pain is a symptom, chronic pain is a disease. And when you treat chronic pain, you are basically doing a job of a psychotherapist, a psychiatrist, a compassionate listener, and a doctor. So you have to be as much as a psychiatrist, because one of my clinic in the week used to be chronic pain clinic, and I used to be mentally exhausted. I used to see only 8 or 9 patients, but used to be mentally exhausted. At the end of that 8, 9 patients, you had to listen and listen and listen. And that's why those patients will get good benefit. So William Osler once said that sometimes you cannot treat the disease in a person. You have to treat the person in the disease. And this is when I met Ron Tasker. Ron Tasker is a big name in pain from Toronto. And I asked him about this, how did you select the pain patients? And what he said, that everyone who has pain more than 6 months is going to be crazy. You cannot be not crazy if you have continuous pain for 6 months. The idea of whatever you do before is to find out if he was crazy to begin with, and that's why he got the pain, or he became crazy because of the pain. And once you are able to differentiate in that, your outcomes will be much, much better. So I think that's the whole trick in treating the chronic pain patients. Another very, very nice sentence which early in my practice of chronic pain, someone told me, was a statement by Spinoza. Pain is a localized form of sorrow. So whatever sorrow you have in your life, that kind of gets down to a part of the body, and that creates a chronic pain, apart from all the neurophysiological things that happens. So the key points when you treating a chronic pain patient is do not try to cure the pain. Pain will not get cured. Just make it tolerable. Just tell the patients beforehand that it will reduce by 50%. Benefits are the same, lower the risk. So if I do a DBS, I get a 50% benefit. If I do a PNS, I get a 50% benefit. If I do a TMS, I get a 50% benefit. So choose your battles, choose your patients where you think you can get away with a minimally invasive or non-invasive procedure, go for that. And then more than that, know your patient. Find out if there are any other reasons why he is having chronic pain. Are there any social circumstances that need to be dealt with? All those things you got to take into considerations. Type of pain is very important. The more widespread the pain is, the less it will respond. Neuropathic pain will respond the best. The nociceptive pain, musculoskeletal pain will also respond very good. Visceral pain will respond to some extent if it is coming from a specific source. I done DBS and spinal cord stimulators for pancreatic cancers, respond very well. I done DBS and PNS for non-specific abdominal pain, very unsatisfactory response. Find out if there is allodynia. Find out if there is sensory loss. That will decide which strategy you will take. Again, coming back to area of pain. The area of pain is smaller than 2 credit card size. That will respond best to your intervention. Whatever intervention you do. You do nerve blocks, you do peripheral nerve stimulation, you do spinal cord stimulation. Area that is in perfect dermatomal distribution, that will respond very well. Vague areas, midline areas, those areas will not respond very well to any kind of intervention. Neuropsychological examination is a must. Anyone who wants to practice functional neurosurgery has to have a full-time neuropsychologist, because every functional patient has to go through a neuropsychologist, whether it's movement disorder, whether it's pain, whether it's epilepsy. Obvious red flags are generalized pain, psychiatric problem. Subtle red flags are complete improvement during trial. I had patients put in a lead in this evening, go to see them for trial, and they say, I'm pain free. And when people say that, I always think this person is going to come back after 3 months with pain, because you never get pain free if you have pain for like 3 to 4 or 5 years. Pain will be reduced 80%, 90%, but never pain free. And people who chase pain, that this part is better but that part is not better. So those patients, those are the red flags you should think about. Also, the patients who come to your office and say, you are my last resort or you are my God, those patients, be careful with those patients. They have a lot of somatic, psychosomatic involvement in their pain. And that's why these subtle flags you understand as you practice more in chronic pain. Expectations have to be set right. Things are not going to get cured. Things are going to get better. Life is going to be more tolerable. Insurance issues are not so much in India. This is just a trend of my practice in neuromodulation. This is an old slide from 2016. But as you could see, my PNS number went fairly high. SCS remained the same. DBS numbers went down. Motor cortex numbers almost stopped after 2016. But these three modalities, SCS, PNS, ITP, remained fairly high continuously throughout my career, because these are less invasive procedures. So remember, less invasive to more invasive. They have similar benefits. They have less risks. Rather than lesioning, go for DBS. Rather than motor cortex stimulation, go for PNS. Rather than DRES, go for PALMs. TMS or virtual reality are very good in the armamentarium of pain procedures. these are some of the pain procedures that we can talk about, the evidence-based, what evidence we have, but we don't have that much time. So I'm just going to stick to the spinal cord stimulation. And this is a very good paper. I think it comes from Mark Russo's group in Australia. They have Australia and New Zealand, they have given guidelines about and evidence about what evidence we have for spinal cord stimulation. And for neuropathic pain, there is a strong evidence as a primary indication. PSPS is a fancy name for failed back syndrome, persistent spinal pain syndrome. Nowadays they use that, like CRPS for RST. So PSPS, CRPS, peripheral neuropathy, post-surgical neuropathy, strong evidence, class 1 evidence also available for that. Nociplastic pain, not so much, but still patient selection is critical. Nociplastic is a new term in pain. Nociplastic is the centralized pain. What we used to call centralized pain syndrome, now they call nociplastic pain. Nociplastic pain and neuromuscular dysfunction, there is not much efficacy with SCS. You have to think about something else. Ischemic pain, there is good evidence, but it's all observational. PSPS supported by RCTs, long-term observational study. CRPS, again, there is RCT on this, they haven't covered it, but there is RCT on CRPS, and CRPS responds beautifully to neuromodulation. Peripheral neuropathy, there is RCT ongoing, I was part of it, it's a 12-year-old project, we've done about 60 or 70 till now, with very good results. So any kind of peripheral neuropathy, spinal cord stimulation is good. Peripheral vascular disease has actually been approved in Europe. It has got a C mark, so it helps in peripheral arterial disease. And angina also it helps, but it's anecdotal evidence. Contraindications, what they have said, absolute contraindications is treat the primary pathology, so no spinal stenosis, active infections, coagulopathy, major psychiatric disorders, and that's why you have to, I would say even minor psychiatric disorders, unless you bring them under control, don't try spinal cord stimulation. Then they are also given where should we use what. So tonic SCS, high frequency SCS, burst SCS, closed loop tonic SCS. I'm not so much of a fan for this. I mean, I personally think if it is axial pain, high frequency and burst SCSs work better. It's appendicular pain, everything works the same way, whether it's high frequency. I mean, Girish might disagree with me, but I mean, when Neuro came, everyone started putting Neuro, and we saw the results were not very different. On the other hand, with the perceptible SCS, you know if your lead is in the right place or not. So recommendations, they are given recommendations, you need a specialist consultation, you need a patient caregiver education, you need a psychological evaluation, you need diagnostic imaging. Is there evidence that it works? Physiologically, this was our paper. I like to bring it up because it came on Neuromodulation front page, that we actually had shown that the spinal cord stimulation works not on spinal cord but on the brain. So the bane of the pain is always in the brain. Always remember that wherever the pain, it's always in the brain. What we had shown is there is a decreased connectivity between the somatosensory cortex and the limbic cortex when optimum stimulation happens, and that gives you pain relief. So when the connectivity between somatosensory and limbic cortexes go down, you will get the pain relief. Just stimulation or inhibition of somatic sensory area will not cause any pain relief. So it's the affective pathway, that's the culprit in chronic pain. It's not the lateral pathway. Thank you very much.
Thank you very much for that excellent talk.
Thank you.
Any questions? Thank you very much. Thank you. Yeah.
What's your opinion about this pregabalin, gabapentin? There's a huge rise of use of all these medicines. So what do you think is your take for the treatment of chronic pain?
I give it very, very rarely, and especially if you have peripheral neuropathy or something that is lot of tingling, numbness involved. Just for pain, I will not give it. I mean, my patients generally don't like it, but I won't give too much of medicine for chronic pain patient. We have a structured rehab, daycare rehabs, so we bring them there, we take them to the pool, we do psychotherapy, CBTs on them, we just give normal NSAIDs, non-steroidal anti-inflammatory, sometimes tramadol type of things if there is acute exacerbation. We use lot of modalities, TENS, IFT and all that. Pregabalin or gabapentin I give only for patients with actual peripheral neuropathy, and I generally stop it after a month, month and a half, 2 months at the maximum.
The number needed to treat is very high with pregabalin and gabapentin to get one beneficial patient, but it dictates that you have to use the conventional medical management before you consider spinal cord stimulator. So we use it, but it's not very effective for
It's
most
not
patients.
very effective,
Yeah.
no.
But then using this gabapentin and all these neuropathic drugs before going ahead with the invasive procedure, is it recommended that we have to have this period of these drugs and then have some?
But the nice dictates that you have to try the conventional treatment before you put in an expensive device in. So we do try as a part of the multidisciplinary assessment.
So
Yeah.
does it guide the treatment?
No, it doesn't guide the treatment. No.
Just one of the requirements you have to fulfill in American Pain Society's pyramid also, the comes before opioids, but after all the drug treatment that he's talking about. Thank you.
So after this enriching and exciting session, which was about introduction to pain procedures, we move to the inauguration part, and we already have our guest of honor, Professor V.S. Mehta here. We welcome you, sir. So we start with the proceedings. I'll ask Dr. Aishwarya to carry on.
Good morning, everyone. We'll begin with the inaugural ceremony now. At the outset, we would like to invite today's guest of honor, Padma Shri Professor V.S. Mehta, ex-professor and head of Department of Neurosurgery, AIIMS, Delhi. We will request Professor P. Sharat Chandra, head of the Department of Neurosurgery, to invite sir with a flower bouquet and honor him with a shawl and a memento. Next, we would like to invite Professor P. Sharat Chandra, Professor and Head, Department of Neurosurgery, and also the Chairman of this conference. Let us invite Professor Deepak Agarwal, Professor of Neurosurgery, and the Organizing Secretary of this conference with a flower bouquet. We would like to invite Professor Ramesh Doddamani, Professor of Neurosurgery, and the co-organizing secretary of this conference with a flower bouquet. Now let us invoke the blessings of Lord with lamp lighting with a Saraswati Vandana. Now, we would like to invite Professor Deepak Agarwal to introduce the conference.
Thank you, Aishwarya, and good morning, and welcome to the third edition of this conference cum workshop. I welcome Professor Mehta, who has been a doyen and is a doyen in neurosurgery. There are two eras in our department, pre-Mehta era and post-Mehta era. So, Dr. Mehta was when he was the head and chief here, when he went, the era ended with him and the new era came in after that. So we have all learned, I was a resident with him, so we all learned a lot in terms of, besides neurosurgical techniques, how to be administratively, clinically, surgically good in whatever we do. This workshop, 3 years back, we started because for neurosurgeons we found a gap that pain procedures is something which is required. We see every day in our clinics, but we are not usually doing anything for them except referring them to pain clinics. And it was more of a learning exercise. We involved experts from across the world, and that was first time organized by Dr. Satish, who's here with me. And it was a very well attended conference at that time. We learnt a lot, and we took those learnings. I think, and the important thing about this workshop and conference is that we take back the learnings and start implementing them. And we actually started doing facet blocks, epidural blocks. Ramesh took the lead also in that. And I myself had done some gamma knife procedures, 7 to be precise, over this time for various pain syndromes. And we hope to continue this because this is an evolution, and most of our residents are now exposed to pain procedures. I think it is a very important thing, especially when you go outside in the private sector. It becomes a bread and butter managing pain in patients, which we see day in and day out. So I again welcome you to this edition and hope that we'll have a joint learning through this conference and workshop. Thank you so much.
Thank you, sir. We would like to invite Professor P. Sharat Chandra to deliver the welcome address.
Good morning to all of you. Respected Professor Mehta, my mentor. Thank you so much for making it with such a short notice, sir. I know you are very busy, but we realize you always have the first priority to our department because you belong to our department. So we always feel that we have this right to call you whenever we can. And I would also like to invite personally all the faculty, particularly the international faculty who have made it. Professor Ido Strauss, who was there with us a few years back, is from Tel Aviv, Israel. He was almost about not to come because of the war, but somehow he could make it, and we are very grateful. And he is one of the leading functional and pain specialists, not only in Israel, but globally. And we look forward for really learning from him. He came here just a couple of years back, where he learned the technique of robotic thermocoagulative hemispherotomy done percutaneously, and they have implemented this in Tel Aviv, and we are really glad that this could be done there. Professor Milind, my dearest friend, I spent with him, I think, 2 weeks in Cleveland with him and his wife. It was a very nice experience. So he's really open-hearted, and he is always ever so enthusiastic to come and participate in academics and our conferences, and we really thank you for that. Girish, my dear friend, he was my batchmate in MCH, and I think I was very fortunate to have him because we had excellent relationships. We had a competitive relationship, but then we were closest of friends, and we would really help each other. So I'm so glad I've seen him. So currently he is one of the leading pain specialists, not only in UK, but among the world, and he's in charge of the entire subspecialty in Southampton. And anybody who wants to go and visit him, I'm sure he'll be very happy to have you there. And I believe this is only a beginning, Girish. I mean, let's go in for a very long inning. And I would of course like to thank my own faculty Deepak and Ramesh who have taken this initiative, because this has come as a result of a huge unmet need for not only the department but also for this part of the country. So our department as such is already extremely busy. We are doing about 130 surgical cases a week, and we have about 9 operating ORs, and then we do about 30 to 40 gamma knives a week. And it's been rated, it's a legacy department started by Professor Tandon, Professor Banerjee, then Professor, like Deepak was saying, we had a pre-Professor Mehta era, post-Professor Mehta era, so then we had giants like him, and we sincerely hope that we can continue taking this forward. And we are very, very happy to say that our department has been rated number 1 in India consistently, number 2 in Asia, and number 11 globally. And if you look at its rankings, it's even higher than departments of neurosurgeries at Oxford, Cambridge, and even UCLA. So in terms of the work we do, in terms of publications we do. So the question is, when we are so busy, what is the need? Again, we are already struggling to get beds. There is always a need, because the establishment of this institute was to demonstrate a model of healthcare and excellence. So we have over 40 residents, 45 residents, several fellows. So it's necessary that we demonstrate subspecializations in all the areas of neurosurgery. And for some reason, we could not develop pain so much. Not because we lacked the patients, because we were always finding difficult to get some space for them to be done. But now we are expanding. So we have a 1,000-bedded cancer institute in Jhajjar, where again we would be establishing a department of neurosurgery. So being next to a cancer institute, we foresee that there is going to be a lot of space for these procedures to be done. And these are really, I think, very satisfying procedures, because you are able to relieve the pain of these patients. And the very fact that there is an unmet need for this subspecialization is brought out by the fact that there are so many people attending. Our number of delegates attending this is increasing by the day. There is so much of interest for everybody to come and do this. So with this, I once again thank all of you for having made it here, and I will wish that this should continue every year, and you as faculty should come here every year, and we should develop long-term relationship. We should see how we can work together. So I think in this world of increasing division, we should demonstrate cohesion to see how things can be done across the border. Thank you very much.
Thank you, sir. Now let us invite Padma Shri Professor V.S. Mehta to share his valuable words of wisdom about this conference.
Dr. Sharad, Dr. Deepak, Dr. Ramesh, and all the national and international faculty, delegates, ladies and gentlemen. Well, as Dr. Sharad said, yesterday afternoon he called me and said, "Sir, can you come for the inauguration?" But as I said, this department I feel as is my own, so I can't refuse that. So with such a short notice, I decided to come, and it's really a privilege for me to inaugurating this important conference on pain and neuromodulation. And I must congratulate Dr. Sharad and Dr. Deepak and his team for organizing such a conference and bringing national and international experts in this field to provide a platform for interdisciplinary discussions. Now, pain, as we all understand, is not merely a symptom, as Dr. Milind was talking about, but it is a complex personal experience that affects the millions across the globe. And despite the remarkable advances, chronic pain continues to be a challenge to healthcare providers. A chronic pain impacts not only of well-being of a patient, but also emotional health, productivity, and quality of life of an individual. Now, as I was listening to Milan, the management of pain is a multidisciplinary task, and it involves neurosurgeons, anesthetists, neurologists, psychiatrists, psychologists, physiotherapists, and also the biomedical engineers. The neuromodulation has been in practice in past, especially after the gate control theory was introduced in 1965. And I know Dr. Sani, who was our neuroanesthetist, he was doing very regularly the rhizotomy, trigeminal, for glycerol injection he was making of his own, and he had very excellent results in the trigeminal neuralgia. With the advancement in technology, the neuromodulation represents a beacon of hope by harnessing the power of targeted electrical, chemical, and biological interventions. We are redefining how pain can be understood and treated. What was once considered as a refractory or untreatable is now being approached with a precision and a promise. And I am confident that there will be a rich discussions, meaningful exchanges between the delegates and the experts. And I wish the conference is a great success and hope all of you will have very enriching and inspiring experience. Thank you.
Thank you, sir. Now, we would like to felicitate our guest faculty by Professor V.S. Mehta. First of all, we would like to invite Professor Milind Yogaonkar, Director of Center of Neuromodulations and Head of Department, Neurosurgery, Manipal Group of Hospitals, Kolkata. We invite Professor Ido Strauss, Professor of Neurosurgery, Tel Aviv University, Israel. We would like to invite Professor Girish Vajramani, Consultant Neurosurgeon, Center for Functional Neurosurgery, University Hospital, Southampton, UK. Now, we would like to invite Professor G.P. Dureja, Director and Head, Delhi Pain Management Center, to this conference. we would like to invite.
So I owe this to Professor Dureja. I don't know how I didn't see him. I was actually looking for him. I was seeing where is he, I didn't notice him. Sorry, sir. But Professor Dureja has been our mentor right from the first conference. In fact, the first workshop has been done by him. And he is the leading specialist for pain management here. So please consider me as your student and forgive me for this.
Now we would like to invite Professor Dhruv Bibra, Senior Consultant, Pain Physician, Delhi Pain Management Center. Thank you, sir. Now let us invite Professor Ramesh Dodamani to deliver the vote of thanks.
Again, very good morning to everybody, and it's a proud privilege of giving this vote of thanks. So first of all, I would like to thank our guest of honor, Professor V.S. Mehta, as sir was actually contacted yesterday itself, and then he agreed without any second thoughts. So and then when I called, he said, "You send me a cab, I'll directly come from the hospital." Thank you, sir, and thank you for your words of wisdom. I would like to thank Professor P.S. Chandra, the head of our department, and he's in charge of epilepsy surgery, and then I have been with him, so a lot of things to learn from him more. So, and I'm privileged to have him in our department. Dr. Deepak Agarwal, again, he's been the backbone and support for this conference. Basically for the pain and neuromodulation, it was his brainchild basically. So that's when we began, and then we have been continuing on it. This is the third one, and hope to see many more in the future. And then I would like to thank all my faculty members who are here, who have been supporting us in all the aspects. Probably maybe my duties or whatever they exchange without even asking me that or questioning me. Thank you, and all my residents who have been a part of this, especially Dr. Ashwin, Dr. Aishwarya is here, and Dr. Manas, who has been accompanying all our faculty. So all other residents who have been in the background supporting this. Then most importantly, I'd like to thank our anesthesia team who will be in action from tomorrow, because we have a live operative, so we'll be doing some blocks, and also we'll be performing a balloon compression by Dr. Girish and spinopelletine blocks. So it will be an exciting opportunity for all of us to learn and then see new procedures. And then would like to thank our nursing staff, especially the OT staff, who again they will also be in action tomorrow and will be helping out in this. The audiovisual team, they have done a good job, and apart from this, our organizing committee members and the office staff, Dr. Neha and her team, they have been in the background, although this conference is going smoothly because of them. The event management team, of course, Sanjita and the other background team. And the sponsors, yeah, so they have been kind to us, and then because of which we have been able to do this. And mostly all the delegates who have come from all parts of the country. So we have nearly around 90 delegates registered for this. There were more they wanted to, but then we had to stop it, because everybody wants to do cadaver, but then many of them wanted to attend this conference for the live operative. We do have international delegates from Bangladesh, from Nepal. So I welcome you all, and I hope that this will be an enriching conference for you, and then you go back and practice whatever we have learned from this conference. So the main highlight is that majority of the neurosurgeons who are either just passed out or practicing, and they are from periphery. They are not from any bigger institutes because they want to go back and then practice. So again, Professor Dureja and Professor Dhruv, they have been the backbone of this workshop. Especially the first one, we began with mainly the pain part, and then that is how I took up, and I started doing pain procedures in the ORs, and then most of, now I see that during my OPD days, I get referrals from my own faculty sitting there that you go to Dr. Ramesh. If they have some pain in spine, okay, go there, he will take care of it. So especially Dr. Pankaj sends me those cases, which increases my burden. And that is what, the one important thing I want to thank Professor Dureja is that he's been supporting us neurosurgeons. And in the past, I've heard from him that he gets some mails and messages, maybe nasty ones as well, that why are you teaching neurosurgeons? But then he has been answering them that it's my profession and then it's my job. And he has been ex-professor of anesthesia of AIMS, so he doesn't bother about all those things. And then he comes with all the zeal and enthusiasm to teach us. Thank you very much, sir. So thank you very much. And we have a brief breakfast break so that we come back again within 25 minutes or so. I'm sorry, there is a national anthem before that, so we play a national anthem. Please stand up for the national anthem.
शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 जय
So we have a quick breakfast and then come back to the sessions. So we start with the next session. The next session, we have named it as Moving to Specifics, Rewiring the Pain. So I would like to invite the chairpersons for this session, Professor Milind Devgaonkar, Dr. Sachidanand. Dr. Sachidanand is from Onco Anesthesia Department. He is Associate Professor. Dr. Satish Verma, he is Additional Professor of Neurosurgery at our department and my colleague. So we start this session. I'd ask the chairpersons to begin the proceedings. I'll invite you.
Yeah, okay. Good morning, everyone. Are you back from the tea? Should we start? Okay,
I would like to invite Professor Milind Devgaonkar himself, who is a chair, for his talk on DBS for pain. So he will give us a better idea of DBS for pain.
Okay. So this is the first talk of this session, and I'm going to talk to you about deep brain stimulation for pain. I've been doing deep brain stimulation for a long time now, since 1998, and since 2001 exclusively only DBS and spinal cord stimulation. If you look at my numbers, I've done close to 3,000 plus DBS. Out of, if you look at DBS for pain, they are probably less than 100, maybe 60, 65, something like that. So that can tell you the disparity between the DBS for sensory disorders and DBS for motor disorders. Modulation of pain, central neuromodulation, the modulation in the brain. You don't have to put a DBS, you can just give medication. They do the same thing, they do central neuromodulation. You can even meditate. We are writing a new book on theotherapy, the neuroexistential therapy and neurotheology, how God helps reduce aging and stress. But that's beyond the point. And then we can do invasive cranial procedures like DBS and spinal cord stimulation. We can do wearable cranial devices like Cephali, or the one we have here in India is pen band. We can do spinal cord stimulation and still cause central neuromodulation. Or we can do peripheral stimulation, like in occipital nerve stimulation, you can still stimulate the anterior cingulate. So brain intracranial neuromodulation is not always DBS, but we still are going to talk about DBS. And for DBS, what you need to understand is the main one of the landmark papers is by Jamanod. So Jamanod is from Switzerland, and he has been doing interventions in brain for pain for a long time with an absolutely excellent results. And his whole idea of chronic neurogenic pain being a result of thalamocortical dysrhythmia is what piqued the interest of people in putting in a DBS and breaking those thalamocortical dysrhythmias. And what's a thalamocortical dysrhythmia? When thalamus and cortex beats in unison. So what we used to do during pain DBS, we used to put two leads in the thalamus, and they were externalized and they were attached to monitors, and we also used to do scalp EEG, and we could see the coherence. The thalamus used to go at 4 hertz, and the cortex also used to go at 4 hertz. Cortical firing increases, the thalamic firing used to increase. So as if they are synchronized. That is called thalamocortical dysrhythmia. Actually, it's a wrong name. It's a thalamocortical synchronization, but it's called TCD. And that what causes all the positive symptom neurological disorders. May it be chronic pain, may it be tremors, may it be psychiatric disorders, there is some degree of thalamocortical dysrhythmia. And Chamanos described this, and he actually found out the posterior limb or the descending limb of CL. Now, thalamic nuclei have hundreds of names. So, for this pain, we will use the Morell's terminology, which is more appropriate. So, VL is nucleus ventrolateralism. It's one of the intramedullary nucleus of thalamus. It's like a scimitar, and the posterior limb of the CL is where you generally want to attack for chronic pain. Now, this idea of thalamocortical dysrhythmia was further demonstrated by Rudolfo Linas when magnetoencephalography came. So he found out a MEG signature of thalamocortical dysrhythmia. This is my picture with him. This is me in last life with full head of hair. and that's Ali Razai, and that's Andre Machado, and that's Rodolfo Linas when he had come to Cleveland Clinic. So these are all the procedures for intracranial neuromodulation. We are not going to talk about others. We're not going to talk about this. We're just going to talk about DBS. So what are the targets for DBS? One is sensory thalamic DBS. So you put a DBS in VC, nucleus ventralis caudalis, or the sensory nucleus of thalamus. CL DBS, you put a DBS lead in CL, but you put bilateral CL leads, because modulating unilateral CL does not help. As you can see, this is one of our patient who has a VC lead and a CL lead on one side and only CL lead on the other side. So contralateral side of pain, you put a VC lead, and then you put CL leads on both sides. The next one is PAG, PVG, periaqueductal gray, ventricular gray. Periaqueductal gray is a very good target, but what it does, it releases endorphin. That's the source of internal release of endorphin. So it's very good in musculoskeletal pain. I done DBS for intractable back pain. I done DBS for intractable ankle pain in a ballerina where nothing else was working. But that was not neuropathic pain. That was just musculoskeletal pain. Nucleus accumbens DBS, this is a very good target, and this can be used in thalamic pain syndrome, because in thalamic pain syndrome, the substrate, the sensory nucleus of thalamus, CL, is already stroked out. So you cannot put a lead there. So you can go to nucleus accumbens and take care of the affective component of the pain. Posterior hypothalamic DBS, we just done one DBS, and that was for cluster headache. It's complicated. You cannot measure the responses. Programming is, I mean, we didn't have the directional leads then, but programming was awful. Rather than doing a posterior hypothalamic DBS, I will rather do SPG blocks or SPG stimulator, or a combination of supra and infraorbital stimulator and occipital nerve stimulator for cluster headaches. So sensory thalamus, basically when you put the lead in the sensory thalamus, you make sure that the last target, the last contact is at the bottom of the VC, in the middle of the VC. So bottom of the VC is much more lower than the bottom of the VIM, at least 4 millimeters below the bottom of the VIM. So your contact 0 goes down to the middle. So you generally target 2 millimeter in front of PC, and then climb back, and thalamus has such a beautiful somatotopy that if you have face pain, you can just put in a face area. The only problem in this is programming is very difficult, because even slight increase in current and patient will feel it. We've done some isolated VC DBS, and we had a programming nurse. She was a mid-level practitioner, and she always used to check the impedances before doing the programming. And pain patients, I will program myself, but when once went to her, she checked the current, and while the machine ramped up to 3 volts and the patient jumped and started clawing at her, it was so much of pain. So normally VC DBS 0.51 is good with a very low rate. We go to like 30 or 35, maximum 50. And these give good benefit, only they don't last long, and that's why you have to attach CL to both of them, either alone or with VC. It modulates the affective pathway. So what you are doing now is VC is your standard lateral pathway and CL is your medial affective pathway. So when you are modulating both pathways, you get effective pain control. 6 millimeter from third ventricle, 2 behind PC and at ACPC. So again, 3 leads. Most of these patients that we did had 3 leads. And we use Morel's atlas, and this is the posterior limb of the CL. This was generally our trajectory. CL is a tall nucleus, so, and it kind of fires at like 4 hertz, no background, so it's not very easy to find out using MER. These were some of our earlier patients, 7 patients that we did about 21 years ago, 25 years ago, in 2001 or so. And these are the durations of follow-up, 23 years to 17 years. These people still call me. 2 we had to explant because it was not working in 1, and second needed some kind of procedure. 3 we have reasonable benefits. 2 are completely pain-free even after 23 years. Both were face pain, atypical face pain. Anesthesia dolorosa responds beautifully to DBS. And these are the some of the follow-ups. This is a VAS, and these were the follow-up in the immediate post-op period. What's important to remember is pulse width of 60. That time 60 was the limit, but now we can even go down on it. So we can go down to 30. Amplitude of ipsilateral CL is half in contralateral. So the ipsilateral CL should be at, if contralateral CL is at 3, ipsilateral should be at 1.5. Rate of 25-30 is the best tolerated, and it gives a feeling of warmth. There are so many things that happen. No one knows intralaminar nuclei of thalamus what they do. They make you more aware. They improve your sleep. Some patients told us they had extrasensory perceptions. Lot of things. Some of the things I cannot talk in front of people, but they did lot of changes. This intralaminar nuclei. Higher rates will worsen the pain. Even in CL, if you increase the rate, the pain will get worse. Higher pursuit will cause sensory side effects. Deeper cathodes that go below ACPC line can cause imbalance, because that's the area somewhere cerebellar fibers, dentato-rubrocerebellar tract comes. Anterior and medial contacts produce dystonic activity because you are now stimulating CMPF. Nucleus accumbens DBS, this was one of our NIH grant R01 with Andre Machado, and I was a co-PI. And we put in nucleus accumbens in the thalamic stroke syndrome patients. The target is 7 millimeter lateral to midline, 2 millimeter in front of AC, and 4 millimeter below ACPC. So you want one contact at least be, in the deeper to the ACPC band. This was published in Annals of Neurology. The benefit in the pain was not very much, but improvement in the quality of living was statistically significant. So patients had pain, but they did not care for them. PAG again works well, but as I said, it works because of endogenous endorphin secretions. 2 millimeters from wall of third, 2 to 4 millimeter behind PC, and up to the upper margin of superior colliculus. Posterior hypothalamic DBS, very complex to program, and this is one of our paper we are writing, 21-year follow-up of 50 patients of pain DBS. So this is the most recent after 21 years. Motor cortex stimulation, we'll have another talk for this. Thank you very much.
Thank you, sir. I think we have 2 minutes more, so we can take one question from the audience.
Very nice work from pain, because very few people have done
Thank you.
So, sir, my question was that we use microelectrode recording along with radiofrequency ablation for pain, common at our center. So I would want to know, I know it's difficult, but still, apart from the fluid discharges, what all nuances do you use for targeting CLP and PAG?
I mean, MER doesn't help very much. CL targeting is very easy. You go anatomically ACPC and you will be in CL, and CL is a tall nucleus. And the nuclei around CL, if you look at them, so most of I cannot, it's gone. But most of those things around CL are either MD, mediodorsal nucleus, or pulvinar. So if you are not too lateral, you can safely go ahead and make a lesion. Actually, Jai Manod has been doing CL thalamotomy, RF thalamotomy for now almost 30 years and he has excellent results. But if you really want to do, use MRG FUS. HIFU is the best thing for these kind of thalamotomies. PAG also, nothing significant area around. As long as you are okay with your ACPC target, you can safely make a lesion. There should not be any issue. The only issue can, even in nucleus accumbens, you don't have to go to nucleus accumbens. You make a lesion in anterior capsule, internal capsule, or 4 millimeters below the ventral striatum, you can still get the same benefits. All these pain targets, MER is not very useful.
So what I try to do is that try and go search the bottom of the thorax and then come 1 to 2 millimeters above it, which is the bottom, should be the bottom of CLP, and then give macro stimulation and look for.
Use Morell's atlas, because SW atlas does not really give you very good idea of where CL is. CL is much more medial, much more posterior, very medial and posterior.
Yes.
So,
Thank you, sir. Yeah.
thank you.
Thank you, Dr. Milind.
Thank you.
Now, I would like to invite our next speaker, Dr. Girish Vajramani, and he is speaking on spinal cord stimulation, how I do it, techniques and complication avoidance.
Okay, thank you very much. I'll be talking on spinal cord stimulator, how do I do, because it's got only 10-12 minutes, so I'll have to be very judicious what we do. So we do a huge number of spinal cord stimulator implants. I do about 150 implants every year, both spinal cord stimulator as well as dorsal root ganglion stimulators. It's really important to be very meticulous with these procedures. You've done a very good assessment, multidisciplinary assessment, selected your candidates, but if you don't do the surgery meticulously, then your outcomes won't be good. So you really have to follow these steps very meticulously. And today I'll be focusing mostly on the percutaneous implants rather than the paddle implant, because 70 to 80% of all the implants that I do are percutaneous. Very rarely we do paddle implants for some select indication. So we'll go through the principles, the anesthesia, positioning, C-arm use, and we'll briefly see implant video as well. So there are different types of percutaneous implants to consider. We do percutaneous temporary trial, where if the patient definitely wants a paddle implant, then we would do a trial, remove the wires and put a paddle at the later stage. We used to do a percutaneous permanent trial, so you do implant the electrodes and the extension wires, but at the end of it you cut the wire and then a week later you can implant the IPG. But a research trial that was done in England, where trial versus no trial was compared, we didn't find any big difference. So these days we do what is called as direct to implant. So we might do an on-table trial, do the testing, and straight away implant the battery at the same stage. That is what most commonly we do. So in terms of principles, it is quite a team approach, and in theater when you're implanting, you have to be absolutely certain because there'll be so many people in the theater, the implanter has to know who's doing what to improve the streamlining the whole process really. So you have a surgeon, an implanter, you have fellows, you have the anesthetist, you have the circulating nurses, the neuromodulation nurses, then you have the radiographer, the surgical technician, the device representative. So really, you need to know who is doing what, and also you have to ensure that there are not too many people in the theater, because infection is one of the risk factors if there are too many people in theater. What sort of anesthesia do we do for these patients? If I'm doing on-table testing where I have to wake them up, so I'll do a light sedation, give lots of local anesthetic, wake them up, do paresthesia mapping, and then resedate for rest of the procedure. That's much better. If I'm doing anatomical placement of electrodes without having to do paresthesia mapping, then we can straight away do under deep sedation, slightly deeper sedation or conscious sedation that we call. You don't have to wake them up. It's much easier. Technically, you can do percutaneous implants under general anesthesia, but I would not recommend it, because once you are in a GA, you lose that tactile feedback, so you're not sure whether you've entered the epidural space or not. There are higher risk of CSF leak with those procedures. In terms of positioning, you have to make sure that the table is arranged that way. The column of the operating table is at the caudal end of the bed, so that the C-arm can easily go to the under the thoracic spine or even higher up if needed. So you have to make sure that nothing is there underneath the table there. So the column is at the caudal end of the patient. So this is how the patient is lying with the head on this side and the foot on that side, lying so that there's easy access for the C-arm. So in terms of C-arm used, you should not start any procedure without ensuring these two things. You have to square the end plates. By that you mean that the end plates should be very crisp and nicely seen. So you may have to do a cordocranial or craniocaudal tilt of the C-arm to make sure that the end plates are crisp. You have to ensure that the spinous process is between the two pedicles, so it's nicely in the midline. So once you have demonstrated that, then you're allowed to start the procedure. So that's the most basic thing you have to do. Your skin entry point is being marked here. So it's if you're doing it from the left side, 3 o'clock of the generally L2 pedicle is my skin entry point, or if I'm doing from the right side, it's the 9 o'clock of the L2 pedicle. When you do C-arm, sometimes you get this kind of picture. It's called as a quantum mottle. You get a grainy picture there, and there could be various reasons. Could be low energy from the X-ray, or the patient could be obese, or there could be conversion efficiency of the input screen. So there are various reasons why you might get a quantum mottle, and if you get that, what you have to do is either increase the strength of your X-ray, increase the MA, or you can switch to continuous mode to get a better quality, because for all spinal cord stimulator implants, you need to get a good quality X-ray images in theater to do it safely. So I told you about this 3 o'clock and 9 o'clock. So the needle has to enter the epidural space. So once you insert the needle, it will first land on the spinal laminar junction. Then you walk your needle forward into the epidural space using loss of resistance saline. Now, most neurosurgeons are not trained to do this loss of resistance technique, but it's pretty easy to learn. And because we do a lot of spine operations, you can visualize where it is entering. So it should be easy skill to pick. So you put two needle in and put two electrodes in, and then you might do on-table testing or just do anatomical placement. And you have to do lateral X-ray always to demonstrate that your electrode is in the posterior epidural space, because it's easy for the electrode to slip onto the ventral epidural space, which is not good. So there are what is called as safe and dangerous zones on the lateral view of the X-ray. So if you're a new implanter, you always have to do lateral, even with the needle on the spinal laminar junction, to be absolutely safe that you're not causing any CSF leak. And you need to know how deep you can go based on those the safe zones on the lateral X-ray.
You should know about the radiation safety. You need, because you'll be using a lot of C-arm. So you and your radiographer should be on the same page. How much X-ray we are using? Is it single shots you're using, or you're using continuous fluoroscopy? So all that you need to factor in. So generally, you need to be away from the X-ray source as much as possible. Wear lead gowns. I also wear lead gloves we have there to minimize the exposure, and do X-ray only when needed. Don't use it continuously when it's not needed. So you need to be aware of the radiation safety when you're doing these procedures. So with this, I'll show an implant video. This is a temporary trial that we did, and we did this for the neurology India actually. So I'll start
to allow craniocaudal angulation of the C-arm as shown here.
So this is the patient positioning.
The level is marked using C-arm.
So
The
I'm
skin
marking
entry
the
point
L2
is
pericle
usually
3 o'clock.
At 3 o'clock
You do the skin
or
marking
9 o'clock from the
do a lot
right
of
side of
local
the
anesthetic,
penicle,
usually
level
mixture
below
of
the epidural entry,
bupivacaine and 1%
usually at
lignocaine with
T12 L1
adrenaline.
or L1 at
You
this
then make
space.
a incision about 1 or 2 inch and make a nice pouch to accommodate the strain relief loop of the electrodes. And also you have to expose the fascia, because you have to make an incision in the fascia later on to get the anchors inside the fascia. So this is, I'm making a pocket there above the fascia. So once you do that, you then insert your 2He needle and the X-ray guidance, and the continuous fluoroscopy at this stage helps.
The needle is
So once you do that, you walk your needle into the epidural space using loss of
technique.
resistance to saline. You can use air or saline. I prefer saline. So as soon as you get that giveaway sensation and few drops of saline go inside, that means you are in the epidural space. You then insert your percutaneous electrode through the needle, and you can steer these electrodes to right, left, whichever side you want.
In the midline
So
posterior
generally, you
epidural
go for the
space.
midline unless patient has
top of
unilateral pain and
T8.
you want to do this paresthesia mapping. So you have to put it slightly off the midlines to the side where he or she has the pain. Generally, we insert 2 electrodes in, and again depends on which company you're using, and which waveform you're using. If it's a high frequency, we would put 2 in a staggered manner. If it's a closed loop, I would put 2 side by side. Same with if you're using Boston Scientific
Lateral
System, you
view
have to use
is done
side by
to
side.
ensure that
Always do
the lead
lateral.
is in the
It should not be
posterior
an ego
epidural
question.
space.
You should always do a lateral, because
The
it's
second
easy
2He
for the
needle is
electrodes to slip
inserted
into
either at
ventral
the same
epidural
level
space.
or a level below.
So once you're happy that the electrode is in good place, then you have to remove the 2He needle without dislodging the electrodes. So there's a nice technique there where you have to hold the electrode and gently pull all under X-ray guidance. You have to remove the needle. So here I'm putting the second electrode in actually.
The percutaneous lead is inserted till top T9 with staggering of the leads.
So one on
It is
each
important
side,
to
I
confirm the
might do it
lead
in a
location
staggered
on
way.
AP and lateral screening.
Sometimes you have slightly thick ligamentum flavum, and it won't allow you to steer the electrode where you want it, but with perseverance and practice, you'll somehow get it there. Because you would have done the preoperative MR scan to make sure that everything is safe in thoracic spine for you to insert these electrodes. So this you can see is a staggered way of inserting electrodes for high frequency stimulation. And once you do that, this is the stab in the fascia that I was talking about. You have to do this when the 2He needle is still there, because once the needle comes out, you can't make a stab incision because it might damage the electrode. So you have to do the stab incision, because when you're inserting the anchors, the nose of the anchor has to get buried inside the fascia to allow to prevent any dislodgement of the electrode. So you remove the needle, making sure that electrode stays nicely under C-arm guidance. And then you remove the stillet, and then you insert the anchor, always
The
holding the
anchor is
electrode, making
placed
sure
on the
that
lead and the
it
screw
doesn't, so
tightened.
you don't accidentally
The anchor
pull.
is
Since we have an
fixed to the
assistant,
fascia
he can
with
hold
silk
the electrode
stitch.
there. So you insert the anchor, lock the anchor, and stitch the anchor in place. So you do same thing for the other electrode as well. Once you secure this electrode, you then remove the needle for the second electrode. And then depending on what you're doing, if you're doing a full implant, you then make a pocket in the supragluteal region and then tunnel these wires using the 2 needle or the tunneler, and then implant the battery there. So that's how I would do a percutaneous implant. It should take anywhere from half an hour to 45 minutes to do the whole procedure skin to skin, but only if there's a good flow of the procedure. You know what you're doing, and you're absolutely meticulous, because you have to be obsessive compulsive about any implant in functional neurosurgery, because even the closure, I tell my registrars that closure is very, very important, because if you don't close properly, then stitch abscess, the implant gets infected and you have to explant the whole thing. So closure is equally important in any functional neurosurgery procedure where implant is involved. So I think if you're meticulous, your lead migration rate is low, your CSF leak rates are very, very low, your infection rates will be very low, and you'll get good outcome. I think that concludes my talk. Thank you.
Thank you, Dr. Vajramani, for that insightful lecture. We can have a couple of questions because we still have some time.
So what is your complication rate in your hand?
So infection rate is less than 1%. We had 4 infection when I started implanting the devices way back in 2010. And I realized the reason, because I was telling the extension wire anti-gravity. So whatever leak was happening, where the wires come out, that would track into the battery side and was getting infected. So now I put all my extension wires as a gravity, this one. And where the extension wires come out, we put a per string stitch, so there's absolutely no leakage there. But as I said, the practice has changed. Now you do full implants. Our infection rate is very low. The Dorsal, the CSF leak is again very, very low. It happens, but you can always go the other side or a level above or below to implant the electrodes. Lead migration rate is low. That's why we have, most of the cases we are doing percutaneous, even in patients who are very physically active. But there are always patients who say they want to play golf or do a lot of exercises. So in those cases, we would implant a paddle electrode.
Also, for patients who have infection, what is your policy? Obviously, you explant it, but then you again do the procedure, and after what time?
Yeah, so if there's an infection, we try to salvage the lead and battery by doing washout and antibiotics and things like that. But once infection sets in, there's always a biofilm which forms over this hardware, and it's impossible to eradicate the infection how much ever you try that. But eventually the electrodes, we have in fact salvaged some of the devices, but yeah, you have to explant at some stage, wait for 3 months, and then reimplant it.
So, sir, in any of your cases, did you need to convert it to open procedure?
No, not on table, because they're under sedation local. We won't do it on table. If you have technically failed because of thick ligament or for any reason, then I'll bring them back for a paddle implant. 1 or 2 we have done that way, yeah.
Right.
But not on the same sitting, yeah.
All right. Thank you.
So any lead migration post-implantation?
Yes, it can happen. No, the leads can migrate. That's why our physiotherapists are very, very particular, because there's a restricted physical activity for almost 6 months actually. They can't lift their arms above the shoulder, they can't bend forward. So there are some restrictions, because it takes time for the wires, for body to form a scar tissue fibrosis. So as long as the patients are sensible, they all would have had what is called as education session beforehand, where our nurses will explain what to expect, what sort of restrictions you'll have, what to do, how to look after yourself after the implant. So all that they would have had beforehand. So that helps actually. So yes, previously we had a few migration, but you can always revise the electrodes or put a paddle at a later stage if needed be.
Thank you, sir. So we can have the next lecture by Dr. Mattis, who is presently not here personally. We have a recorded lecture of him. Audiovisual team, can you please play the recorded lecture?
Till that time, I would urge everyone to please open the web scan. Already you must have scanned. Please give your feedback, answer the poll questions, and chat. So obviously offline we will keep answering those chat by the speakers. We'll ask them to put it in the chat box.
Greetings from others. My name is Maris. Thank you very much for having me. I was asked to speak about spinal cord stimulation, a favorite topic, indications, techniques, and outcomes. Let's start with pain first. We all know that there is an unmet need here. Chronic pain is one of the most prevalent and debilitating conditions worldwide, affecting more or less 25% of the global population. It arises when pain signals become dysregulated or occurring in the absence of identifiable tissue damage. We all know that conventional treatment strategies, including pharmacotherapy, physical rehabilitation, and surgical intervention, frequently provide inadequate relief. Many patients remain trapped in a cycle of poor pain control, reduced function, and diminishing quality of life. Spinal cord stimulation is one of the many neuromodulation options. It is an implantable or reversible neurostimulation therapy delivering targeted electrical impulses to the dorsal columns and horns of the spinal cord, modulating aberrant pain signal transmission before it reaches conscious perception. So we have electrical impulses, precisely calibrated waveforms delivered via epidural leads, electrodes to the posterior epidural space adjacent to the dorsal columns. We have signal modulation. Therapy interrupts and modulates ascending nociceptive transmission, reducing the brain's perception of pain without damaging neural tissue. And we have a durable analgesia, long-term pain relief sustained over years with adjustable parameters that can be tuned as the patient's condition evolves. How does it work? Spinal cord stimulation exerts its analgesic effects through several complementary and synergistic mechanisms: neurotransmitter modulation, descending inhibition, cortical reorganization. Spinal cord stimulation promotes the release of inhibitory neurotransmitters and mainly GABA within the dorsal horn, suppressing excitatory pain signaling, and serotonin and adenosine pathways are also implicated in this procedure. Descending inhibition stimulation activates supraspinal structures, reinforcing descending inhibitory control from the periaqueductal crane and rostral ventromedial medulla, the natural pain-suppressing circuits in the brain. Cortical reorganization. Spinal cord stimulation is associated with measurable changes in cortical activity and connectivity, particularly in pain processing regions, suggesting neuroplastic adaptation beyond simple single signal blockade. Today we have different types of stimulation, different waveforms. We have high frequency stimulation with 10,000 Hz, 10 kHz, a stimulation below the paresthesia threshold. We have burst stimulation, which mimics natural neural firing with packets of closely spaced pulses. And the interesting thing here is that this type of stimulation targets both the sensory and the affective, emotional, cognitive dimensions, aspects of pain, meaning that it is associated with improvements in anxiety and mood comorbidities. We have closed loop systems which use real-time neural feedback to automatically adjust stimulation intensity. compensating for positional changes, ensuring consistent optimal dosing throughout the day. And then we have the traditional tonic stimulation, stimulation with the tingling sensation with paresthesias, and newer subperception modes like fast-acting subperception therapy. And all of these waveforms are tailored to patient preference and pain distribution. Who benefits from spinal cord stimulation? There are many indications. The major one is the famous failed back surgery syndrome, or the new term persistent spinal pain syndrome, which is actually persistent radicular or axial or both pain following lumbar and spine surgery or cervical or thoracic spine surgery. And this is the single largest indication for spinal cord stimulation implantation. Patients with complex regional pain syndrome, type 1 or 2, with or without capsalgia, patients who have allodynia, autonomic dysfunction, and disproportionate pain after injury or nerve damage. Diabetic patients with this painful diabetic peripheral neuropathy who are reporting burning, shooting, lower extremity pain, refractory to pharmacologic management in diabetic patients. Ischemic pain, stable refractory angina, critical lip ischemia. We are talking here about patients who have already received stents or bypasses. They are taking medications and they still have pain. And the last group is the cancer pain. Selected patients with refractory cancer-related pain, neuropathic pain, which are not adequately controlled by opioids or adjuvant therapy. The leads we are using, the leads that we are implanting, are precisely positioned in the posterior epidural space, overlying the dorsal columns and the spinal levels corresponding to the patient's pain distribution, translating anatomy into analgesia. For example, if we have a patient with back pain, we will place the tip of the lead at T7, T8 or T9. The procedure. The most important step is the patient selection. We need a comprehensive psychological screening, pain mapping, and multidisciplinary evaluation. There is typically a trial period, 5 to 7 days, in some countries 2 weeks or 2 months even, but this is mandatory before permanent implantation to confirm efficacy. Perioperative management, we have to take into consideration the anticoagulation breaching, antibiotic prophylaxis, imaging review. We are performing this procedure under fluoroscopic guidance. The patient is usually awake or under light sedation for real-time feedback. During the implantation phase, we have percutaneous cylindrical leads or surgically placed paddle leads, which are advanced to the target level. We have a battery, a neurostimulator, this IPG, the implantable pulse generator, which is placed subcutaneously in the abdomen or usually in the buttock area. Postoperative care, activity restrictions for 6 to 2 weeks, 1 to 2 months, incision monitoring, systematic programming optimization. We need a long-term follow-up, which includes battery monitoring and parameter adjustments as needed. And we have some emerging technologies that make the life of our patients even better. We already discussed about these ECAP systems, that is ECAP control closed loop spinal cord stimulation. When we stimulate the spinal cord reacts with these evoked compound action potentials, which we can actually measure. And this is the spinal cord's real-time electrophysiological response to each stimulation pulse. The systems can automatically adjust output to maintain a consistent therapeutic neural response, compensating for postural changes and impedance variation. We have clinical data showing superior pain relief consistency compared to open loop systems, the first traditional systems. And then we have another neuromodulation technique, the dorsal root ganglion stimulation, which targets the dorsal root ganglion with highly focal electrical stimulation. It is particularly advantageous for discrete pain territories, mainly the foot. And these are areas that are difficult to cover with conventional dorsal column spinal cord stimulation. And there are studies, especially involving CRPS patients, showing superior outcomes in, for example, this accurate RCT study. Do we actually have improvements with this therapy? Yes, we have. We have pain reduction. The majority of appropriately selected patients, and this is very important, the selection of the patients is the most important part in this therapy. These patients achieve at least 50% reduction in pain scores, which is actually the standard benchmark for clinical success in neuromodulation trials. We have functional gains. We have reported rates of meaningful improvement in physical capacity, returning to daily activities, in some cases returning to work. We have opioid reduction. Average reduction in daily opioid consumption among patients is almost 40%. Increased quality of life, sleep, mood, social participation, overall well-being, as measured with specific validated instruments like SF36 or EQ5D. Before spinal cord stimulation, we have pain which is persistent, refractory, despite multimodal therapy. Patients have limited mobility and physical deconditioning, high opioid burden and diminishing returns, sleep disruption, anxiety, and social withdrawal. After spinal cord stimulation, more than 50% pain reduction in the majority of the patients, improved mobility and return to daily activities, significant reduction in opioid requirements, enhanced sleep quality and emotional well-being. We are speaking about an evidence-based efficacy. We have prospective clinical trials, we have cost-utility evidence, we have long-term durability of this therapy. There are some landmark RCTs, including the PROCESS study, evaluating these persistent spinal pain syndrome patients or FBSS patients. The ACCURATE study, it's about dorsal ganglion stimulation, CRPS. The SENSE RCT study, evaluating 10,000 Hz stimulation versus conventional spinal cord stimulation. And all of these clinical trials demonstrate consistent superiority of spinal cord stimulation over conventional medical management, with durable benefits maintained at 2 years follow-up and beyond. We also have multiple health economic analyses, which confirm that spinal cord stimulation achieves favorable ICERS, incremental cost-effectiveness ratios, well within accepted thresholds, and the upfront implant cost, which is indeed high, is typically offset within 2 to 3 years through reduced hospitalizations, fewer outpatient visits, and decreased medication expenditure. Long-term durability. We have registered data and long-term follow-up studies up to 10 years, which confirm that a substantial proportion of patients maintain clinically meaningful pain relief with stable or improving functional status, supporting spinal cord stimulation as a durable rather than transient intervention. We have some challenges. There are some possible complications with this therapy, and the patients and the colleagues should be aware of them. Implant site infections, reported rates 2 to 8%. We have superficial infections that may respond to antibiotics. We have also deep infections that often necessitate device explantation. These problems are mitigated by strict sterile technique, prophylactic antibiotics, and antibiotic impregnated implant components. Device malfunctions such as lead migration, fracture, connector failure can result in loss of stimulation efficacy. The paddle leads carry lower migration risk than the percutaneous ones, but require an open surgical placement. Battery depletion requires an IPG replacement, the battery replacement, under local anesthesia. Ongoing management. Spinal cord stimulation is like a marriage, is a lifelong therapy, requiring regular program reviews, device interrogation, and patient education on activity restrictions. For example, MRI compatibility, diathermy avoidance, and a multidisciplinary follow-up optimizes the long-term outcomes. The future of spinal cord stimulation will have a personalized pain management. We need precision in neuromodulation, and all these advances in neural sensing AI-driven programming and biomarker-guided patient selection are enabling truly individualized therapy. Future systems will certainly adapt dynamically to changes in pain state, activity level, and neural response without the intervention of clinicians. But we also have to understand pain deeper. We need a growing insight into pain neurophysiology, glial involvement, central sensitization, and all of these things are illuminating new therapeutic targets. Next generation spinal cord stimulation platforms may combine electrical stimulation with pharmacological delivery or transcriptomic feedback to address pain at its biological roots. We also have and we are developing miniaturized, rechargeable, and MRI-safe IPGs, along with wireless programming interfaces, which are making spinal cord stimulation more accessible, comfortable, and compatible with modern clinical workflow. Spinal cord stimulation represents one of the most powerful evidence-based tools available to pain medicine, offering patients with refractory chronic pain a realistic path to restore function and improve well-being. We have a proven efficacy with robust level 1 evidence across multiple indications. We have personalized therapy with waveforms, targets, closed-loop systems, and we have evolving innovation, a rapidly advancing technology landscape, promising even greater precision, safety, and patient-centered outcomes. That was all. Thank you very much for your time and your attention. Thank you very much for your invitation. Please feel free to reach out with any further questions, and this is my email address. Thank you very much.
So, sir. No, sir, it's recorded. So now I would like to invite Professor Chandra, and sir will be speaking on vagal nerve stimulation for pain. Sir.
So we have been running a very active epilepsy surgery program since 1996, operated over 5,000 cases. And neuromodulation forms one of the primary verticals for epilepsy surgery, particularly VNS. The reason VNS forms a nice vertical is it's very easy to do. It's an extracranial surgery. Surgery will be over in 45 minutes. But its advantage itself is a disadvantage, because then people can misuse it. So our program has been always very, very rigid, in the sense that we would perform neuromodulation only when all the options are absolutely excluded, including in those MRI negative pathologies where we still explore the possibility of doing stereo electroencephalography, and then we do. So we have done about 100 VNSs. So our threshold for doing neuromodulation is not very low, because we always explore the options of resective versus disconnective surgery. And now the disclaimer upfront is, I don't have any experience of using VNS for pain. So it's a kind of a forced presentation, because Deepak said that you should try to present something about the role of VNS. So I've gone through the literature. It's been helped by my fellow. I didn't have any time also for the past 1 or 2 days, but Aparajita, my fellow, has done a good job. She has combined some good slides. So upfront, you have to understand that doing VNS for epilepsy is like adding another drug. About 50% of the patients are going to have 50% improvement. And very rarely any patient is going to be seizure free. So, and that's one of the reason. And we have to also understand that the improvement of neuromodulation continues to happen over years. So which means the second year improvement will be better than first year, and so on. The third will be better than second. So we have to wait patiently. Now one of the caveats of VNS is that you have so many options while doing programming. So that is the reason programming is very, very essential. And you have more than 8,000 combinations. So that's the reason, if we do a VNS, there could be number of bottlenecks where you could fail the procedure. For instance, when you are putting it around the vagal nerve, if you strip it off, if you cauterize, the nerve is going to die. And you then put a wire around it, it's simply not going to stimulate it. So you have to very carefully preserve the sheath or the vagus nerve and then put it. Similarly, when you're doing your programming, if the neurologist is not clear about programming, you will end up a patient who doesn't have a good outcome. Now, I was looking at the timeline of utility of VNS. It has been in 2017, they have approved it for cluster headaches and chronic daily headaches. But this is an approval for non-invasive VNS, which means more like a cutaneous VNS or putting it on the neck. As far as I have seen in the study, I have not seen any studies where they have done an invasive VNS. I don't know if Girish or Milind have an experience of doing an invasive VNS for some kind of a chronic pain and all that. I'll be very interested to take their opinion, especially Girish's, to see what are the practice parameters in UK with regards to VNS. So the advantage of obviously vagal nerve is it's got the largest distribution, practically reaches to every organ in the body. So you have a potential outreach to every organ. So now the question is, if you stimulate this, is it going to have some effect on pain? Now this, I apologize for this busy slide, but this is fundamentally to show that we have a very rigid protocol for epilepsy surgery. And ultimately, you know, when we are not able to form a reasonable hypothesis of surgical failure, only then we do neuromodulation, which should be the case for every tertiary center. Otherwise, the threshold for misutilizing this is very, very low. You know, and I have seen VNSs being done for hippocampal sclerosis. So, some things are common for neuromodulation. So, if you do it, you have to understand that the onset will be slow. The improvement happens over a period of time. It continues to improve over a period of time. Don't expect any cure. So whenever you do VNS, there would be a significant reduction, but don't expect a cure. The placebo effect is quite significant because patient is paying a lot of money. There is a battery, he can feel the battery. He thinks it's like going to be like a pacemaker for cardiac. And of course, programming is very important. Now we don't exactly know how VNS works. I have gone through a lot of literature and I have seen that, you know, a lot of hypotheses, it's got an anti-inflammatory effect, it inhibits the mast cells, so many things have been written. But I think at this point it would be suffice for us to understand that the VNS has got a very nice outreach to a lot of, I think almost the entire body has a supply by the VNS. And it acts primarily via the limbic system. So because the effect of outreach is there, it also alleviates mood. So it's been approved for depression. So that's the way it could be done. So if you look at various types of VNSs which are available, you could have a trans-cervical VNS, or you could have a trans-auricular or a percutaneous VNS. So you have to put some acupuncture needles and then you could stimulate the nerve. So these are the non-invasive VNSs which are available. Now, the reason it came into effect for pain, why the people started thinking is, they found that when it was operated for patients with epilepsy, they had a significant improvement in the mood, and many patients of epilepsy also had chronic pain. So that also improved with VNS. So that's what started for them to think that whether it could be. It's of course approved for depression, and more recently they have used VNS for the right-sided failure, rheumatoid arthritis, sepsis, obesity. I think they mentioned everything except baldness. So I don't know if we can also include that. So over here, if you look this is a nice, it's a busy slide, but it's an important slide. So the black triangles are the FDA approved indications. So the traditional VNS is obviously approved for epilepsy, depression. It's also approved for stroke. But again, a number of it has also been done for general anxiety disorder, tinnitus, fibromyalgia, rheumatoid arthritis. The transcutaneous cervical VNS is approved for cluster headache and migraine, but it also been done, has been performed for COVID-related inflammation, stroke, atrial fibrillation, post-traumatic stress disorder, opioid use disorder, and even painful chronic pancreatitis, which could be very painful and it's a very long-standing condition. The transcutaneous auricular VNS has not been approved, FDA approved for any of these indications, but it's a non-invasive. It comes mostly, it's done by a Chinese company. You can put it in the ear and you can stimulate it. And it's been approved for conditions like fibromyalgia, tinnitus, stroke, irritable bowel syndrome, post-operative inflammatory response, newborn feeding rehabilitation, opioid use disorder, depression, Prader-Willi syndrome, rheumatoid arthritis, erosive hand osteoarthritis, idiopathic nephrotic syndrome. So they have included practically everything. Now for primary headache, there have been a number of studies, and I found maybe one study where it was significant, but otherwise most of the other studies have not shown so much of improvement. And if you see this study, which is an Act 1 study, over here, particularly the episodic chronic headache or daily chronic headache, there has been a much better response with VNS as compared to where it was not done. Similarly, in the Presto study again, they have shown that there has been some improvement, more improvement of NVS as compared to sham trials. So the current guidelines, it can be used for acute or prophylactic treatment of headaches, which could be migraine, cluster or daily chronic headache. But you have to fundamentally decide whether the headache is severe enough to merit a VNS, and again a non-invasive, and also medication overuse headache. The FDA approves it for acute treatment of again migraine, episodic cluster headaches, as well as for prevention of migraine and cluster headaches. Now if you look at the approval of VNS for fibromyalgia, again there have been some studies which I could pull out, which more or less have shown that there is not much of improvement. So again it's plus minus. It's also been used for backache, and surprisingly when I went through some studies, the p-value seems to be significant. So again it's very difficult to explain how backache could get relieved by VNS, but there you're opening a Pandora's box. But it remains to be seen. Maybe it works, I really don't know. So we'll have to look at it more carefully. So these are the current trials which are going on. So there are about 127 trials, and they're exploring it for various conditions, but mostly includes pain disorders and migraines. So again, I apologize for this busy slide, but the reason I have put here is that whenever you look at a study, most of the trials say that they are well tolerated. They don't mention about the efficacy. So we have to understand that the objective is not tolerance, because obviously it's not much. Even if you do an invasive VNS, it's a relatively simple procedure. So other off-label uses includes chronic widespread pain. So this we could have in some of the patients. Chronic visceral pain like chronic pancreatitis, irritable bowel syndrome. And in one study, which was an RCT, they have shown up to 64% of improvement with irritable bowel syndrome. Diabetic neuropathy, again, in some cases of intractable diabetes, we get those patients, whatever medicine you give doesn't work. I don't know if VNS will work there. Chronic musculoskeletal pain. Now in India, we have a huge population of these patients coming. In Victoria, when I was there with Girish, we used to call it as HPD syndrome. Hatha Pava Dard syndrome. Practically every patient starts walking, they're saying, what is your problem? Oh, I have a pain here, and we don't actually investigate these patients. So it seems to be seen that what could be the problem with these patients. So I'll conclude this short talk saying that VNS definitely is established for epilepsy, but the threshold I feel should be not so low, it should be high. It's also approved for depression, and it's also approved for some kind of maybe migraine headaches or chronic headaches, which could be associated with the depression. But again, we'll have to take it with a pinch of salt. So I'm not too much convinced about pain right now. I think we need some really good studies. So I don't know if you've heard of Freeman. Freeman was a psychiatrist who took upon the responsibility of himself to perform a leucotomy for every person on this planet. So he learned it from the neurosurgeon, and then he would go on this lobotomobile, and then he would go on treating everybody. He would pass this hammer, this chisel through the eyebrow, and then he would do a leucotomy. And this was one of the reasons why it was overused. There were a lot of complications, and the US Parliament was also on the verge of actually abolishing psychiatric surgeries. Fortunately, they did not, because of which psychiatric surgery is still there. So I could show you a small video because I believe most of you here are surgeons. So this was a patient where we had absolutely no localization, and we investigate all the cases quite a lot. We do magnetoencephalography, we do MELD imaging, we do ictal SPECT, PET, fusions, everything we do. So that's the incision. So first is to make a small pocket in the chest. Now it's a straightforward surgery, but remember, sometimes straightforward, now this is in the neck, I'm sorry. So exposing the internal jugular vein. So I prefer using sharp dissection with scissors. I will advise you against using any kind of cautery here. So it's very important to identify the vagus nerve. Often you can end up seeing an ANSA on the surface and you think that is a vagus nerve. So you have to dissect the IJV as well as the carotid, and then you have to go into the space between them and then identify the vagus nerve. Often a vagus nerve has got its own sheath, so it's present in a very much more deeper area. Now over here you can see this is ANSA. So there are possibilities, people could confuse ANSA with vagus nerve, and you have to be careful about it. So you have to open up both the IJV as well as the carotid artery, go into the depth, and that is where you'll find the vagus nerve. And when you find it, do not strip off the vagus nerve. It's very important, because if you strip, it could easily get devascularized, and then the VNS is not going to be effective anymore. So that's the vagus nerve which has been exposed. So you could find this video on the YouTube. It's there it's been published in Neurology India. So we pass a sling around it, expose the vagus nerve from top to bottom, and then the electrode is brought here. So you have an anchor lead, the positive and the negative. So wrapping, this is the most technical part of the surgery. So it has to be done carefully so that it doesn't get twisted in a wrong manner. And then you have to leave a lot of redundancy so that you don't strip it off. So you have to provide at least 2 strain relief loops. And then finally it's connected and you do. So it's a relatively straightforward, but you have to remember certain bottlenecks where it could go wrong. So I will stop here. So thank you very much. So maybe some comments by Girish and Milind on what you think is the current role of VNS. Girish, take the mic so that they can also hear. Mic दे दीजिए.
Yeah, even DBS for pain is no longer funded in England. So we stopped doing DBS for pain in 2013 itself. VNS, again, even for depression, you have to go through lots of hoops. So VNS for pain, certainly a no-go.
Okay.
I don't think there's a good evidence for that, and it won't be funded.
Milind, you want to add something?
I mean, I told you this, the brain behind VNS is Warren Grill. Warren Grill is this absolutely brilliant neurophysiologist, neurologist, and he's turning into Peter Janetta. So his first thing worked so well, epilepsy, that he started he said, why not depression? And depression, it did not work, and I don't know why FDA approved it. And there was actually it was said that the chair of the FDA was the author in that publication, so there's huge conflict of interest. After that, they tried to do it in different things, but it doesn't work as well as epilepsy in anything else, and that is always the thing. Procedure that you design for one thing works in that thing the best, and then just because you know how to do it, you try to apply it to different things, and it doesn't work. I mean, in his later days, Peter Janetta used to do microvascular decompression for diabetes. So those things are never going to work. I done ONS for fibromyalgia because ONS were approved in US for fibromyalgia. Help a little bit, not very much, but never a VNS for fibromyalgia. Okay, thank you.
Thank you, sir, for the presentation. At the end, I would like to again invite Dr. Bain to present motor cortex stimulation.
Okay, so hopefully you haven't got bored listening to me. So this is the talk which actually is a misnomer. It's not a motor cortex stimulation. We'll come to that, but it's called motor cortex stimulation. So we're going to talk about indications, techniques, outcomes, current evidence. So why motor cortex stimulation of pain? I mean, anyone who knows a little bit of basic neurology would think, why would you stimulate a motor cortex for pain? Motor cortex has no role to play in pain. And but what we are stimulating is not motor cortex. We're basically stimulating central sulcus. This should be called central sulcus stimulation than motor cortex stimulation. So central sulcus has this pils deep passage. These are the interconnectomes that are seen in every sulcus. And this pils deep passage in the central sulcus, now there is this concept of somatocognitive connectomes. So if you look at the somatocognitive connectome of the central sulcus, it goes from midbrain to forebrain, and most of the cognitive areas, cingulate gyrus, posterior midbrain, and dorsolateral prefrontal cortex, and also frontal forebrain bottom. So this somatocognitive connectome, which is exclusive to the central sulcus gray matter, is what we are stimulating. And again, so we are taking care of not the localized sensory component of the pain. We are taking care of affective component of the pain for motor cortex stimulation. What are the indications? Neuropathic pain, yes. Most of our indication, we done motor cortex stimulation in variety of conditions except for leg pain, because leg is on the medial side and we were not strong enough to put in lead on the medial aspect of the hemisphere, but otherwise we've done it for variety of things. Mostly deafferentation pain, because deafferentation pain needs an alternative pathway to be stimulated. The deafferentation pain is there because sensory pathway is damaged. And if you stimulate a damaged pathway, it's not going to result into anything. So for deafferentation pain, motor cortex stimulation is one of the good options. Neuropathic pain also, motor cortex stimulation helps. We've done it for facial neuropathic pain, atypical face pain, post-stroke central pain, thalamic pain, brachial plexus avulsion pain, phantom limb pain, post-herpetic neuralgias, pain coming out of Wallenberg syndrome. Now, lateral medullary syndrome giving pain is very, very rare, but we had a patient. So we did that. CRPS, multiple sclerosis pain, if the disease is not progressive, stable disease, then we can do that because they do need MRI scans all the time. Patient selection, intractable pain, that is the one thing. All other criteria for chronic pain intervention apply to this. Better if it is localized, because motor cortex has localized areas. And so if you are going to put a lead across the motor cortex, you cannot put more than 2 leads. So the area has to be really small. So if there is a hemi body pain, you probably would not do a motor cortex stimulation. So better if it is localized. Upper body pain is more responsive and of course technically easy. I have seen a patient where someone had slid the lead on the parasagittal side, but we never done it. Neuropsychological clearance is a must. Imaging to rule out any damage to the motor cortex or the central sulcus. And these are just various patient characteristics. Are there any preoperative predictors? Now with TMS coming into picture, a lot of people used to ask us, do you want to do TMS to see if there is any benefit? And yes, TMS is a good positive predictor. So with TMS, if the pain goes down, then with motor cortex stimulation, there is a good chance that you will get pain relief. But if TMS is not effective, that does not necessarily rule out that motor cortex stimulation will not help. Preoperative workup, we did stereotactic MRI scan, stereo CT, bold fMRI with DTI to localize the area of motor cortex. Anesthesia, local, general, mostly we did under general anesthesia. And they use the specialized anesthetics where you can actually stimulate the cortex and see the responses using remifentanil and Dexmed. So, intraoperative monitoring was SSEP, cortical grade, cortical stimulator. Procedure stages were implant of the lead. We did an externalized trial for 7 days, and if patient had benefit, we internalized the leads. If no benefit, opened up the craniotomy, took out the leads, and if there was good benefit, we internalized them, then we did the programming. There are various techniques of doing it. The Italian group, I think for Zani's group, use 2 burr holes. And then just slides a lead from one burr hole and pulls it out from another burr hole. Epidural. We always did epidural. Intradural, Jamie Henderson used to do intradural stimulation. Somehow we thought that was too invasive, and the motor thresholds go down significantly. The seizure threshold, we had to check the seizure threshold while stimulating. So what we basically did is we did craniotomy. We first localized the area, face area. According to the area, we did the craniotomy. So this was one of the, I think, this was a hand pain, hand deafferentation pain patient, and under general anesthesia. Linear incision, we had already marked her area of hand on the fMRI scan, and then marked it real time. And we used to do a craniotomy. Some people do it through the burr hole, as I showed you, but we used to do a craniotomy and then put a cortical grade. Now after putting the cortical grade, you got to look for phase reversal. Phase reversal is this N20, P20 diversion that you see, that will tell you where your central sulcus is. So this and this is the phase reversal. This and this is the phase reversal. This and this is the phase reversal. So you come to know that between the contact 4 and 5, between the contact 8 and 9 and between the contact 12 and 13 on that cortical grade is your central sulcus. So you mark those between those contacts. So you actually get a map of central sulcus. And at the same time, once you map your central sulcus, you also do individual stimulation through the cortical grade to find out which is your hand area if you want to put in hand area, which is your face area if you want to put it in the face area. And then we used to use the specify leads. Now those leads are not available anymore. Those were spinal cord stimulation lead, 4 contact paddle lead. Now those 4 contact paddle leads are gone. Medtronic has stopped producing them. I haven't done a motor cortex stimulation since they stopped producing them, but those leads were very nice. We will put 2 contacts on the motor side, 2 contacts on the sensory side. So 2 contacts anterior to the motor central sulcus, 2 contacts posterior to the central sulcus, and 2 specify leads side by side. So there used to be like that. So that was our area of hand, and central sulcus was probably somewhere here. So 2 contacts back, 2 contacts front. These are 2 contacts back, 2 contacts front. And then you bring the wires out from the craniotomy. This is how the x-rays look. You fix the craniotomy and the wires are attached to extension and the extensions are coming out. And then you keep the patient in hospital. You choose the contact which are across the central line. So you can choose the one most distal or the closer contact. A tighter stimulation is better because it goes deep in the central sulcus, but sometimes you can use a wider stimulation. So always bipolar, go from one to another. What we have found out that if your active contact is on the motor side and anodal contact is on the sensory side, you get better benefits. And the reason for that is probably the that plis deep passage, the interconnectome is more on the motor wall of the central sulcus. So you put the active cathode on the motor side and anode on the sensory side, and then you start stimulating. Before start stimulating, you have to look for seizure threshold. Too much stimulation will give seizures. So we used to put EMGs to look for seizure threshold. And we used to check the seizure threshold sitting up, lying down, standing up, because it changes, because brain changes, CSF changes. These are epidural stimulation. And then you go 2/3 of the seizure threshold. You can cycle the stim. Programming parameters are generally low frequency, medium pulse widths. You don't need more than 1.5. These are not perceptible. The patient doesn't perceive it. Bipolar stimulation with cathodes or motor cortex, anodes or sensory cortex. Cycling helps quite a bit. If there is more than 50% reduction, we'll do the stage 2. If not, we will not do it. Benefits and complications, we have series of about 45-50 patients, I think. We've seen one infection, but nothing major, and there are a lot of other patients also. What's the future? Maybe non-invasive, maybe better leads, maybe nanotechnology, optogenetics. Optogenetics is very useful. We've done dog studies in which what we did was the dogs with depression, we took out the bone in the dorsolateral prefrontal cortex and put a LED light inside the bone and put the bone back, and the depression score started improving. Do you know, everything inside our body is dark. There is no light inside our body. Light is all outside. There is no light inside the brain. So you just put light on the frontal cortex and the depression will get better. So something like that. Maybe I'm just talking about sci-fi. but something like that will come in future. Thank you.
Very interesting lecture, Milind. Any questions or comments, Girish?
Generally the enthusiasm for motor cortex stimulation seems to have died down. What's your view? Do you think, are you still a believer in it, or?
Anesthesia dolorosa. You've got no other thing you can do. Because anesthesia dolorosa, I used to do peripheral nerve stimulation. Anesthesia dolorosa, that also does not work. So, a focal deafferentation pain. Focal deafferentation pain doesn't respond very well, or post-stroke pain, doesn't respond very well to spinal cord stimulation. And these face pain patients with anesthesia dolorosa, I had a patient who had 23 surgeries, like 6 times microvascular decompression. His face was completely numb but severely in pain. Got away, completely got better, and it's now many, many years. Mark DiGiacomo, he's now won an election in New York last week. But yeah, in selected indications, I think motor cortex stimulation is still a very neat, a very brainy surgery. But there are a lot of other options for a lot of other things. So I will not do it for neuropathic pain. I'll just do it for focal deafferentation pain, either face or upper limb.
I think we have asked the question, but we keep forgetting in the hierarchy of the procedure. Where would you put motor cortex amongst the other procedures, like you said, spinal cord, peripheral nerve stimulation? You have a pain. Would you, because it appears a very elegant procedure, so would you try it up front or only after you have tried peripheral nerve stimulation, as you said, or you tried something else?
I'll put it on the side and not in the hierarchy at all.
Okay.
In the standard hierarchy, it doesn't come.
Okay.
So it just only for a selected indication, anesthesia dolorosa, or severe deafferentation pain which has not responded to cervical spinal cord stimulation. Apart from that, I would not really do a motor cortex stimulation.
So for the patients who have failed spinal cord stimulation, then we can go higher up?
We can, but yeah, the only beauty of motor cortex stimulation is it is targeting a different pathway.
Correct.
It's a completely different pathway.
But as we all understand, spinal cord stimulation is also acting on the brain.
It is also acting on the brain, but it's decoupling the somatosensory and limbic network. And this is just augmenting the affective network. So, yeah, I mean, you're right. In a sense, everything acts on the same pathway. But this exclusively acts on that pathway. In spinal cord stimulation, there is some role of gait, but neuromatrix theory, basically neuromatrix is neuromatrix. Gait control theory, I don't believe so much for chronic pain, because chronic pain cannot be so simple to close a gate. It has to be the whole brain. It's like dementia. So affective component, spinal cord stimulator also. But motor cortex stimulation, just like your trigeminal brace surgeries, not everyone should do it, and it's not needed for every patient. So motor cortex stimulation is like that.
Okay, thank you, Milind. So we can go to the next talk. Okay, we have come to the finish of the session. So we can go to the next session, which looks quite interesting.
Yeah, thank you, chairpersons, and we had a very good session. So claps for all the speakers and the chairpersons. So we'll move to the next session, which is So the next session is, we have termed it as Blazing Guns, Fight Fire with Fire. So I would like to invite the chairpersons, Professor Ida Strauss from Tel Aviv, Israel. We already know about his intro. And then I'd like to call upon Dr. Shantanu Bora. He is an associate professor in the Department of Neurosurgery is my colleague. Then would like to invite Dr. Mayank Garg, who's again associate professor additional professor, I'm sorry, at AIMS Jodhpur. He has been alumni of AIMS New Delhi, and then he is doing great work at Jodhpur. And lastly, Dr. Jitin Bajaj, again our epilepsy and functional neurosurgery fellow from AIMS New Delhi, and he is now at Netaji Subhash Chandra Bose Medical College, Jabalpur. So he is again doing great work in epilepsy and functional neurosurgery. So let's begin the session.
Interesting session, and not a very common topic. We had a short introduction in the morning, but it's a pleasure to introduce the first speaker, Dr. Girish Vajramani, which will give an overview on cordotomy, and I'm personally very curious to hear what he has to say.
Okay, thank you very much. So I'm going to talk an overview of cordotomy. I'm sure you're going to talk more in detail. So sorry, apologies if I steal the thunder. But yeah, I mean, cordotomy is, as told in the morning, that it's not a new procedure. It's been there for several decades, where you kind of destroy the spinothalamic tract to get pain control in patients with intractable malignancy pain. If you see the history, it was 1910 that Schuller did some animal experiments and demonstrated that you might get good pain relief with the spinothalamic tract lesioning. But it was Spiller, who was a neurologist, who convinced Edward Martin, who was a neurosurgeon, to do this cordotomy as an open procedure. So that was the first cordotomy done in 1912 as an open procedure. Then Sean Molan in 1963 developed a percutaneous procedure where he would implant radioactive strontium needles into the spinothalamic tract, and over a period of time it would destroy the spinothalamic tract to give good pain relief. But much of the modern cordotomy that we do, and there seems to be a resurgence of the technique. It was a dying art, but people seem to be taking this on more and more now. And we owe this to Rozumov in Canada, who did the radiofrequency thalamotomy. Yusuf Kanpolat in Turkey, he described the CT-guided thalamotomy in 1989, and that seems to be getting popular as well. So this is Rozumov describing the percutaneous radiofrequency thalamotomy. We know that pain and temperature go through the spinothalamic tract on the opposite side. It's present in the anterolateral part of the cord, ventral to the dentate ligament. So that's a very important landmark where the dentate ligament gets attached to the spinal cord. Of course, there may be some variation in individual patients, but general rule of thumb is that anything dorsal to dentate is your corticospinal tract, and ventral to that is the spinothalamic tract. And again, there is a somatotopic arrangement within the spinothalamic tract, with the sacral fibers most superficial and the thoracic and cervical quite deep down into the medial aspect of the cord. So this is mainly indicated for refractory unilateral somatic pain in patients whose life expectancy is less than generally 3 years, and where everything else has failed. So we go to the surgical technique. The gold standard is to do a C1, C2 puncture and insert your radiofrequency needle within the spinothalamic tract. You can have a fluoroscopic guidance or CT guidance, and it's done initially under sedation, but you have to wake the patient up to do on-table testing.
So this is a patient lying supine position, and one of the indication for this is patients should be able to lie flat and supine. Those patients who have a lot of respiratory distress, especially with the lung pleural effusions, etc., they won't be able to lie flat, and you might struggle to do this procedure. So the patient should be able to lie supine without any respiratory embarrassment there. It's done under sedation and local anesthetic. The landmark is generally about 5 millimeter below and posterior to the mastoid tip for a C1, C2 puncture. You need to do a good true lateral projection of the fluoroscopic image and do a C1, C2 puncture. Initially give some local anesthetic to the skin, and also when the needle has reached almost the dural level, you have to give a bit more local there, because dural puncture can be quite painful there. And then what I do is I inject once I do a C1, C2 puncture, take off some of the CSF, and then I mix CSF with lipiodol, which is a lipid-based contrast media. It's no longer used generally, but it's still available, and people are using it in the angiogram suite as well. So I use that, mix it with CSF, and mix it with a few air bubbles, and then make a mixture, and then I will inject that into the C1, C2 space. The idea is if you inject air, it will go to the ventral space, and that will delineate your ventral border of the spinal cord. The lipiodol then goes and sits on the dentate ligament, and it also goes into the posterior space as well. So this is the video of the lipiodol being injected. You can see that soon as I'm injecting, you can see so that's the dentate ligament line. The top one is the ventral surface of the cord, and you can see the contrast going into the posterior space as well. So that needle seems to be in good position. Again, another example, this is not a video. Yeah, this one, another example. You can see the ventral surface of the cord, the dentate ligament, and then the posterior subarachnoid space there. So this needle seems to be in the good position. You then insert the needle into the cord under continuous impedance monitoring, because when you're in CSF, the impedance is around 100 to 200 ohms, and as soon as you enter the cord, the impedance suddenly goes to anywhere between 200 to 400. People have described that it can go up to 1000 ohms as well. So generally about 500 ohms is what I would go for. You'll get a nice impedance recording once the needle enters the cord. Okay. Is this a laser here? Yeah. So this is the ventral surface of the cord there. You can't see the ventral dura because that'll be filled with air there. This is the dorsal surface. No, the patient is supine. So this is the anterior surface of the cord. This line is the dentate ligament, and this is the CSF in the posterior subarachnoid space. So same thing if you see the video. So as you're injecting, you'll see that both the ventral surface is some contrast, and the dentate ligament, this is the dentate ligament here. This line is the dentate ligament. So you'll have three lines: ventral surface of the cord, not the dura, then the dentate ligament, and the posterior subarachnoid space there. And then you do the on-table testing. By this time the patient is awake. So you do 2 Hz stimulation to make sure that you're not anywhere close to the corticospinal tract. You will get some ipsilateral trapezius contractions because you're close to the ventral nerve roots. That is acceptable as long as you don't get any spasms or twitching in the ipsilateral leg. Then you do the 100 Hz stimulation for sensory stimulation. The typical response is patients should get a nice warm, hot feeling contralateral to where you're doing. So the patient's got pain on this side, you do this cordotomy on the opposite side. So you should get nice warmth sensation there. That means you're right in the spinothalamic tract. This table tells you all the scenarios where, depending on what sort of stimulation, you may have to adjust the needle. You should always do an AP X-ray to make sure that you have not gone past the midline. You should always be on ipsilateral of the midline, of the side where you're doing. I won't go through in detail with this. And then you do your lesioning at 70 to 80 degrees. When you're doing that, you give a bit more sedation. Some people do in a staged manner. I do directly over 90 seconds. People have done 60 seconds as well. I do 2 lesion, but you can always wake them up and do testing with the pinprick, see where the patient is anesthetic in which areas. And if you're not satisfied, you can do another lesion again with more testing. So that's how I would do. You can't do bilateral C1, C2 cordotomy because of the high risk of sleep apnea or Ondine scares, where the patient, as soon as he sleeps, he is not able to breathe. That's why it's only done on one side. If you have to do both sides, then I do open thoracic cordotomy, or sometimes I've done unilateral percutaneous cordotomy, and then when the patient starts getting pain on the other side, I've done an open for the other side. So one of the side effects is complications of Ondine scares. Mirror pain you have to be aware of. Although there's no metastasis or no issues on the other side, sometimes when you do cordotomy for one side, the patient starts complaining of pain on the other side. It's called mirror pain, and I have seen that it happens. It's something to be aware of. Ataxia, bladder dysfunction, they can get low pressure headache from the loss of CSF there, so you have to keep them flat for a couple of days, drink plenty of Coke. So bilateral or unilateral open cordotomy, we always do it with intraop neurophysiology monitoring of corticospinal tract, mainly the MEP response as well as the D wave, which is the direct wave. So I will insert a electrode caudal to where I'm making lesion, stimulate the motor cortex, and then record it for D wave when you're making lesion. So where unilateral is contraindicator of patient that's got bilateral pain, you do that. I think I showed the pictures this morning. You do a T1 to T3 laminectomy, expose the dura, and then you cut open the dura, keep the arachnoid intact initially, and then I will locate your dentate ligament, and you have to cut the attachment of the dentate ligament to the dura, hold it with a microneedle holder, and then you twist, rotate the cord so that you can now you're ventral to the dentate ligament, and then insert a dental mirror so that you can see where is the anterior spinal artery, and also if possible locate the ventral nerve roots, and then sort of visualize where you're going to make a lesion. Before you do all this, you would have measured the diameter of the spinal cord, and so divided by 2, you should not have the needle more than that number. So if it's 8 millimeter cord, I would not go more than 4 millimeters, so 2 to 3 millimeters I would do. So you can use number 11 blade, put a bone wax, measure the blade so that it's 3 millimeter or 4 millimeter, whatever you want, and put a lot of bone wax so that you don't go too deep. And then you can make a PL incision and then push the needle, the knife inside, and using bipolar you can complete the lesion making. And you close it. So I think that's the overview on how we do unilateral and bilateral cordotomy, but I would be interested to see how he does it with this technique. Thank you.
Thank you. So I think we have time for some questions.
Yes. Dr. Green, very nice presentation. So first I'll start with the open cordotomy. So when you're making the incision, it starts from the dentate ligament up to the midline, or
yeah, I mean,
what is the length of the incision and the depth?
Yeah, if you've done 3 millimeters or 4 millimeter, you make a stab just ventral to the dentate ligament, and then you sweep like that, so that the whole anterolateral part of the cord is sort of, you made a...
so it is in horizontally, it is in one plane?
And then you have to do sweep as well, yeah.
So by sweep you mean a C-shaped kind of thing?
Exactly, yeah.
Okay. So
as you can see, when you rotated the cord,
yes,
you just make incision, and then you can, using bipolar, you can enlarge the lesion,
and it goes up to the midline.
You can go up to the midline, but you don't have to actually, unless you're doing cervical, this one, because the cervical fibers are close to the midline.
Yes.
So most patients have the, say, pelvic pain you're doing, you can be a bit superficial. For chest pain, you have to go slightly more deeper.
And so, would you do both sides simultaneously?
So we would do, yeah, simultaneously, but if I'm doing the right side at T1 at that level, and the opposite side I'll do at T3 level. That's why I do T1 to T3 laminectomy.
Okay.
So you shouldn't do both at
Both
the
at
same
the
level.
same
Yeah,
horizontal
it is
level.
staggered, yeah.
Staggered, and this is just for the crossing fibers.
Yeah, just so that, and otherwise the spinal cord becomes just literally hanging by a thread. Yeah.
Okay, okay.
So that's why you cut on this side and then few levels below you do it on the
And
other side.
because this time the patient is prone.
Yeah.
So he's under GA.
Yeah.
So we can't wake him up immediately to
No,
see.
you
So
can't.
only the D wave is your only
Exactly.
way of detecting if everything is fine or not.
Exactly, yeah, yeah.
And if, because we have seen that the D wave and everything keeps changing based on the sedation and so many other factors. So is that your also practice, or you?
But yeah, I mean sometimes you won't get good D-wave response. Same with MEP as well. You may not get good response depending on if the anesthesia is given a bit more relaxants. You
Yes.
can't get all. So all those factors are definitely there. But as long as you stick to the being ventral to the dentate ligament, you kind of know, yes, there is a possibility that they might get leg weakness from that, possibly temporary or transient. But that's a distinct possibility, but there's nothing you can do. You have to do it under GA. You can't wake them up to do testing, yeah.
So I assume these patients are kind of having cancer or terminal patients.
Yeah.
And this is the last resort for them.
Yeah.
And so how many of these procedures are you doing in your practice per year or per month?
Well, I mean, for the open cordotomy, we might get about, about 5 a year or so.
Okay.
Same, slightly larger number for the percutaneous. But yeah, as I say, it's slowly
increasing.
It's increasing now, yeah.
Very nice.
I think once you set up the service, people know that you're doing, the palliative team are the most important people to talk to. So now we have a cancer pain MDT where monthly we discuss all the cases and we discuss what is the best option, and we go from there actually.
And the durability of this pain relief?
I think it gives a good 1 to 3 years pain relief, but as I say, afterwards the patient will start getting dysesthetic pain, and that's why the prognosis for these patients has to be less than 2 to 3 years. And I will always discuss with the oncologist to make sure that the prognosis is not good if I'm doing this procedure.
Okay, thank you.
I mean, I would always prefer percutaneous because it's so good for the patient, quicker recovery and things like that. So I would prefer percutaneous if it's a unilateral one. Only if I can't do percutaneous for reasons like, he can't lie flat or he doesn't want, he wants it under GA, then I would consider open.
And what about, like you said, mesotheliomas are more common there, and then that's the reason you perform it. So they are usually unilateral. So, but then what about those cancer pains due to bony mets or some other reasons of cancer pains where this is indicated?
Yeah, so I do a lot of pelvic pain, say metastasis in the ilium bone or pelvis or invading the lumbosacral plexus. Those ones are good for unilateral as well. But if, I said, if they get other side pain, then they would always do the imaging to make sure there's no metastasis. Then if it's a mirror pain, we'll somehow manage that. But yeah, if needed, I can always do the open cordotomy on the other side. But we do for a lot of pelvic pain as well, cancer pain, yeah.
Sir, one question. Suppose for bilateral pains, why can't we do percutaneous through transforaminal, one at higher level and one at below?
You usually do C1, C2.
No, below. Suppose T1 and T3 transforaminals at different levels.
Suppose
you cannot do the approach. I'll show us a few pictures.
Yeah.
You cannot approach.
It will be difficult to. I don't know whether that's been described or not. But yeah, if you could do thoracic both sides percutaneously, that would be good. But I don't think there's a technique described that way.
So is it mandatory to do always at the C1, C2 level, or we can do in the subaxial spine also?
I mean, I think C1, C2 is the best approach because you got that C1, C2 puncture technique and the CSF is wide there, easy to get into the spinal cord there. So that's classical description there.
I mean, there are open, people have described actually, open like doing corpectomy, cutting the dura and then doing like a ventral open cordotomy as well. But again, nobody will do at this era. I think you just want to keep it safe and simple. C1C2 would be the best approach.
Thank you, sir.
Yeah, and he had a question, I think. He had a question, is it? No, you have one.
It's very nice work, sir, again. So I had a question that if a person has a mirror pain later on, it defeats the whole purpose, right? And it's very painful for the surgeon as well to see that.
Yeah.
So are there any ways to predict, and how often do you feel these mirror pain happen?
I mean, it's not that common. I have seen one definitely. Again, I don't know whether, because after the cordotomy, and if it's successful, which most of the time it is, the palliative team will reduce the tapioles very rapidly. Almost next day, 50% of the opioids are gone. So I sometimes wonder whether is it the rapid reduction of the opioids that has caused this mirror pain. I don't, because the oncologist will definitely say there's nothing to explain the pain on the other side. But yeah, if the pain is pretty bad, then at some stage you may have to go back and do open cordotomy for the other side. But generally I'll try to manage medically as far as possible.
Thank you.
Thank you, sir. Now I request my co-chair, Ido Stross, to talk on cingulotomy for cancer pain and candidate selection.
Okay, so thank you. Thank you for the invitation. So I think it's an interesting session, and I think it's going to be a complementary view approach to cancer pain, and yeah, I'm glad there's a whole session on cancer pain. So maybe, you know, we've been talking the whole morning about cancer pain, and maybe, you know, first of all, why do we need to do that? I'm not sure if we have an anesthesiologist or pain physician in the audience, but you know, there are so many medications and people try so much, but so why actually do we need to still use surgery? And the answer is, unfortunately, that medications are not enough. So if we look at the whole cancer patient population, most of them will suffer from pain at some point during the course of the disease, about 80% of them. And unfortunately, despite all the available treatments, about 50% of cancer pain is undertreated for various reasons. And even more disturbingly, or the patients that we want to approach are 10% of patients who suffer from what is called refractory or intractable pain. That means pain that is intractable. We saw in the morning the WHO ladder, so not just any pain that has, you know, tried and exhausted all the possible treatments, and they're still suffering from severe pain, like patients you see in these pictures. So Girish also already showed something similar to this. You know, usually our instinct when we see those patients, so this is like a typical patient, right? This is how they look when you see them in the oncology ward. They call you for a consult, and you see this patient, they're about to die, and your first instinct is to say, no, we cannot do anything, right? If you call an anesthetist to evaluate them preoperatively, they say, no way, we're not doing any anesthesia, they will not be extubated at the end. So if you even want to consider something invasive in those patients, it has to be, like Girish said in the morning, it has to fulfill certain criteria. It has to be quick. Those patients cannot lie down for a very long time. It has to be minimally invasive, so no big incisions, no CSF leaks, no wound issues, without general anesthesia, and it should produce immediate pain relief. So the patient goes into the operating room with pain and comes out without pain, and the next morning they can be discharged or sent back to the oncology ward for further treatment. You do not want to get stuck in your department with those patients with complications. Right? The idea is not to get them complicated, but so they can move on. So what can we do? So as neurosurgeons, we are privileged. We can intervene anywhere along the pain pathways, and that's been described in the morning, so I'm not going to repeat that, but we can intervene practically anywhere along the pain pathway. We don't have to stop at the door. But what what should we do, right? So a lot of treatment have been described today, right? So we can basically divide our treatment into two main categories, right? There's the there's the old neuroablation, the RF techniques, and that's been used for many decades now. And in the past 2 decades, the pendulum has shifted towards neuromodulation, and we've heard about motor cortex stimulation, spinal cord stimulation, intrathecal pumps, and so on. And those techniques are very, very useful, and they are reversible. So they're neuromodulation and don't cause any permanent damage, but they require a relatively bigger surgery. So you need to do a big incision. They are very labor intensive. You have to program the stimulator. You have to refill the pumps. It's more of a surgery. And I want to argue that for cancer patients, specific for terminally ill cancer patients, neuroablation with radiofrequency, a small minimally invasive technique, is preferable. So we've heard, so we can intervene anywhere along the pain pathway. So how do we choose where to intervene for a specific patient? And I find it useful when I see a patient in the clinic to broadly categorize them into two categories. Either they have focal regional pain somewhere along, at least unilateral pain on one side of the body, or they have diffuse pain. It makes the distinction between bilateral pain and diffuse pain. Yeah, it's always a debate, like, well, what does the patient have? But broadly speaking, if the patient has focal pain or regional pain, I'll keep it simple, then the best way to help them is to disconnect the spinothalamic tract somewhere along the way. And that will, it's a binary result, right? It's either on or off, it's 0 or 1. If you disconnect the pain pathway, it's like cutting the cable from the electricity cable from the switch to the light bulb, right? If you cut it, then the light is off. The brain doesn't receive the signal. So then it depends on the distribution of pain. If the pain is low, below the cervical level, you can do a percutaneous cordotomy. If the pain involves the head and neck, then doing a percutaneous cordotomy at C1, C2 will obviously not help that pain, and then you have to go a little bit higher, and I'll describe that. And for visceral pain, there's a specific pain pathway that I'm not going to go into. It's a visceral pain pathway in the dorsal columns. You can do a medial myeloctomy. For diffuse pain, and I completely agree, for patients who have this bony metastasis with diffuse, ill-defined pain, usually I would go for a singulotomy, and I'll give a few examples. So, okay, what would you do? What would you offer this patient? This is a 42-year-old man with a metastatic sarcoma, right? He's lying now on his right side. This is his left hip. He underwent multiple lines of chemotherapy, had orthopedic intervention, got complicated with necrosis, infection, and so on, and now he's left with this open necrotic wound. I think it's obvious to anyone in the room, right? No matter how many opioids you give him, it's not going to help. He needs something different, extreme. Or this lady with a metastatic melanoma invading the chest wall. And I could keep on and on going. There are many examples, unfortunately. So if we look at those two examples, they both have pain below C5. So they have pain below the shoulder level. So according to this flow chart, the best treatment for them would be to do a cordotomy. And cordotomy has been described already this morning, but you know, when I first started doing cordotomy, when I first proposed it to my oncology colleagues, they said cordotomy, it's like, it sounds scary, right? Are you crazy? What, are you going to cut the spinal cord? So it's actually, maybe it's better called selective cordotomy, right? So it's a tractotomy. We are disconnecting the spinothalamic tract. And so it's been said it's best for patients with unilateral pain, and you can do it either open or percutaneously. And if we want, so it was asked before, why do we go between C1 and C2? So if you look at this diagram, right, so this is the anterior spinal artery. In blue, it's the spinothalamic tract. This is the corticospinal tract and the dorsal columns. So we want to approach somehow the sensory spinothalamic tract without injuring all those critical structures. So one way is, like Dr. Girish said before, to do it in open way and to rotate the spinal cord, but that's a relatively big surgery, so you have to do a skin incision, laminectomy for patients who are malnourished, they have wound issues you want to avoid. So why do we go to the C1, C2 space that was answered? This is the answer. If you look at the lateral X-ray, you cannot go in between C3, C2, C3, so you just cannot come through, right? So the thoracic cord, you have to go through the thorax and the lungs, that's in the way, and below C2, the cervical vertebrae are like roof tiles, one on top of the other, and the only place you can place a needle safely is between C1 and C2, between the atlas and the axis. So because this allows us, half of our rotation, so there's enough space there between a half a centimeter and a centimeter, and this is our surgical tool. So a spinal needle, a 20 gauge spinal needle, and we insert this electrode through it. So this is how it looks. So there are two techniques to do it, and that's why I said it's complementary. The two talks. One way is to do it with the C-arm, which I think is technically more demanding, so it's much more difficult to see the spinal cord. The other one is using a CT or an O-arm. I use the O-arm because I have access to it in the operating room. CT, I don't get access to the radiology department. So this is where the needle ends here, and this is just the electrode continuing on, and this is the exposed tip. So the diameter is 0.3 millimeter. So 300 microns, and the exposed tip is 2 millimeter long. And what you see here, right, so this is the C1 level, you see the dents, and this is the spinal canal. We injected contrast, so the CSF is white, the spinal cord is here, it's this dark structure. You see the needle ending here, and this is the electrode coming to the anterior, the ventrolateral part of the spinal cord. And once we are there, we use mapping like was described, both motor and sensory. So this is how I set up the room, right? So the patient is lying supine. I don't use, I saw you said you're using a 3-pin hand holder. I was using it in the beginning, and I found you can just tape. So I tape the head to the bed so the patient doesn't move, and he's awake here, right? So. Okay. No. So you see he has a nasal canal, so he's awake, and like Dr. Giri said, the approach is 1 centimeter below the mastoid process. And this is, I hope the video runs. So this is how it looks, right? So you do, it's just doing a cervical puncture. It's like doing an LP, but in the cervical spinal cord. So you go in, and I fluoro on the way, right? So it's not shown here, but I go in and I make sure on the fluoro that I'm approaching the right height, obviously. Once we are there, you just see CSF coming out, like here. And then once we are there, this is what you see without contrast. So you can't really see anything with the O-arm. It's not a CT. With the O-arm, you cannot see anything, so you have to use a contrast. So you can either inject the contrast when the needle is inside, and then you get this nice demarcation of the spinal cord. What I do now, I actually inject the contrast before we start. So I do a lumbar puncture. We inject 10 cc's of water-soluble contrast. I put the patient with the head down for 20 minutes, half an hour, let the contrast mix, and then you can use it from the beginning. And again, this was already described, but I just showed the video. The resolution on the screen is better, but we look here at the impedance. So the impedance in the beginning, maybe on the screen you can see it better. It's about 100 or 200 ohms in CSF, and once you touch the spinal cord, it goes to 400-500. When you're inside, it's usually 600-700 ohms, so above 500. It should be when you're inside the spinal cord itself, and then we use the. So this is what we want to see, and then we use the mapping, and I show a short video that was already described, sensory and motor testing. We do, so it takes time to build the practice. In the beginning, the first patient, then the second one was 6 months later, and then 3 months later, and so on. Now I guess we do about 2 a month, so we've done more than 120 by now. This is from a few months ago, so 120 procedures, about equally between men and women. And this is how we do again, just to illustrate what we do with the mapping. So what you see here, right? So this is I combined my 3 talks together, so we have 45 minutes. Okay. So if we look here at the spinal cord, this is the midline of the spinal cord. This is the ventrolateral. If we go down to the diagram, then this is the dentate ligament. We want to be anterior ventral to the dentate ligament, and the electrode goes into the spinothalamic tract. And what we do when we stimulate, we want to make sure, just for the illustration purposes, that we activate this part of the spinothalamic tract, and we want to get the sensory, the sensation at the very low threshold, so below 0.2 volts. And then we want to make sure that we are far enough, so we don't want to cause any damage to the motor tract. The motor, this is the corticospinal tract here. So we stimulate at a low frequency, and we want to make sure that we are far enough. Obviously, if we use a very high intensity, we'll activate it at some point. So I use a 0.6 volt as a threshold, which is, I think, pushing it to the lower limit. I started with 1 volt, then 0.8, and now I dare go even as low as 0.6. So this is how it looks. The patient is lying supine. Dr. Zegerman, that's my regular anesthetist. He's slowly, and again, the resolution is good, but I think on the screen you can see it slowly goes up with the amplitude of the stimulation until the patient, there's no volume, but at some point he'll say, when he feels it in his leg. So he has pain in his right leg, and at some point he'll jump up because he went up too quickly, he feels the pain, and then we slowly go up and we find the threshold. Once we are there, we know that we have the right position. We want to make sure that we are not causing any damage. So we use the 2 hertz stimulation. And you see here that we went up to 0.9, there was nothing. Only at 1 volt, he started getting the motor control, which means that we are far enough. We are at the safe distance from the corticospinal tract, and we can do this. And you can see here on the sign in these illustrations, at one point, so here, in this case, we were too close. We were in the middle of the spinal cord, and we got the motor contractions already at 0.5, I think here it's 0.5 volts. So this is too low, it's too close. When we readjusted and moved the needle more anteriorly, now the stimulation, now the activation is only at 1 volt. So 1 volt is safe enough, and you can do the ablation. And this is how an MRI, a post-operative MRI, looks 1 day after the procedure. You see the T2 changes here that are localized to the ventrolateral part of the spinal cord with a little bit of edema going to the side. Again, it doesn't, so when you start, you have to be prepared. It does not always doesn't always go to the right place in the right and on the first try. So in this case, this was the first attempt. You see the needle is here in the posterior and the dorsal columns. So when we stimulated, we activated the dorsal columns, we got ipsilateral sensation. Then we had to move the needle, and in this case, now it's in the middle of the cord. Now we got contralateral sensation because of the corticospinal tract, but a low threshold motor activation. And only when we were here, this was the final position. And another point to notice, and I think this is maybe one of the reasons it's easier with a CT or an arm, is that the spinal cord moves all the time. So if you look here, right, so here it was pushed ventrally, now it's pushed to the side, and you see, so the position changes. You cannot get that with the C-arm, so you have to know and be prepared with the C-arm. It's more challenging. Again, another example, the spinal cord is pushed to the back part of the spinal canal. So you cannot really see that without contrast. Again, a few examples of how an MRI looks. In this case, I think we did a too big ablation, and it crossed to the other side. So like limit the ablation size. One of the works we published, we showed that you don't need to have a big ablation. So even if the ablation is 10% of the spinal cord, if you're exact in the correct position, then it's enough to take the pain away. One important point is regarding risks. So when you go between C1 and C2, you usually the vertebral artery goes above C1, but I think there are like 1 or 2% of the population have like an aberrant vertebral artery that loops down below C1. So at some point, I don't know, I read this article and we started doing routine CT angiography, and I had 2 cases. This is from the literature, but this is one of my patients that we saw this loop and we abort. So I do that the day before the procedure and we canceled the case. So yeah, try to get a CT angio before the procedure. Those are our results. So again, in over 100 patients, usually you get a very good immediate pain relief in about 95% of the cases. And this is one of the cases. This is the oldest patient we've treated, an 88-year-old woman. This is one day after the procedure. So it's a minimally invasive, usually well-tolerated procedure. She was bedridden for 3 weeks before the procedure. And this is, again, another patient with a family. So we give them, the satisfaction of spending the last few weeks of life without pain. And that was also asked before, so what is the duration of pain? Because we know we do the ablation and the pain might come back. So what we see in the Kaplan-Meier, on the left side, that's the survival, right? So most patients die within 3-4 months. And this is the failure of the pain. So in most patients, all those lines are the ones that were censored. So in most cases, the pain doesn't have time to come back. So most patients die before the pain returns. We don't have a long follow-up. The median survival in our series was 3 months. So we get the referrals very late. Complications. So when you do more procedures, you'll encounter also some complications. About 20% complication rate. Most of them are mild and transient and go away, and some headaches and some maybe attacks and so on. We had 3 patients that had severe complications, so about 2.5 or 3% of patients had hemiparesis, one even with hemiplegia. And maybe the most, so this was the case of the hemiplegia, and this is why I started injecting the contrast before I do the procedure. So this was the initial approach. The needle was here. The patient was very painful, had a very hard time lying right. So this was the initial approach. I injected some contrast. We did not see well enough, so I decided to inject some more. And during the injection, it jumped, and this is what happened. So you see the contrast here, it's intramedullary. It went into the spinal cord itself. And this is how it looked on a post-op CT, right? So you see the contrast inside the spinal cord. He was left with hemiplegia and also severe myopia on the other side, so very, very unfortunate case. Luckily, it was case number 10. So by then, like the oncologist already trusted me, and they kept on referring patients. So as long as you keep your complications rate low and have a good communication, it will work. So at least in my experience, so most patients don't report the mirror pain. When you ask them specifically, when you ask for that, you find the mirror pain. This is the most troubling side effect, mirror pain, in about 1/3 of patients. In most of them, it's mild, and they don't even report if you don't ask them. And 5% or so, 5 to 10%, they have severe mirror pain. small aminotomy and just like and just crush or cut the both bilaterally, both parts of on the two sides of the midline raphe. You just crush it with the forceps, and it helps. Again, it's like it's a bit of a bigger surgery under GA, so that's why I don't know. We don't use it, and I prefer singulotomy, but that's a viable option for cancer pain. And also today, I think our pain clinic is doing much more celiac blocks and other blocks that now I get the patients very late, and then it's too late to do that. Yeah.
So in cordotomy, do you take real-time feedback from the patient to confirm the need?
Yeah. So after we've done this, I usually use like a pinprick just to make sure that the area around that region is numb to pain cessation.
In your practice, you already know how many of the cordotomies you have done, but for the mesencephalic tractomies as well as the stylotomies, how many of the numbers are there?
So I think mesencephalotomies we've done 5, and the reason for that is the referral patterns from the oncologist, from the pain clinic, from the palliative care. It's I think mesencephalotomy is a great procedure for the oncologist. For the palliative care, it's easier to refer for percutaneous cervical procedure, which is perceived as less invasive, less dangerous. Although I think doing a cordotomy C1, C2, it's not less dangerous than doing because I do many more DBS. So the approach is, but it's a psychological issue with the referring doctors, and not my preference. I don't get so many head and neck referrals. I'm working on it.
And one more on the slide, singulotomy you showed that over time there is improvement. So at 1 year it is better than 6 months.
Now, so that I showed something from the literature. It's not better at 6 months. You have to look at the end. So the number declines. So from the patients who survived, there were a bit more there, but patients are lost to follow up. And in my personal series, so the median survival was 4 months. So I don't have 1 year follow up on singulotomies. We've done, I think, more than 30 cases, but most of them die within less than 6 months, usually 3 months or so.
I feel that because we do a lot of gamma knife, I think we can do radiosurgical singulotomy as well as mesencephalotomy.
Yes, you probably could. You could. The question is the time to the effect. So with singulotomy, with RF singulotomy, the advantages, at the end I do a very small incision and I do small barrel. The effect is immediate. With gamma knife, I guess the effect would be, after a few weeks, a month, and by that time the patient could be dead. For mesencephalotomies, there is a series now by you'd have to give a very high dose of energy to a very small target in the brainstem, and you don't have any real-time feedback for gamma knife. So you might end up with radiation necrosis in the mesencephalon without. So I would be a bit hesitant about using gamma knife for mesencephalotomy. There's a trial now going on by Jeff Elias in Virginia for doing HIFU, for doing FUS mesencephalotomies. I think they have some promising results.
But in those terminal patients we are talking, so we are not bothered about the radiation necrosis down the line.
Yes.
And it's it doesn't require sedation and anything like that. That's one of the bigger advantages in our center, because anesthetist time is also valuable. We don't get that time on table.
Yeah, it's a question. I don't know. I've not done it, but then, like you say, they might not develop radiation necrosis, but maybe the effect will be too late for them. So
yeah, that's one thing we need to find out.
Sir, just one more thing. In cordotomy patients, do they have issues with temperature?
sensing
Yes,
cold.
yes, that's one of the, sometimes you get a call. We always tell them, be prepared, but, you have to hold a cup of tea or coffee in the other hand, don't you, because you will get bad. Sometimes I get calls, like after a day, they get home, they take a shower and they call us, I don't feel, the hot water on one side of the body. Yes, that's the sign that it works. That's what we wanted to do, but, you have to prepare patients for that. Yes, definitely. It's pain and temperature together. It's a side effect, but it's something that what we want. Yes.
Where do you place intrathecal pumps in your treatment algorithm?
I don't. So I've done a few. We don't have the support team to take care of the intrathecal pumps. So I've done 2 intrathecal pumps. So we do them for spasticity, and I have a team to treat. To do the baclofen refills, and we do pumps for spasticity. For pain, I think I've done 2 pumps for that, and then the question is who takes care on and the pain clinic. So I decided I'm not doing that. But theoretically, for patients with more than 6 months to live, with like 1 year or more of prognosis, I think intrathecal pumps are great. You just need to have it's a financial issue. So takes you need staff.
One very fundamental question that so once the pain is fine, patient is very happy on the day 1. Then after a few days they forget about the pain because it is not that bothering now, and then the trade-off of that numbness and lack of temperature sensation that comes in, right?
Yeah.
So do you feel in your practice that they start becoming unhappy about that anesthesia? Is it the case, or are they still happy in general?
They're happy in general for the pain. You have to be realistic in your expectations. Those patients are in a bad condition. They don't. Most of them are so late. They don't. That it's almost too late for them to take advantage of the improvement in pain. They are still weak. They're sick. So they go. They go home. They suffer less. They're happy. The family tells us they're happy. But it's like we try to get the referrals a bit earlier. What we do see, we saw a few times, is sometimes that the pain is away, and suddenly the patient get depressed, because until then they were so bothered with the pain, they were not really coping with the disease and really realizing they're going to die. And suddenly, when the pain is gone, they come back for after a few days or a week for follow-up. And they are depressed, and now the truth is something that they are going to die within a couple of months. My palliative people tell me that's good, because now they can start to do the real work with them and prepare them and the family, to say goodbye. So the palliative care. So that's why you have to do that in a multidisciplinary setting. You have to have someone who is ready to take care of the patient and do the work after the pain is gone.
Right, and for a patient with a unilateral pain who would be eligible for cordotomy, but having life expectancy of say 2 to 3 years, then would you prefer singulotomy over?
No, I would not offer them any destructive procedure. I would go for pump or for a stimulator.
Okay.
Spinal cord stimulator or an intrathecal pump. I'm just referring to a different center. So there's another hospital that does pumps.
Right. So do you have any experience in singulotomies in such pains? No. Okay.
No. One. I've done one case of a patient with CRPS, and it's a different story. And the pain was gone. It was great. He was drinking Oxycod out of like 4 or 5 bottles of Oxycod a day. Like he was just going and drinking out of the bottle Oxycod. Again, the immediate effect was great. We was able to win him that's also very interesting. There's no withdrawal side effects when you cut down. It's very fast, but after 4 or 5 months, the pain was back to baseline. It was back. So I don't do that for chronic pain. I do that only for cancer pain.
Yeah. Thank you.
Thank you.
I think we have to go on with your time, right? With the next lecture.
Yeah. Thank you, Professor Strauss. Yeah. So because of lack of time, we now proceed to Dr. Ramesh's lecture on resolution for defibrillation pain. We can continue the discussion in the lunch period.
So, very good afternoon. We are already running late. So, I'll finish it as fast as possible so we can all have lunch. So this talk is basically again the lesioning part, and then most of the talks have been taken care of, including all the neurosurgical procedures. This is one of the procedures which we do at our institution. This is dorsal root entry zone lesioning for brachial neuralgia. So this will be the progression. Like, I'll introduce first what is DRES, and then the anatomy, and then the indications and our own experience with the video. So as you can see here, that dorsal root entry zone is the area where it lies posterior lateral to the, it's a posterolateral sulcus. Basically, it lies lateral to your entry of the roots on bilaterally. So it has bilateral posterolateral sulcus. It includes these rootlets, dorsal rootlets, and something known as the tract of Lissor, where this is a white fiber bundle where all these fibers enter into the dorsal horn. So that forms a tract of Lissor. And your dorsal horn laminae, that is rex laminae, we have studied in our MBBS days that we have 10 laminae inside the thing. So the pain producing laminae are the dorsal rex lamina 2 and 5. So these are pain producing lamina. So including all these components, this is the part where we perform the lesion for the pain. So this is, so if you see this figure, yeah, oh, it won't stop. So you see here that when the dorsal root, if you take a cut section of the dorsal root, the far away from the entry point into the spinal cord, these are arranged randomly. Yeah. So we have from our physiology days that we know the fibers, the signal carrying fibers are divided into A, alpha, beta, delta, and C fibers. So A, delta, and C fibers are basically the pain producing fibers. They are small fibers, and the large fibers are the they carry the proprioception and other senses. So as you come closer to the point of entry into the spinal cord, that's a dorsal horn, these start rearranging themselves, and then you can see the larger fibers go more medial, and these are towards the lateral. And as you come here, these fibers get into more, the tract of Lissor is arranged in such a way that these fibers are, they rearrange themselves. So that is the reason that our, the tract of Lissor, that is a part of the tract of Lissor, and then the part which is just lateral to the root entry is the one we cut it and spare the large fiber part. So mechanisms have been described variously. So the rex lamina, which is the lamina 2 and then the lamina 5, they have, Denny Brown described that these in the animal studies that there is a state of tonic discharge. These cells are involved in the pain production. So now the latest concepts in the morning, Dr. Renu Bhatia described about the wide dynamic range neurons which are present in these region, which are responsible for this neuropathic pain. And there are various peripheral as well as central mechanisms like spinal and supraspinal mechanisms which are actually due to post deafferentation, these changes happen and then the pain starts coming up. Now it's basically a deafferentation pain following brachial plexus avulsion injuries. So most of our patients who come to the trauma center here, they do have this avulsion injuries due to stretch probably or high vehicle motor accidents. And it is well visible on the MRI that these patients have the pseudomeningocele. So this is basically a preganglionic injury which is a prerequisite, and then these patients do have this deafferentation pain. Approximately post injury 70% of them have pain which are managed with medications, of which around 30% develop this refractory pain. And they don't have a cure, and it's kind of suicidal pain. These patients have the tendency, I think Dr. Deepak's first patient was almost, he had committed suicide, and then somebody saved him. Then we had to, when we performed the surgery, now I think he was in the police department, so he's now happy. So predictors of outcome like intermittent, the sharp stabbing ones, segmental pain, preganglion root avulsions, and complete BPI. These are the patients who have better, they respond better to the pain following dorsotomy versus the other types. And in the literature, they say lumbar has better than cervical and then thoracic. So there are mainly for the intractable brachial plexus avulsion injuries. This is one of the best indications, like the other indications being the sacral plexus avulsion and then craniofacial pain. Dr. Girish in the morning had talked about the nucleus caudalis lesioning, where it's similar to the dorsotomy, and post-operative neuralgia. Even dorsotomy is done for spasticity, so where it takes care of phantom limb pain. So various indications. Sorry. So there have been various techniques described. The first one was by Marc Sindau, he from France, and it was his med school thesis, and it was the first, he was the first to actually describe the mechanism as well as describe the technique of performing this microsurgical dorsotomy. And then came the technique by Nashhold, which was RF lesioning, which was again published, and then various other modalities came in, like laser and then ultrasonic. And lately we published this technique of not using any lesioning equipments, rather we try to use a mechanical disruption, where we just use a micro scissor and then we just cut into the dorsal horn region. So basically this is because the other modalities use some form of energy, like the Sindau's technique used the bipolar coagulation, where the heat used to, probably it led to more complications because the microvasculature actually dips inside the sulcus, and then the heat actually causes the microvasculature to get damaged. And similarly the RF, again it's a lesioning, laser and ultrasonic. So in our technique we generally use just the micro scissors, very fine micro scissors, and then do a mechanical disruption. So this was a classical technique of Sindau, where it was the posterolateral sulcus is sulcomyelotomy is done, opened up, and then you do the lesioning using a fine tipped micro bipolar at 1 mm intervals, and the entry angle will be somewhere around 40-45 degrees, so that you actually go in between the fascicles, like the dorsal fasciculus, you have the gracile and cuneatus, and then laterally you have the spinothalamic tract. So you have to enter in between them. If there is a change in your or orientation, then you might end up damaging one of the structures, either the dorsal columns or the spinothalamic tract, leading to complications. So again, the Nashhold's technique is basically, the technique is the same, but then they use RF probes at 1 mm intervals and then they burn. So the depth of the lesioning should be around 3 mm. That is what takes you to the Rex lamina 2 region, where the pain producing neurons are present. Various modifications have been done. This was from Japan. They had only 10 cases where they have gone more deeper, like to the lamina 5, and then they have done the lesioning, and they found excellent result in 100% of patients, but again it's just 10 patients. So coming to our technique, this is we have described and it's already published. The video is also available on Neurology India website. You can go through. So it's a unilateral laminotomy, and then we use the micro scissors and then do the disruption. So I'll be showing you the video briefly. So this is the figure which I have made for explanation. So you can see here the scissors go in the dorsal horn at around 45 degrees, and then the lesioning takes, the lesioning started just lateral to the entry of the rootlets into the dorsal horn. So this posterolateral part, you lift up the root and then you go along it. But in avulsion injuries, obviously the roots are avulsed, and then there is a region where there are no roots. So you'll have to identify the normal root above and below, and then you go draw a straight line and then go in through that sulcus so as to get the procedure done. So generally we mark the tip of the scissors at around 2 mm so that we enter our area, like Dr. Girish was showing about the bone wax. He puts a bone wax and then the rest of the tip cuts it. So we usually mark with a kind of permanent marker and then do it. So these are the intraoperative figures. I'll come to the video, which is at last. So this is our experience. We had around 56 patients, of which 9 patients had lost to follow-up. Majority of them were road traffic accidents, and the root avulsions was found in C5 to D1 on MRI in majority of the cases, and then we had the follow-up is around 5 years follow-up approximately. So we had, following this procedure, excellent results in approximately 80% of patients. The excellent outcomes were 75%, and if you combine the, like we did the numeric rating scale, where more than 75% was included as excellent, and good outcome was between somewhere 50 to 75%. So more than 50% reduction was seen in 80% of our patients following this surgery, as you can see here. And 4 of them had recurrence of pain in the long run, and then 2 of them were reoperated, although reoperations are very difficult. So, but still we could have 50% good outcome in the operated patient. 2 patients did not have significant relief. They still continue to have the pain. Complication wise, you can have motor weakness because you have corticospinal tract in the vicinity, and then you can also have dysesthesias, paresthesias because of this involvement of the dorsal columns and the sensory part. Urinary incontinence can happen. We haven't seen any. CSF leak, of course, is one of the complications. So if you see this table here, most of the complications which used to happen in the past, basically you can see that motor is 50% and sensory is 75% in the initial Nashville series, sorry. And similarly, the complication rates were higher. But then in our technique, since we are not using any energy based lesioning, we are just using the mechanical disruption. So that is probably one of the reasons that we have had some good outcomes. And this I discussed in the meeting with even Professor Sindhu. I had met him at WFNS. So he was actually, we talked about this, and then he shifted himself to doing a mechanical disruption since lately. So he was very happy about that, and then he was actually wanting to see the paper. So this is the various techniques which have been used with radio frequency, laser, and so ours is the 3rd largest series published in the literature, I can say, and then we have equally good results without using any fancy equipments here, which is cost effective also, and then it can be used with a basic neurosurgical setting, even in a peripheral hospital. Obviously the expectations are like pain relief, quality of life improves in these patients. They have a better sleep quality because it's a suicidal pain and they don't sleep and they have this pain, horrible pain. So, and they call it a suicidal pain also. And complications I already talked about. So these are other procedures which are alternatives, like selective rhizotomies are there, and then dorsal column stimulation. Spinal cord stimulation has already been talked about. The cordotomy, I'm not sure, Dr. Ido might be able to tell about it. Cingulotomy, yes, and this is the video. I'll end with this. So it's a 55-year-old gentleman. He had a right upper limb brachial plexus avulsion. He had complete grade 0/5 on the right upper limb, complete loss of sensation. It was a pan-brachial plexus injury, but he presented with severe onset pain. On MRI, you can see there is pseudomeningoceles. That is evidence that there's a root avulsion. So we do it in prone. We do a hemilaminectomy because it's on the right side. So we do a right-sided. We did a right-sided hemilaminectomy in this case. You can see here. We open it in the midline, but then we strip off the muscle on one side so that it's good for doing a hemilaminectomy. So this is the hemilaminectomy which is completed. Now you open the dura in the paramedian area. So now you can see there is no root seen here. There is normal root up and one below. So this zone has no roots because it's completely like owl's roots, and then they have undergone degeneration. That is the area where we have to go. And you start by going from one root, couple of roots above, normal roots, because when the pain fibers go across the opposite side in the spine thyroid tract, they go up 2 levels and then go. So that is the reason you go 1 to 2 levels above the normal level. You can see the descending vessels there, here. These are the microvasculature which are dipping inside the sulcus, and then this sulcus is between 2 fascicles. It is easy and then it opens up, and you in this case, because it is a post-traumatic avulsion, there were gliosis and then which happens to be seen. So, and you can see we have marked the tip of the scissors with a marker so that we don't lose our depth of lesioning. And then we go up to 2 to 3 millimeters depth. This is how it opens up, and then that is the end of the procedure. So you can see the marking there. So that is how it opens up. So we go that level of depth, and then it's a avascular plane basically. Once you know it, and then you are there. So take-home points: rhizotomy is a very elegant procedure, very excellent for post-brachial plexus avulsion injuries, and then the pain relief is instant. The moment the patient comes off the OR, he is like unbelievable. There is no pain which he was suffering, and then even it can be used for spasticity and other indications. Continuous sulcomyelotomy that is done, and then just mechanical disruption has better probably outcomes in terms of the complication profile. So, and it's best suited for peripheral setup where limited resources are available. So these are few of the publications which we had, and thank you very much for patient listening. And
any questions? Yes.
Excellent talk. When you do microsurgical rhizotomy, I hardly use bipolar to make the lesion actually. Bipolar is just making the PL this one, and I put a roton to make the lesion. So it's as good as your technology
yes,
the roton.
yes.
We don't use the continuous bipolar energy as Sanju described.
Yes.
That's one thing. Second thing is, if the patient has completely flail and anesthetic arm, I would definitely go for DRES. But if they have quite significant preserved sensation, we always try spinal cord stimulator first, and if it fails, we do DRES.
Yes, that's what I showed, that these are the alternative options, like you can use it. But then for those patients with quite severe pain, and then the cost factors, that's the reason probably we didn't get a patient of spinal cord stimulation here. And it's very good for resource setting which are limited by resources. So I think that is even many of them are not aware of that such procedure is available. So
we may use cordotomy for failed rhizotomies.
I have not used cordotomies for chronic pain.
So Dr. Milind was saying about focal deafferentation pain, probably motor cortex stimulation you would like to. So are these the cases where motor cortex stimulation can work?
Yeah, it can, but then this is much more simpler.
Yeah.
No implant, no programming, less expensive, and gives very good results.
Yeah, it's a one-time procedure, by the way. That is another advantage of this technique.
Also, I would just like to add that for those who fail this, you can always repeat it. And again, excellent results after sitting. We have even given it 3 times for those patients.
Actually, sir, I had a patient, we have done twice, still he's having pain. So I was just
that can happen in a because Dr. Deepak and we have done like analysis. So 4 patients had a recurrence, of which 2 we read it, and then 2 had actually good outcomes. The remaining 2 did not have that much.
Selection is most important. There are certain patients patients who have other kinds of pain. So again, there are so many variabilities in this.
So that is why I was just exploring if cordotomy may be used or not.
So thank you very much.
Thank you.
And we are already running late. We should break for lunch now. And I request everybody to have a quick lunch and come back. Please don't be there for more than. So we are starting, it's 2. So by at least 2:40 we should be here.
That's not quick lunch.
That's not quick.
The lunchtime was 1 hour. So
I've done 2 cases. How do you know? They are not all
ಆಗಿದೆ ಕಣ. So let's begin with the next session. I think there are a few people still having lunch, but still we go ahead with our scheduled time. So for the next session is Healing Sans Touch, and we start, I would like to invite the chairpersons, Dr. Ravichandra Kota is not here. Dr. Raghavendra. Dr. Raghav, I would like to request to chair this session. Dr. Raghav is a ex-consultant from AIMS Department of Neurosurgery, and he has worked in Postgraduate Institute PGI Chandigarh as a faculty for a short stint, and now he is practicing in Paras Hospital, Gurgaon as a full-time consultant neurosurgeon. So we start the session. You have the program. Start inviting. So the first talk will be by Dr. Devesh. He is a professor at Department of Anesthesia and Pain Management. So he would be giving us an overview on RF ablations. So Dr. Devesh, please.
Okay. So first of all, good afternoon all of you, and thank you very much for the invitations, and I really glad to just give my talk in this topic. So that normally a procedure that is a very common procedure and a very essential procedure as per the chronic pain management perspective is considered. So the topic given to me is the radiofrequency ablation. So basically for the chronic pain, if you say it is considered the pain, it may be considered as a chronic pain. And overview, so the chronic pain patient that you see in the mostly daily clinic, that you get referral from the patients of spinal pain or the trigeminal orificial pain, or many condition that basically sympathetic pain, and so many condition that need the definitive management after a diagnostic block to go for a long-term management of that pain. So for that, the radiofrequency ablation is a very essential role. So just try to see what exactly by this and what are the point to be considered. So just to declare, there is no conflict of interest. I've taken some evidence from PubMed and also some images and Google for my talk. So if you say the history of the radiofrequency ablation, it is not new. The technique has started since 1920. And if you see the initially, that is again the neurosurgeon has been gone through these phases because they have seen the patient in the to give something, the technique that after or beyond surgery. So some of the patient may not be in a good candidate for surgery. So what are the options for them to provide? So 1920s the questions, the series of experiments to show the utility of the radiofrequency ablation. And after that, it started the journey in 1930. Again, if you see the trigeminal neuralgia, all must be seeing and a pain physician and also neurosurgeon. This condition, something that is a suicidal disease, the patient is excruciating pain, pain that has basically a pain of lifetime. So that, again, the same patient, sometimes you are not fit for the MBD, or in that case, the options is again land on basically the RF ablation of the gastrointestinal ganglion. So this how the intervention basically came, and if in the 1950s, one of the very important landmarks here that Cosman and RF, they put the first commercially available RF generator, because the machine that is came in practice in 1950s, that Cosman company, that machine, I think many of those are old basically practicing pain. This is the machine that is used by many, even in our department also this machine I have used since I think before the new machine in years. So if you see the consider the radiofrequency ablation, is there are different types of ablation, or if it's the radiofrequency considered, there is different types. If you just broadly classify, one is basically the continuous RF, that is a CRF that is most commonly done from those patients of which genicular RF, or some of the patient that sensory, basically it's not a motor nerve. The another component is basically the non-destructive. If you see the CRF, the continuous RF, that there is some the thermal lesion, that is there is destruction of the nerves. But in case of a non-destructive, some of the nerve that cannot be damaged, that is a non-destructive modulation. So there is a neuromodulation phenomenon, that is a pulsed RF. The third one is a cooled RF, that's the new advanced technology, but is basically if you see the CRF and PRF, that again I will consider later on. The third burst of the RF, that in between the pulse there is a basically the limiting a silence phase, and the burst of RF is delivered for 20 milliseconds, and in between the silent period basically the heat dissipate to the tissues that without damaging the tissues. So in case of a cooled RF, it is advanced technology that is more with the water cooled channel is there, so that the heat will not be the tissue will not be charred, and the heat of the will be properly dissipated among the tissues, giving a bigger lesion in that. So another technique is basically the two electrode placed side by side that causes a bipolar lesion. So that is a bipolar RF. So these are broadly the four RF condition that is there. So if you see the lesion compared with the conventional RF versus a cooled RF versus a bipolar RF, the lesion sizes or the lesion morphology is different in that way. So just continues one by one if you see to consider the basic of what exactly a continuous RF is. So if you see the RF generators basically delivers a minimally invasive, as you say. It's an image guided procedure that might be an ultrasound, or mostly we do on the fluoroscopy also. It uses the radio waves that is around 500 kilohertz frequency to generate the heat, and that destroy the targeted tissues such as the pain transmitting nerves. So the target selective, basically neurodestructive procedure is this. Most common, if you can see the patient with facetogenic pain that has a medial branch is the most of the contributor to that. So most common procedure that is done. And in this case, if you see, there is protein denaturation, that the thermocoagulation occurred and the nerve signal is damaged. And subsequently, if you see, this is lead to a volume degeneration for that. So that means there is nerve damage in this case of a continuous RF. So that's why also you have to consider this procedure selectively, in which case you want that volume degeneration for this. If you see the indication of RF, is a clinical practice, yes, all were clinician. So many conditions that as an intervention pain procedure that using RF technology, if you see the consider the head and neck pain, many a patient that is trigeminal neuralgia or some of the headache, which are the post-herpetic neuralgia or occipital neuralgia. Many a patient with the spinal pain, if you see the spinal pain is one of the most common condition that bombard with the pain clinic or the patient with the orthopedician, neurosurgeon. If you see 60 to 80% many a patient has, if the degenerative spine, they all have mostly the mania, the one of the pain generated the facet. If you see, consider that. Some of the radiculopathy, if you see, though sometimes if the surgery also doesn't work in that way, but in some cases you have to initial part that doesn't fit for a surgery, you have to target the dorsal root ganglion that needs some sort of RF, that is maybe a pulsed RF. So there are certain modality that can be used in clinical practice of this technique. So I'm not going to the other modality in that way, because cancer pain and other pain modality like a joint pain, so knee joint, shoulder joint, in all basically the chronic pain condition, RF has a definitive role. If you see by the guidelines or the evidence-based practice that we normally would do, it has a very good recommendation in chronic or low back pain, where if you see the facet joint pain, one of the considered, in that way it is a middle branch block has been given a level 2 recommendation for a radiofrequency ablation. If you see the intraarticular injections, basically sometimes it is not ideally recommended in that way. But if you consider the other condition like a chronic neck pain as well, that a facet or the pain coming from the facet joint, so middle branch block has been targeted for that, and also the giving good result. So what are the equipments for this RF ablation? If you see, this is the RF generator that is that I already shown in that way. It has two electrode and the probes that conduct the RF energy, and there is some sensing mechanism like temperature and the impedance control. So another important part is the sensory and motor stimulation. It is one of the very important part for doing the stimulation. Why? To differentiate the basically the see the at what stimulus the pain is generated, and also rule out the motor component. So if you see the component in this case, if you see there is a generator is there is a grounding pad, and the active electrode, basically this is a monopolar RF setting in this case. The current is generating to the RF electrode, and basically this particular electric port is placed, and the needle is placed close to that neural structure. So if you see the components, if you very closely see, this machine has different monitoring system. If you see, the first is to the impedance, second is basically stimulation. The stimulation in this case, if you did, there is two types of stimulation. Mostly the sensory stimulation is done to know exactly at what voltage or at what current the patient is having the sensing the similar type of pain. And also it has that other component that is the motor stimulation, so that you can have a sensory motor differentiation, and also you can see the at what stimulation that you are having a somebody important structure is there close by, and you are giving a motor stimulation. Another important is the output, basically the RF output. If you decide to go for a pulsed RF or a continuous RF, based on that you select on that and just select your output, basically the current or what exactly you want to do, and the time. So basically the 60 second or the 90 second, that single cycle is there. On some cases pulsed RF, basically you go for a longer duration, those were neuromodulation, but in case of a RF, is conventional RF 60 to 90 second is done and repeating the cycle in that way. If you see the cannula, if you see most commonly used, its electrodes are available in various length and sizes or diameter. If the RF cannula is a 5 or 6, basically 10, 15 or 20 centimeter length, and if you see the closely it's used this tip. So it has an insulated part and an active tip. So the active tip is basically, if you see, this is the area that we are going to place the, or the put the probe close to that nerve. And based on the thickness, it differs from the different gauges from 22 gauge, and the active tip also, the length also differ 2 millimeter, 5 millimeter, 10 and 15 mm. So this basically decision depend on the which basically area you want to do, and also sometimes the curved and straight. The needle also sometimes curved and straight to increase the capture rate. Sometimes the nerve is not very close to that, so that if it is a curve, then it chances that it might be, the nerve capture might be more in that way. There are certain newer modality also coming up. This is the Trident needle that is not, I think, available in India right now, but it's, yes, it is in the outside the US, it is there. The venom needle, the last one is the basically the venom needle, that is, I think, given with the striker. So the other new component in the RF needles is there. So as I told you, regarding the stimulation part is very important to sensory motor dissociation before going for the treatment modality. And also decide exactly the length at which part you are getting the ear. So it decide the electrode or the nerve distance. If you see, you are getting a stimulation that is around 0.6 volt, that means it's more or less the nerve is around 3 millimeter. If you are getting a 2 volt, that means the nerve is away. So that means if you are doing it to RF, that means you are getting a sensory stimulation at around 0.4 to 0.6, so that it is over that, because the lesion is going to form around 2 to 3 millimeter around the needle only. So beyond that, even if you are getting a stimulation at a higher voltage, the lesion may not be created at the respective site. So that's why it is very important, so the stimulation part. So what exactly happens in the ionic hitting or the principle of hitting in this RF? So if you see, the current is basically that create ions in the surrounding tissues move, that create a friction. So that friction hits the surrounding tissues, and the thermocouple basically that sense the temperature. And if you see the probe, basically the placement of that area, so that temperature rises on that area. So if you see the placement of the RF generator, and the probe electrode is placed around the area along the grounding pad, and this impedance is also again is important to see it resistance. This is a resistance circuit to the current, that's basically that confirm that you are getting a impedance, that means that's continue, the circuit is complete. And also it also difference between the different tissues. Basically when you are, the needle is moving in that way, we are expecting around a 250 or 300 of resistance, so that if suppose a bone is there, it's, if you consider the impedance, the bone gives the most resistance, the spinal cord, CSF blood. So basically the impedance is differs in that way. So for the neural tissues, we normally consider around 250 to 300 resistance. Sometimes there might be the structure is close to the bone, so in that case it gives a high impedance. In that way you can use the saline or something, so that the impedance will be decreased, and also that improvise the lesion formation. So if you see the temperature distribution, how does in a conventional or the continuous RF, how does the temperature is distributed? If you see, this basically the active tip is there. So the lesion is formed around along the nerve longitudinal. That means the more you go away from your probe, the activity, the temperature drops. So the maximum tissue charring, that is the destruction, occurs around that. And the neuroduction, if you see that the more than 45 degrees Celsius, there is neuroduction occur. And also if you go away from that, some zone of some reversible temperature there, because the temperature is decreased. So that is the area, the reversible zone or reversible damage around that. So if you see the more than 80 degree already region occur. So needle placement, as I said, this is basically the nerve has to be placed parallel to that. If this is an example of basically the middle branch block. So if you see here, the needle has to be placed parallel to along the course of the middle branch, and then the lesion has to be done, so that the lesion will be formed around that along the longitudinal aspect of that nerve. So this is the way the needle has to be placed, and also you can check by the fluoroscopy. So as I say, the lesion, the shape of that, it is a spheroid or the ovoid side. It depends on the electricity configuration, that if the temperature, how it is there, or the local tissue characteristics, and the time. These are all the factors that basically, if you see, consider the different factors that contribute to the lesion formation. So based on the different tissues, again, if you know, of course, variation. Suppose sometime it might be seeing ultrasound, you are seeing directly the nerve. That means you might be more, can be placed very close to the nerve. Might be sometime the tip shape or the cannula gauze, the higher gauze size might be from a bigger size. In some cases, the monopolar, bipolar, the cooled RF, depending on that different technique, the lesion size differs. If you see the tip length basically, so the 15 mm active tip has the lesion size bigger along that radiation. If you consider the gauze of the bigger size of the needle, if in this case, if you see the gauze is increasing and that way it's giving lesion is bigger. If it's the temperature and again the time also, it's again depend on the how the initial part when the temperature rising basically, normally the initial part that the temperature rises, the maximum lesion occur. So that if you see the beyond 30 or 40 seconds, the lesion doesn't increase more. So there no change beyond 60 seconds. And that's why the lesion timing doesn't increase by 60 to 90. So many a time RF cycle is getting repeated rather than a prolonged time. So a conditioned RF you don't do for more than 90 seconds. Mostly if you see in the CRF, it's basically where the temperature will increase and the tissue become charred and there will be no lesion. So that's the importance when you have put a good or basically the temperature is controlled. Another modality is pulsed RF. So what exactly you need a pulsed RF? The pulsed RF differs in that way, this is not a continuous one. So the lesion is basically, the current is basically supplied in between a pulse, 20 millisecond, and there is basically the silent period where the heat is getting dissipated. So here there is no any thermal or nerval destruction, rather it is neuromodulation, and it works by modulating the nerve activity, reduce the neuropathic, radicular and the joint pain, mostly a different indication. And in this case, if you see the mechanism, as I think it's still undergoing so much of research regarding the nociceptive signaling or inflammatory path. So if you see, so that's how this mechanism also differs as compared to here. And if you see the DRG is one of the conditions that normally we do for the radicular pain, the PRF, pulse radio frequency ablation for this duration around 3 minutes or 5 minutes, that modulate your radicular pain in those patients having that. So these are the difference in that way. Again, in this case, there is heat production there, and also the main issue is the neuromodulation part as compared to RF. This is an overview of that's basically differ with the conventional versus the pulsed RF, where exactly neuroablative versus neuromodulation. And as you say that the indication also differs in that way. So there are another tips is basically you can see if you see if you are putting an RF in that way, you make sure that a needle tip should be very close to that nerve so that the width is not going to more than that. Another important part is basically the cooled refractive ablation. This is something that is newer advancements, because if the temperature is going beyond that, the tissue charring occurs because of the temperature. So if something can cool down the tip, so if you see the probe tip temperature is still cooled down by the 60 degree and the tissue temperature 80 degree, that means the lesion size will increase. So this cooled RF needle is something different. It's a gauge is bit of more. This is a machine that has a pump and a motor for a RF, basically the water channel that is circulate, and the needle is basically the water is cooled. If you see in this, the water is there is output and input, and the water is circulated and the temperatures get down. So active cooling of the tip occurs that lead to the bigger lesion size. The difference in that case, sometimes when you do a cooled RF for a medial branch, in this case the needle placement is perpendicular. That means in that case the technique is a bit of more different because you have to put the parallel, but in case of a cooled RF you can directly put it here because the needle lesion is formed just in front of that. That means in front of the tip also. See, this is mostly the procedure that is done in that is Cordotomy view, and the needle is just at the same the gun barrel view the plate is placed. And you can use a lateral view also confirm that it's the lesion at the 60 degree. So that is what is the difference between the probe position basically in this case. If you see once you put the stellate and the probe, in this case normally there is a gap of 2 millimeters. So the disadvantage in this case is maybe because the lesion is formed in front of that. So if you take out the stellate and put the probe, that means it's giving a circle more of a spherical side. So I'm just coming to my end. So the lesion morphology is something different in this case because in this case spherical form of descent as compared to the conventional RF. And if you see the again initial part in the cooled RF, there is a cool phase, and then so around the tissue interface basically the temperature is less. So that's how the tissue charring doesn't occur and give a good lesion size. Again same thing, that is normally the difference. This is the bipolar RFA sometimes is done for the basically the disc or bipolar plasty is done, or sometimes the knee RFA also. In that case, if the two electrode is placed close by, and if you see the electric current, it's passes with the two closely placed electrode rather than from the grounding pad. So in this case, sometimes there is, if you see the lesion size is much bigger as compared to single conventional or the continuous RF. So this how does the lesion size can be increased depending on the which area I want to do the ablation. So risk and complication, if you consider it is minimally invasive, if compared to many other infections as very rare, but sometimes which is possible, you have to maintain some strict asepsis. Nerve damage might be possible because if you are improper placement, and sometimes you are working against a very close area. Pain recurrence, yes, you have to explain the patient that this pain might come again because the nerve is going to regenerate over time in a different way. Chances of skin burns is there because of here the poor grounding, or sometimes if you are using the probe very close to the skin, there might be procedural pains, failure. These are all everything can be patient to explain to the patient. So the last of the key message is that it is minimally invasive. There is no major surgery required for this. It's an OPD procedure. Sometimes patient is coming and the discharge. Effective pain relief in some cases can last months to years. Sometimes it again differs from patient to patient. You cannot say that every patient the same procedure will last. The recovery is quick, patient can go home the same day, and the risk is less as compared to the other. Thank you very much.
Thank you. We'll move on to the next talk. Professor G.P. Dureja sir, DRG stimulation, when, why and how.
Not this, not this. The third lecture, please. Not this, not this. Yes. Thank you very much, Chairperson, and thanks a lot, Ramesh, Dr. Sarath, and Dr. Deepak for inviting me. I'll be talking about dorsal root ganglion stimulation. Perhaps in the morning we had a speaker who talked about spinal cord stimulation, and I'm very happy to tell you that the first spinal cord stimulation in our country was done in this institute. I learned a lot from this institute, and that's why I'm taking it forward to the private sector. And that was 1998 when we did in one day we did 3 patients where we put in spinal cord stimulator, and from 1998 to 2005 we almost did 200 of neuromodulation devices. I'm still continuing in private sector. My last case was just about a month back, which we did in a patient of failed back surgery syndrome. So obviously since morning people have been talking about neuropathic pain, the various conservative therapies, but when everything else fails, see, basically these are not the first modalities. When all else fails, you have to rely on the neuromodulatory therapies. And initially we had this spinal cord stimulator and intrathecal pumps, which we do in plenty for various pains like neuropathic pain, cancer pain. But then specifically, I'll be giving you an overview of dorsal root ganglion. Of course, spinal cord stimulation, everybody knows. Also termed as dorsal column stimulation. In the past, we have peripheral nerve stimulation, which came in a big way in the early 2000s, and people were putting leads everywhere, occipital nerve, anywhere where there was a pain or a scar, people put a lead and then connect it to a pulse generator. So that was peripheral nerve. But to be more specific and to address the focal neuropathic pain conditions, we have this modality which is called the dorsal root ganglion, and as the name suggests, you have to put the lead around the dorsal root ganglion. So this is what we used to do in the past. We put a lead in the spinal cord near the dorsal column, very close to the midline, and then fix it up and then connect it to a pulse generator. Initially we do a trial for 4 or 5 days. If the patient has relief of more than 50%, then we put a pulse generator, and that's a complete spinal cord stimulator. But over the years, I think somebody was mentioning in the morning too, what my experience of almost 150 spinal cord stimulators is that over a period of 1 to 2 years, the efficacy of spinal cord stimulator starts going down, and sometimes patients are very upset about the paresthesias, and they say that I'm not happy. So I have explanted a lot of these stimulators because patients said that the efficacy has gone down, and that this is real. This may not be, you may not read this in the literature because the literature says that 3 months, 4 months, 6 months. Nobody does a 2 years, 5 years follow up of these patients. But most of my patients, almost 50% of my patients, have said, no, I don't want it. Please take it out. This has happened. This is real. This is what we used to do in the past. We put a lead in the spinal cord near the dorsal column, very close to the midline, and then fix it up and then connect it to a pulse generator. So that was peripheral nerve. So then came the concept of dorsal root ganglion stimulation. Dr. Devesh was talking about dorsal root ganglion radiofrequency ablation, but we are talking about stimulation, which is more precise. And I'll tell you why we choose dorsal root ganglion. This is the dorsal root ganglion, and this is my lead, which is like just like spinal cord stimulation. This lead is around the dorsal root ganglion. Now, the difference between spinal cord stimulation and dorsal root, the anatomy of the dorsal root ganglion allows stimulation of abnormal pain fibers more selectively than the conventional spinal cord stimulation. So, why we choose dorsal root ganglion, I'll come to it in the next few slides, but the literature in the last 10 years, maybe it came in 2009 probably, in the last 16 years have said that if it is a focal neuropathic pain like a post-herpetic neuralgia or a scar pain or knee pain, CRPS, phantom limb pain, dorsal root ganglion would be more effective than a spinal cord stimulator, and that's how. So this is the dorsal root ganglion we all know, and this is a very important structure which I just give you the anatomy. It's a nerve structure located in the intervertebral foramen, and the primary sensory neuron, these are the most important thing. It has a 15,000 primary sensory neurons, and we all know that the pathway of pain goes through these primary sensory neurons. So if you can do some modality which stimulates these primary sensory neurons, which are the cause of the neuropathic pain in a big way, then I think you have achieved good results. This is normal action potential generated in response to sensory input, and they are carried through the propagation, and you have a normal sensory feedback. But in a patient with altered sensory pathway, there are inflammatory cytokinins which are released in response to the injury. Spontaneous action potentials are generated by the cells in the dorsal root ganglion, and these are the primary sensory neurons where the action potential is generated. And if you can some way control these action potentials, you will be able to control neuropathic pain much effectively as compared to what you do when you put it in the dorsal column stimulation. So it's a DRG is a very important, plays a very important role in modulating the sensory input. So there is a scientific reason why we do it, and it has been shown to be responsible for generating a finding, as I said, increasing the possibility of neuropathic pain. So every target, like we burn the dorsal root ganglion in patient feedback, here we are stimulating the dorsal root ganglion to prevent the pain signals from traveling to the brain and in a way interrupt this pathway. Dorsal column stimulation, we still do not know. The spinal cord stimulation, we still do not know the hypothesis. It is maybe the paresthesia which cheat the brain sensation. So still till today we are not sure how the spinal cord stimulation works. But herein we have a hypothesis which says that primary sensory neurons are responsible, and we know it physiologically, and if you can work at that level, the things would be much better. And this again to highlight that the action potential generation is reduced, and that's why neurostimulation techniques of the dorsal root ganglion have been able to, we don't have very much randomized controlled trials as yet, but whatever studies we have in the last 16 years, they have all shown to be positive results, and I think over the next few years we will be using this more often. So just to give you an example, focal neuropathic like a complex regional pain syndrome, we get plenty every day in our OPD, we get plenty of such patients. Post-herpetic neuralgia, one of the deadliest neuropathic pain conditions. If a patient comes after 6 months, you may do anything. I've put spinal cord stimulators, every devices I've done, and it's still a failure if it is more than 6 months. And then you see this is a patient who had a TKR or a surgery, and after that CRPS develops, and these are very common pain syndromes which come to us, and you have to do something. It's a localized pain. It's not a generalized pain, but it's a localized pain. So if you can localize the dorsal root ganglion and stimulate, patient would get much better relief in these patients. So these are some of the indications. CRPS, as I said, post-surgical groin pain, very, very common. Post-surgical knee and hip pain, TKRs, THRs, a lot of patients come with post-surgical foot and ankle, phantom limb pain, where nothing works, even spinal cord stimulation doesn't work. Maybe dorsal root ganglion gives some hope. Fail back, I don't like this word. Post-surgery, continuous pain syndrome, peripheral nerve injuries, post-herpetic neuralgias. So this is as compared to the spinal cord stimulator lead. There's a difference. This is a lead which is little curved, and you can maneuver the lead. You can easily maneuver. Of course, the spinal cord stimulator, you can maneuver, only the tip moves here and there, but you can't sort of bend this portion is not made like this, so you cannot bend. Because for enveloping the dorsal root ganglion, you have to have a lead which envelopes the dorsal root ganglion. And you can see you have to go through the epidural route obviously. So if I have to put the lead on the dorsal root ganglion on the left side, I will have to go put my needle through the right, and it will be like a tangential insertion. So from here I'll put my epidural needle and just below the lamina here, and through that I'll put my lead and try to bend it, maneuver, because you have a sort of a stellate through which you can maneuver and keep it on the. You don't have to encircle the dorsal root ganglion, you can just keep it on the dorsal root ganglion, and the stimulation, when you do a trial stimulation, the patient would be able to tell you exactly the dermatomal distribution of the paresthesias which occur. This is again to show you, it's an oblique, it's a 14 gauge 2 needle, and it's an oblique needle. If you're doing spinal cord stimulator, it's not difficult, because you have to go one and enter in below the lamina and then maneuver your needle into the around the dorsal root ganglion. So this is just maneuvering the needle around the dorsal root ganglion. This is again to show you that the needle, and through this we have put this. So we are going like this into the epidural space. This is my DRG lead, and my DRG lead I am trying to place it right on the dorsal root ganglion. So little difficult than spinal cord. Sometimes you get stuck in spinal cord stimulation lead also, but here you have to really use your expertise or maybe your luck that it may go there and lie on the dorsal root ganglion. So more efforts and more time are required. So this is again a lead on the dorsal root ganglion. So this is just to place just on the dorsal root ganglion, and once you do the stimulation, you will be able to. So there are different types of leads, like you have a octrode, you have a quadrotode, whatever, like 4 active leads or 8 active leads which you can use, and then you can see as per the dermatome you will get stimulation in that particular area. In spinal cord stimulator you get a very wide area, like you can cover 80% of. So if it is a patient with a leg pain, I won't prefer a dorsal root ganglion, I would prefer a spinal cord stimulator. But if it is like a thigh pain or a knee pain or localized area pain, I would prefer this, because I'll be able to stimulate that particular dermatome where the pain arises, because I'm at that dorsal root ganglion and I'm doing it. The literature also says a lot about the lower extremity neuropathic pain syndromes. There are lots of evidences, and this is just a review which you can go through, and this review has mentioned about various studies which have found it to be useful in CRPS, in post-hepatic neuralgias, in failed back surgery syndromes, and in lot other conditions like a knee pain, lot other conditions. And one of the major difference between DRG stimulation and spinal cord stimulation is that the paresthesias are much better. As I said, one of my patients after the trial had a good relief, but he said that I cannot tolerate the paresthesia, because these paresthesias are really disturbing. I can't sleep. I said, you have good relief, so what about the pain which you had? But he said, no, I'm upset, I couldn't sleep the whole night. And he refused. After the trial, he said, no, take it out. So the advantage of DRG is that the paresthesias are much less, and you stimulate at sub-threshold levels, so that these paresthesias are hardly negligible or no paresthesias, yet the patient gets very good relief. So that's a bigger advantage over spinal cord stimulator, that you don't have paresthesias, which is normally seen a lot. Rather, we believe that the paresthesia is the one which distracts the mind of a person in spinal cord stimulation, but herein you have less paresthesia or no paresthesia, and that's a big advantage of these are some of the studies which also found that 87% patients did not report any paresthesias. So to conclude, primary sensory neurons located in the dorsal root ganglion play a very important role in the development of chronic pain and maintenance of chronic pain. We all know that, but it has been substantiated now, and we know that it plays a very important role as a modulator of the sensory inputs, and stimulation can interrupt this process. Of course, radio frequency, as Devesh said, can cause damage to it, but why cause damage to an important structure? Stimulate it. The primary sensory neurons are the ones which are taking the pulse impulses to the brain. You stop the impulses going to the brain, and the evidence is showing much better results than spinal cord stimulator. Little expensive, but even spinal cord is very expensive now for our Indian patients. So let's hope that in the future, dorsal root ganglion, particularly for focal neuropathic pain conditions, does a better job than anything else. Thank you. Thank you so much. Is there any questions we can take?
Question from the audience, please.
Yeah.
Thank you very much. Excellent talk. So we have implanted huge number of DRG implants in the last 15 years. The enthusiasm seems to have come down because
the hardware is not very robust. There is a high incidence of fracture rate as well as lead migration. So in UK, pretty much most of them have kind of stopped doing DRG. They're all waiting for a new hardware to be released. So that the company has told us that it will be much more robust. There's a new sheath which would make it very easy to implant. So that's one thing. The second thing is, I mean, most spinal cord stimulators these days are paresthesia free. So
high frequency ones.
So burst stimulation, for example. Same thing with all the DRG stimulation. We do it paresthesia free because we use burst stimulation, so patients don't feel anything. But you're absolutely right that for focal neuropathic pain, and I've implanted from C5 to S1, pretty much every level I've implanted, and you get very good coverage of the pain areas compared to spinal cord stimulator if you have a very focal pain area. So again, I appreciate your.
Thank you. So actually in India, you know, we get these products a little late, like spinal cord stimulation, the burst and the high frequency are still not available. So we run a little late than the word, but still, I mean, whatever we have, we continue to do the work.
So, sir, is it just one lead or you tend to, because most of the time it's overlapping pain and then you are not like specifically.
So not generally one lead, but 2 leads minimum. But if it's a very, very local area, then 1 lead can also suffice. But it's generally 2. More than 2 would be very comprehensive. And these are very flimsy leads. These are very thin leads as compared to spinal cord, which are very good, hard and robust. Here they are very thin because you have to maneuver them. So as he rightly said, that the chances of the migration of the lead are very, very, very commonly seen. But the concept is good, and if we have a good hardware, I think the job would be done. Yeah.
Thank you, sir.
Thank you, sir. So we'll move on to the next talk, MR focused ultrasound in pain by Dr. Milind Devgankar.
I think this talk should be given by Edo, but I'm going to give it. So, this is a new tool which is very much in demand nowadays, and people think this is going to replace everything, DBS and all those things. But we got our HIFU machine in 2019 and I used it for pain and movement disorder both. One thing which is really unique about this machine is you cannot harm a patient. It's very, very difficult to harm a patient with HIFU. I mean, you got to be really, I mean, machine itself has checks that you cannot go beyond a certain point, and HIFU is so safe, and you can go to any part of the brain. So that's another thing. I mean, nowadays you can make a lesion, you can start with PTT, go to STN, so you can make the lesions in a line. Like for CL, you can make the lesions one above other. You can curve the lesion, you can change the sizes of the lesion. And with LOFU, that's low frequency ultrasound, you can just cause neuromodulation. There is not even destruction. So I think this tool is there to stay. For pain especially, it is there to stay. It's a very good tool. It's very stealthy. You go in and out of the brain without causing any harm, and the patient goes home within 2 hours. So I think it's a very good tool. Lesioning procedures, these are the cingulotomies we used to do. We always did 3 lesions, 1, 2, 3, 1, 2, 3. So 9 lesions on one side, 9 lesions on other side. Very destructive procedures. Again, coming back to Jamanod, Jamanod was the one who first described thalamocortical dysrhythmias, and he was one of the first one to even do the CL thalamotomies using HIFU. So what are the other modalities? John Reggie has given a very nice paper on this, different modalities, RF, gamma knife, laser, what are the pros and what are the cons, and the same thing with HIFU. So there are various modalities available to make lesions for chronic pain. But HIFU is by and far looks like the safest modality right now. So what is HIFU? You all probably know, but I thought I'll put in few slides about it. It was developed by Incytec in Israel, and it was first used for soft tissue fibroids and soft tissue malignancies. And then they started using it for intracranial lesions, to make lesions intracranially. It's MR guided, and you can actually have a real-time MR thermometry while doing the sonication. There is a helmet, and then there is a cap on the head which is filled with water bath, so the temperature at the skin should not rise and you should not get skin burns. You have to shave all the hair. I think they are now working on getting a newer version where you don't have to shave the hair. But right now you have to shave the hair. I think there are total 1800 sources. And depending on the SAR of the skull, some of the sources can go in, some of the sources cannot go in. So I think you need at least minimum of 800. We've done cases like 160 sources also, but that just takes time. So the patient gets on the MRI and this goes around their head, and the patient goes in, and then you can do a real-time MRI. This is another picture. So that's the helmet that goes on the head. You go inside, you can do a real-time MRI to make your target, and then you can look at how many sources you are able to get, and then you can start your early sonications, low energy sonications, and then see the benefits. And this is beautiful in tremors. I mean, in tremors, if I have a choice, I would do only HIFU rather than doing a DBS. And in elderly PD patients, again, HIFU is the one I will do. Young onset PD, I will not do it. And chronic pain, definitely intracranial intervention, if I have to do, I'll use a HIFU. So this is what the MR thermometry shows, how the temperature goes up and how that graph goes down. If there is a cavitation or something, that can also be seen here. You can use tractography also to target in HIFU, and that gives accuracy in movement disorders as well as pain, both. This was NEGM, Jeff Elias was the first one to start this in US, and this is his trial, and it was published in NEGM, which shows significant improvement in tremor with very, very little or no complications. What about the use in pain? So as I said, Jamanod started using it in pain, and this was his article published in 23. He has a new article with 120 patients now. This is 63 interventions. And this is what he shows the lesion. So You can make the lesion along the posterior limb of CL, 1, 2, 3. So he actually makes multiple lesions now. Even up to 12 lesions he can make. So these are the coordinates that he chooses to make the lesions for CL thalamotomies. And he has one of the best results for CL thalamotomies. This is his Kaplan-Meier graph. The pain comes down almost to zero in all of his patients. So all the p-values here are really significant. So extremely good result. And these are complex pain patients who are referred to him from all over the world. These are not simple chronic pain patients. So HIFU CL thalamotomy really works. What are the other possible targets for chronic pain? Intracranially, spinally, you can do probably midline myelotomies using HIFU if you can find out its use in spine. Musculoskeletal, some people have started using it in bony metastasis and arthritis. So this is what for pain you can do HIFU. HIFU can probably be used in insula. Insula is still unexplored target. Insula is a target which is a very complex target, and you wouldn't want, people tried to put DBS in insula but did not help very much for fear disorders and chronic pain. So with HIFU you can make actual lesions in insula. You can also go to brainstem target like locus coeruleus. You can make lesions there. So, so all these which are parts of the somatosensory processing of pain pathway, you can make lesions. And as I said, that's the beauty of HIFU. And I don't know if one modality is better than other. I think all modalities have their pluses and minuses. But with HIFU, having a complication, having a bleeding is very, 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 very extremely rare. And you can make lesions for gamma knife. You have to have shots. And but in HIFU, your lesions can be stacked one above other. You can give them U-shaped, you can give them X-shaped, whatever shape you want to give with multiple lesions. So again, as I said, this is a lovely tool with sensitive touch, flexible, stealthy, and can reach in the nooks and crannies of the brain. And that's why I think in future, when it comes to managing pain with intracranial interventions, probably HIFU will be much more important once it's freely available. And it's a one-time thing, there are no implants, so I think not now, the machines are still not there and they're still very expensive in India. But as the machines become more common, Dr. Razai's team in RNI is working on small portable HIFU machines. You don't have to go in MRI scan, you can put in a frame and attach the machine to the frame, and you already have targets, and you give the order, and you can do it in OT table, and patient still walks out within 2 hours. So I think once the machines of that time come, this might be one of the primary modality of pain treatment. This is probably slightly more invasive than TMS when it comes to actual the settings and going home and all those things. But you can reach very deep in the brain. I mean, out of all the HIFUs I've seen, I only seen one small bleeding, and that too in low frequency ultrasound, not in high frequency ultrasound. I haven't seen a single bleeding in high frequency ultrasound. But CL thalamotomy procedure, we are doing anterior inferior anterior capsule lesions with HIFU in OCD, not so much in pain, but we can do that in pain also. And then other targets of pain, whatever brain targets of pain, we put in DBS or do RF lesioning, subchordic tractotomies, or nucleus accumbens. So all these can be basically reached by high frequency ultrasound without incisions, without hospital stays. So I think this is a machine of the future. Thank you.
Dr. Milan, very nice talk. My question is, half a century back we were using RF lesioning. Then came the deep brain stimulation saying that it is non-destructive, and that was the main USP. Now after that whole cycle we have come back to destructive lesioning, and now we all thought that is industry driven, but now we have you as a major proponent of HIFU. So you said in elderly patients, those with essential tremors, you would actually prefer HIFU over deep brain stimulation. So why is that?
See, permanency is not a curse always. Permanency is sometimes a boon, because you have a permanent lesion and you don't have to see your doctor any time again in your life. So that's not bad. I mean, having a DBS system coming every 3 months for programming, checking the batteries, charging it twice a week, worrying about it. So why not just to make a proper lesion, because this is going to be for the rest of their life. And especially in essential tremor, the symptom complex is not going to evolve like it evolves in Parkinson's. You have to make adjustments in DBS. That is not going to happen. That's why a young Parkinson's patient, I would still do a DBS, because his symptoms are going to progress in a certain way. But in elderly patients, 65, 70, we know it's not going to evolve. Even if it evolves, it's going to evolve into non-treatable motor or non-motor symptoms of Parkinson's. So do it one time, let him go home, and don't have to come back again. And I think this third cycle keeps on changing. I think this is becoming popular, or gamma knife is becoming popular because of the perceived non-invasiveness. It's not non-invasive, but it's perceived as non-invasive. So a lot of people think if I'm going home in 2 hours without tremor, what's wrong in it? It's like always some of my patients ask, I said, well, this is there for last 10 years. What will happen after 10 years? I said, I don't know. But this is like angioplasty and CABG. So you do a CABG, you're good for another 40, 50 years bypass. You do angioplasty, stent might get blocked after 10, 12 years, might not. But it's significantly non-invasive. So if you want to take that course, take that course. Non-invasiveness is a big plus. And permanency is a plus in certain conditions, certain age groups, certain symptoms.
Agreed. So another thing which I had in my mind was, what I read was the disposables for HIFU are very expensive, because that water bath is a disposable, the whole thing is a disposable and costs more than 1 or 2 lakhs. So I just want to know, is that correct?
Yeah. Yeah, that's correct, but there are things the foundation is trying to give it at a lower price. The price of HIFU disposables is not driving the price. Price of HIFU in India is driven because of the investments hospitals have made in it. It's expensive machine. They got to take the money out. So I think if there are 10 HIFUs, the price will come down significantly.
But for a government institution, it is the consumer which create a problem.
Right.
Because the upfront capital cost we can give very easily, but and we can even provide free to the patient once they have the capital. Like gamma knife, we can give it. But it is the consumer which create a hurdle for day-to-day use in these patients, because most of them are poor. Then we have to arrange the consumer.
I personally, I mean, I'm not an expert, but I personally don't see why that silicone cap has to be disposable. It can be reused.
Yes.
You can just keep that, and as long as it fits tight and water doesn't leak, it can be reused.
Thank you for that talk. I don't know how the economic model works here, but in England, if you do sort of 10 or 20 cases, you can recover all the costs back. So it's almost like cost neutral there, but I don't know how it works here. The only disadvantage of HIFU is if it's very superficial target, it's very difficult to do that.
Correct.
And the second thing is, although people have done staged bilateral thalamotomy for tremor, you still have high risk of speech disturbance. So it's still, generally indicated for unilateral thalamotomy. So if a patient has bilateral essential tremor, you can still do one side. I would not do both sides. And then talking on Deepak's this one, there's certainly a resurgence of interest in lesioning procedure despite DBS. Certainly, both RFA and the gamma knife and now the ultrasound. I think there's still a role for lesioning procedures, especially for elderly patients.
It got recently approved for bilateral thalamotomies by FDA because the risk is very, very small. And secondly, you can actually test the speech on table by doing low frequency, low intensity sonication to see if speech changes. And if it doesn't, then after making a lesion, chance of speech going away is very, 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 very small. So it got FDA approved for bilateral thalamotomies in US. And this is, you are right, if your target is too lateral or too close to the surface, you cannot get all the sources there. So yes, I mean doing cingulotomy might be difficult using HIFU. But most of the other targets are central, thalamic targets, so it should not be a problem.
So just a comment on the overview of lesioning. So I've been doing it for more than 2 years and 50 plus cases in movement disorders. And sir, RF ablation is, lesioning in general is a very, very, underutilized and underrated actually. And of course, our industry and everything drives it. But in my opinion, the patients are quite happy. Most of them would complain for the second side because most of the fine work can be done by one hand. So they're not so unhappy. Even in Parkinson's disease, the results have lasted for at least 2 years. Especially when the significant asymmetry of either dyskinesia or the rest tremors, which generally is, but high asymmetry, it works, much better.
I completely agree. I think RF should be done more. And once you start doing this more and more, you will start making lesion sizes bigger. So it will last even more than 2 years. It will, I think initially we are prone to make lesion sizes smaller. And then after few years, I can add another lesion 2 millimeter up and nothing will happen. So in that case, that will probably even last longer. So RF, for India, RF is great. Dr. Dodamani, where is he? He's gone. But he had this dystonic storm patient last month and wasn't going away, Wilson's disease. And he did a unilateral palidotomy and the dystonic storm went away. So the patient came off the ventilator. So that's the beauty of palidotomy. You can do it very quickly if you have the RF thing, stereotactic frame, AMR set up in your own hospital. You can do it without asking for implants.
Right, and sir, PTT I think is even a more game-changing thing than palidotomy, which is a more dispersed target, and PTT is quite, compact.
PTT is very good. We used to think that VOA, VOP is good target if you have, and they're still good targets, but PTT is much better than that. And again, with HIFU, you can do along the PTT lesions, going all the way up to the base of thalamus.
So you can do multiple. Yes.
So you can get so much benefit in echinacea and rigidity.
Right. So, and one last comment about bilaterality. So what we do generally is one-sided PTT, and when it is required for the next side, we do palidotomy. So non-corresponding targets, I think, work very well for either Parkinson or dystonias and.
Rather than bilateral,
rather than same structure.
Palidotomy is if you do one PTT and one palidotomy, or even both PTTs.
Even both PTTs, sir.
Much more safer.
So we've done 5 both PTTs and quite okay, manageable. So not much side effects
good.
in general. Yeah.
Good.
Right. Thank you, sir.
Thank
Very
you.
fascinating talk. We'll move on to the next talk, gamma knife radiosurgery in pain. Professor Deepak Agrawal.
So, good afternoon to all of you again. We have talked about the different modalities from DBS to, I would say, lesioning to HIFU. Now I'll come to gamma knife, which I do for pain, and which we recently started over the last few years. So I want to introduce you to the concept of radiomodulation. You know, this is this has been published, and this was by John Adler also, that if we give sublethal doses of radiation, it changes the neuronal behavior without actually destroying the neurons or the axons. And this axonal destruction actually occurs at very high doses, maybe 80 grays or more. But if you give lower doses, 40 grays, 60 grays, nobody's got a target yet, this may lead modulation without ablation. So if you look at this figure out here, you can see that if we are giving very high radiation, obviously there's endothelial damage, neuronal damage, axonal degeneration. But if you are giving lower doses, there is reduced synaptic activity. It's a down regulation of the whole neuronal complex where we are targeting. And this has come out very nicely in the epilepsy model, where it has been demonstrated that if you give around 40 grays, the spontaneous firing, this is by single cell monitoring, they found out that spontaneous firing of neurons decreased by around 50%. And this was sustained. So you are given 40 gray one time, but the sustained decrease in the firing of neurons. Then they took out the brains and put them through histopathology, and they found there was no evidence of necrosis. So this is a very convincing and clinching study that this is what the hypothesis is actually there. Also, because we've been talking of various modalities, and you can see all the modalities listed here on the left side. Radiomodulation, or by gamma knife, that is, it is the only modality which the direction of neuromodulation is always down. Why I'm saying is, any other modality, if you're stimulating, you can have paresthesia, as we talked about, a lot of speakers told that you have other kinds of hyperesthesia, you have problems and patient may not like it. Here you only have down regulation, you don't have new symptoms coming in, and that's very good. Also, it is non-invasive, it is focal, and as HIFU, it can reach anywhere in the brain. That's the beauty. It can reach down to the cervical region also. So coming back to our, the theme, which is pain and radio modulation and pain. So I'll start with trigeminal neuralgia, and I'll go on to other domains. We have to understand what we accept as pain relief, and this is the BNI grading, which is if there is 3A, it means that despite medication is required, but despite medication, there is no pain. So I think that is what is considered very good relief and as a standard for relief in major papers. With gamma knife, the ability to be pain-free comes immediately, I would say within 2 to 4 weeks. And this is where pain is different from any other lesioning or by gamma knife. So if you do gamma knife, so tumors to any other thing, it will take months, years for the response to occur. But for pain, the response occurs in weeks and sometimes in days. That is the beauty of this radio modulation. And you can see here that up to 80% of the patients have, by 2 months, they have achieved pain relief. So it is not taking 6 months, 12 months, and it's become very flatline. So they have achieved that relief. Now what happens is, how long are they pain-free? There are so many dogmas about gamma knife and radiosurgery in general, especially in trigeminal neuralgia. You look at 10 years, and we have around 50% of the patients still having BNI grade 3A. That means they are pain-free, maybe on medication, but they are pain-free. Even at 12 years, 44%. Very good pain relief. And side effects. One of the side effects is hyperesthesia because the trigeminal nerve may get activated, and you see extremely low, 0.1 to 0.2%, and whatever happens within the first 2 years, then nothing happens. That is the beauty. So very low complication rate, negligible complication rate. Coming to again recurrence. Now this is a different thing. If you are pain free, you might try other things like balloon decompression or something else after gamma knife, but not surgery, because this is what the patient is the king. They don't want to undergo surgery, come what may. And in that case, this slide is important because it shows that they can remain pain free with gamma knife plus minus other procedures or medication which is equivalent to MVD. So this is what we are saying, almost 80% improvement, and all these slides are only relevant for one particular type of trigeminal neuralgia, that is the typical trigeminal neuralgia. This is T1, in which you have episodic pain. Obviously it's a complex kind of trigeminal neuralgia, we have continuous pain. All this does not hold true, and that is true for anything. So typical trigeminal neuralgia, excellent relief. What we do is we combine typical and atypical trigeminal neuralgia and show that the results are very bad. And this was another study which also asked the patient at the end of the study that do they have any regrets after 5 years, 10 years that they underwent gamma knife and not MVD, and you can see that more than 95% either did not have an opinion or rated it very highly. You compare this with MVD results, which we all say are the gold standard in the best of, and this paper is by Janetta himself, so there is no better gold standard. This is still 70% at 10 years. What happens if these patients fail trial and they come back with recurrence? The beauty is you can again give gamma knife, and I have personally given many patients after the last few years only, twice gamma knife, and one patient thrice gamma knife, and still we have very good relief. So it's a mixed bag, but it is something you can keep trying, and 5 patients we have given with I would say 70% of them having good results, but the good result is for a variable duration. You cannot, some patient may have good relief for 6 months, some may have it for 2 years, some may have it for longer. So this duration is what you provide them. You cannot give them a number that this is like MVD. You can say, okay, for the next 5 years or something you might have very good pain relief. With gamma knife you cannot say, it's individual. Statistically you can say that over 10 years, you 50% chance that you will be pain free. If we fail standard lesioning, and as Dr. Milind also showed, obviously the thalamic lesioning is there. People have tried it, published it. We personally have not tried thalamic lesioning for trigeminal neuralgia simply because they all walking, talking patients, normal like you and me, apparently normal. So we are just too scared to lesion the thalamus right now, and we would prefer rather doing a MVD than going in for a thalamic lesioning in these cases. But if the patient comes after MVD failure, then I think that would be the right candidate for us to try. Cancer pain, we have been discussing a lot since morning about cancer pain, and pituitary stalk irradiation with gamma knife. So just the stalk, you give gamma knife, 160 grays. This was the paper which got us thinking. So the authors here showed that 100% pain relief within days, and this persisted till the patient's death. So no hormonal dysfunction also occurred in these patients. So then we also were searching, and we found a patient. This was a 43-year-old female with CA lung, solitary brain metastasis. So we gave the gamma knife to the metastasis. Then she came back with severe pain in the head and all over the body, and we referred her to palliative care. Palliative care, they started up with morphine, increased to 120 milligrams of morphine per day. She was 40 milligrams 6 hourly or 4 hourly. She was getting morphine, and no response to pain. So then we decided, okay, we can try her as a first case. She was an advocate, so we were a little worried. But she had tried everything anyway. So we gave gamma knife to the stock, and this was again 160 grays. This was January last year. And within a week, there was dramatic response. She could stop morphine altogether from 120 milligrams to 0. And we just followed her up a few weeks back. Currently also her pain score is 1/10, which means negligible. So she is very well, and this response is continuing, which shows that it is very stable. Second patient, acromegalic. I think all of us as neurosurgeons have seen acromegalic patients, pituitary patients with severe pain, not responding at acromegaly. I usually start them on somatostatin or refer to endo to start somatostatin. But many a time they don't respond to somatostatin also, and they continue to complain of severe pain, not responding to analgesics. And this would be a response I would say you would have seen personally, every one of you. So then we offered a pituitary stalk irradiation because pain was 10/10, 9/10. Again, and she was on hormone displacement therapy, so we thought it would not really harm her in any way in case something happened. Again, dramatic response to pain. And we have 6 months follow-up on her also. We just followed her up. Her current pain score is 2/10. So because we have started all these patients in the last couple of years only, we have follow-up around maximum around 2 years, I would say. Third patient, which we did again, was a 54-year-old male. This was a CA soft palate who had underwent surgery, chemo, radio, everything. Had recurrence with maxillary involvement. The maxillary involvement went into the orbit, and from the orbit into the orbital apex intracranially. So they referred to us for gamma knife of that metastasis in the orbital region and the maxilla. So when he presented, he had that intracranial lesion, but I'll be combining two presentations, so my talk is 15 minutes more. So this we gave gamma knife to the orbital lesion, obviously with the integral, and we said we'll give it to the pituitary stalk also, because again the patient was having severe hemifacial pain. Again, not responding to morphine, they were already on palliative care. Dramatic relief within 3 days. So he was very happy. We have follow-up 3 months, again pain score is 2/10. So I think it is an excellent modality, again very, very underutilized. And for cancer pain, from head to toe, we have seen various things from DRG to cordotomy to, spinal cord stimulation to everything at the top of the neck. This, I would say, I would rate it number 1. It's so simple and it can be used, and we have used it now on these many patients. There are other studies which have shown that you can target other, as Dr. Milind also showed, using lesionectomy or by HIFU, the same targets can be targeted by gamma knife, although we personally do not have experience in this. Chronic pain, again, you heard about so many talks on chronic pain. This is a major paper which a very large number of patients, and the beauty about this paper is majority of the patients do not have cancer pain. So 73 were non-malignant, they might be having failed back syndrome or something else. And here they gave they did a medial thalamotomy, and there was an initial reduction of from 40 to 100% of the patient initially, which remained there at last follow-up. So 50% of the patient who responded, the response was very stable or durable and was there till last follow-up. In headaches also, we have tried, and this is two types of headaches. One is the sunk, this is the short. In these patients, what happens is you have very short episodes of headache which are continuous, like a train of headaches, along with the continuous watering from the eyes. So even we didn't see these patients. There's this patient who came to me after failing, this was 34-year-old female, and pain score was 10/10, tried everything, and they had been trying medications for last 5 years. So we said, okay, because we read this paper, we said, okay, we'll do the same. We'll give you for the trigeminal nerve and the sphenopalatine ganglion. I think Girish has been doing sphenopalatine. I think gamma knife to the sphenopalatine ganglion, excellent, very, very simple. Again, we gave it and it was in relief within 3 days. Within 3 days, she had complete relief, and we have 15 months follow-up on her also. Pain score is 1/10. So imagine from where she was, very durable relief. Cluster headaches, people have tried. We personally have not tried cluster headache, and they have found that it has excellent results in cluster headache. So to conclude, I would say stereotactic radiosurgery has a huge role also in your armamentarium wherever it is available. Obviously, you have to see in the chain of availability where your institution stands, and I would rate it very, very high from our own personal experience. Thank you so much.
So small question. You mentioned one orbital lesion in which at the same time you gave radiation to the stalk. But for patients such as acromegaly and these who are presenting, they many times present with a lot of headache. Would you wait after surgery or would you consider doing them side by side as well?
No, surgery is primary. So these all patients, the acromegalic also came after surgery. After surgery, residual lesion, severe pain. So there also we gave gamma knife first to the residual lesion. And we gave them the option, maybe that also would have helped, but it didn't help. So again they came back, so then I decided to do only pituitary stroke.
Is there any time frame that you would wait after the gamma knife?
I cannot answer that because they have single patients, so we have no, I would say, experience in that. And there are no papers also in this, for this. Yes, Ido.
Thank you. Very interesting. So when you target the stalk, you target. Thank you. So when you target the stalk, you target it just above the.
Just above the
pituitary.
Yes.
And what is the dose that the optic chiasm or the optic nerve receives?
No, optic chiasm receives less than 10 grays, and nerves receive less than 8 grays. So it is quite low, just above the pituitary gland.
And it's 160 to a point dose?
To a point dose. Just one collimeter, 4 millimeter collimeter.
Okay.
100%.
We have to try it.
Yes.
Excellent talk there. I think the issue with gamma knife is, over the decades, they were interested more in ABM, CT angles and what have you. The functional neurosurgery was
Yes, relegated to the back.
Even thalamotomy, trigeminal work, it is very difficult to get it done. So I think I congratulate you that you're taking that on. Certainly, it definitely has a role to play.
Yes, thank you.
So sir, one more question. So as you said regarding trigeminal neuralgia, I said, so do you think the age might be a consideration to offer as a MBD or a gamma knife? Suppose how will you
No,
decide?
that is always a consideration. If a patient comes after 70 years of age, his ejection fraction is very low, they are anyway poor candidates for surgery in terms of surgical risk. So patient, relatives, doctor, all three in those cases would agree for a non-invasive, which starts with medicine, then balloon occlusion or something like Gesserian block, and then they might prefer gamma knife if they know about it. It all depends on who's referring to whom. This is the practice everywhere.
And one more thing, just because as in pain clinic we receive many patients at different stages of say the same trigeminal neuralgia, we have initially done a PMBC or balloon, later on responded to RF. So do you think that the effect of gamma knife will be different
Yes,
if you
very
offer
good
to
question.
a
Yes.
classical patient and to
All studies have shown for every modality that if you offer that modality first, it gives the best result. So if you provide MVD first, it gives the message. Same gamma knife papers have also shown if you provide it upfront first, it gives the best result. If you provide it after failed block or longer duration, it gives poorer result.
Yes, sir. Thank you.
I think that has to do with the pain pathway which has set in, chronic pain. Yes, Ido.
Do you think also after failed MVD, do you think it's harder to target the nerve? Or do you have any experience with?
Yes, we have done, I would say, around 5-6 cases after failed MVD. The nerve is usually thinned out, so it is not very difficult to target, but yes, the nerve is thinned out. That is one thing we have noticed. And the result is not as good as would have been upfront.
Thank you.
Thank you very much for this wonderful session, and then I thank all the chairpersons for doing a really excellent job, being on time. So we move on to the last section. This is from all the central, now I'm moving towards periphery. So this is on peripheral neuromodulation. I would like to invite the chairpersons for this. Dr. Shantanu is here. Shantanu is not here. Nihal Ahmed. Nihal Ahmed is again our former epilepsy and functional neurosurgery fellow, and he's practicing as a consultant neurosurgeon. Was in Kerala and now moved to Bangalore. He is from Bangalore, by the way. Raghu Samala. Dr. Raghu, yeah. Dr. Raghu is again our senior most, one of the senior epilepsy and functional neurosurgery fellow again. He is practicing at AIJ Hyderabad. He is doing both epilepsy and functional work. Now he is interested in pain, so he wants to start it. So I think we have two. So, okay, then we can start the session. We'll start the session with Dr. Raghu himself will be giving the first talk on the peripheral nerve stimulation for pain, an overview.
So I thank you organizers for giving me this opportunity and organizing a conference of neuromodulation, particularly in the peripheral. Now, when you go to a DBS conference for the movement disorders, the people are like halls are full of people and so much of things are going on. When coming to the peripheral neuromodulation, which is not much practiced in India because of financial reasons and lack of education, and this initiation is much appreciated. So we are doing cranial neuromodulation for the movement disorders, but we have just started neuromodulation for the peripheral now pain and other things recently. So I start with some case scenarios. This is a 34-year-old male patient who underwent RMSOC for a hemispatial spasm outside and had a greater occipital nerve injury. Then he came with the complaints of shocks of 20 seconds duration with a VS score of 8 to 10 and more than 30 episodes per hour. So outside they did alcohol lysis of the occipital nerve, which caused very severe burning pain. That resolved over the time, but the shock type of pain came back again. So when he approached us, so what is the next step? So the case scenario 2 is a 54-year female with a known case of Aplar syndrome, underwent a below-knee amputation with a stump pain following wearing of the prosthesis, and she developed the blisters and they healed and started having severe pain even for the light touch, so which is unbearable. And the USG was showing multiple neuromas at the closure site, stump site. So what is the next option? So these are all failed cases for routine best medical management. Case scenario 3 is a 30 male with a penetrating bullet injury when he has a elbow flexed. So there are 4 wounds, 2 exit and entry wounds. There was a medial and radial nerve injury, and there was a hematoma. Surgery was done. He didn't recover. Both the nerves completely gone. So he had interesting pain patterns. So pressure anywhere in the body, he will have the severe excruciating pain at the operating site, where the bullet injuries happened. So what is the next step in these kind of patients? These are very hard to treat patients. So there comes the peripheral nerve stimulation for pain. So why about the PNS now? So initially, when initially started, the implants itself were like they're bigger. We had to open the nerve and implantable VNS kind of devices were there. Recently the advanced have become more advanced, and the implants have become very miniature, and it can be done at the OPD basis. So these can be used for the many patients of this kind. So coming to the history of peripheral nerve stimulation, the first reports were published in 1962 and 67, but the percutaneous approach of the lead placement was started from 1999 onwards. So last 20 years there was a tremendous improvement in the technology, and the various companies have come with the various versions of miniatures of peripheral nerve stimulators. So this is a technology. Initially it was open surgeries where the lead was like encirclage type. We have to find the nerve, and we have to do the open surgeries and all those things. But nowadays it is ultrasound guided or fluoroscopy guided placements, and most of them are daycare procedures. So this creates a major, decreases the major surgical intervention to a daycare procedure. So the concept, since morning we are hearing the same things again and again. The mechanism of action, now we are well versed with it. The segmental, the gate control theory, or dorsal horn, decreasing the hyper-excitability, or activation of descending inhibitory pathways, and local neurotransmitter modulation. So these are the various devices. I don't think that none of them are available. So in India, I think most of them are done with using sacral nerve stimulators or spinal cord stimulators. So the stimulating parameters, we use 3 types of parameters: the low frequency stimulation, mid-range stimulation, and high frequency. The usually low frequency stimulator, they stimulate the alpha beta fibers, which are mainly for the motor contraction. So most of these things will be used in hemiplegic shoulder pains, or like low back pains where there is no other organic causes there. The mid-range most commonly used 20 to 100 Hz. So it has a sensory effect. So they cause paresthesias and vibration. So these commonly used parameters for most of the pain conditions. A high frequency, or like these are more than 1500, or ultra high. These are still, the literature is evolving over this. The pain relief without paresthesias. So the patient selection, the favorable profile will be well localized neuropathic pain or mixed pain mapping, particularly localized to a named nerve. Then pathology should be stable, and all the surgically correctable things should be addressed. The failure of the optimized conservative therapy, and then the patient should have the realistic expectations. So these patients are good candidates for the peripheral nerve stimulators. Whereas the red flags come to the poorly defined widespread pains, or uncontrolled psychiatric disease, or contraindication to any surgical procedure. So what evidence says? So the evidence for the peripheral nerve stimulation is now it's very robust. Level 1, level 2 evidence is there. So more than 66% of the patients, they will improve. Pain improvement is more than 50%. Level 3 evidence is mainly for the pelvic pain or refractory cluster headaches. There is a limited use of peripheral nerve stimulation. So these are the common indications: upper extremity, post-stroke shoulder pain, post-surgical trauma, peripheral neuralgia, post-surgery, craniofacial, we listened since morning, that refractory migraine, then abdominopelvic, genitofemoral nerve, there's a low back pain, very common, multifidus, medial branch nerves, and cluneal pains, lower extremity, all sorts of sciatic, femoral, common peroneal, neuralgia, ankle pains or peripheral neuropathy, all this can be treated with the peripheral nerve stimulators. So these are other common indicators: occipital neuralgias, axillary or suprascapular pains, intercostal pains, post-herpetic neuralgias, or back pain, or pelvic, tibial or pudendal nerves. So what are the strategies for the PNS? So whenever we want to go for a PNS, we have to choose whether it will work for the patient. So how do we do it? So one way is like for a proper placement of the PNS lead, there is a one thing called nerve block. So you give a combination of lidocaine and bupivacaine and see if you are targeting the correct nerve. So if the pain is relieving with that, it will only show that the target is correct. So whether it is the nerve block doesn't depend on the long-term outcomes. So the next is short-term PNS. Usually this is micro electrode which is placed and waited for 60 days almost. So In this case, after removal of the 60 days, because of the neuromodulation effects, the pain will continue to get relieved for more than 60 days. The trial period is usually for 1 week, and we place the lead and we'll see if the patient gets relief for more than 50% of the pain relief, and then we consider as a trial as a success and we implant the peripheral nerve stimulator. So most common technique is a day care procedure, so based on USG guided or fluoroscopy, but the fluoroscopy used when the bone nerve is particularly consistent with the bony anatomy, or other nerves we go with the ultrasound guided. So the lead is placed few mm away from the nerve. It should not be intraneurally and parallel to the nerve most of the times, and pulse width, frequency, amplitude have to be adjusted comfortable to the tolerable limits of paresthesia and motor contraction. So programming conventionally is a paresthesia based stimulation for the painful field, or for the recent thing which is coming is subperception, high frequency or burst patterns are coming up. So 60 to 70% of the patient achieve more than 50% of the pain reduction, and beyond the trial, the short duration trial, which is like a 60 days trial, can yield benefits lasting for months to years. The safety profile and complications, most adverse related to the device hardware, which are usually lead migration, irritation or discomfort, infection, and the other neurological complications when we put the lead very close to the nerve or intraneural placement. So peripheral nerve stimulator versus SCG or DRG. The strength of PNS is when the pain is localized to a particular nerve, the PNS will help, whereas spinal cord stimulator or DRG more regional or widespread pain syndromes. So for the case scenario 1 that we thought, like greater occipital nerve injury with a pain shock, like he might benefit from the greater occipital nerve stimulation. For the stump pain, probably from a sciatic nerve neurostimulation, and penetrating bullet injury, which has a diffuse body spread. So he gets a pain in this hand whenever he apply pressure elsewhere. So this could be he could be benefited from cervical spinal cord stimulator, or that is more than the peripheral nerve stimulator. So peripheral nerve stimulation is also used for other functional indicators like fecal incontinence, epilepsy, central sleep apnea, obstructive sleep apnea, or the restless syndrome, etc. The future perspective would be the new lead designs which become more miniature and closed loop PNS, and resorbable leads in case of where we want to keep limited time application like short term, like 60 days. The smaller battery inclusive fully implantable devices that will allow more patient acceptability. So these are the other advanced. Take home message would be the PNS is applicable and has a good result when there is a discrete neuropathic pain or axial pain which exhausted conservative management. Contemporary PNS is image guided, minimally invasive, and can be done at the daycare. And integrated neuromodulation program should include the neurosurgeon, neurology, and the pain physicians, etc. Thank you.
Thank you, Dr. Raghu. We are open to any questions.
Which system do you use? Sir, at our center we didn't use as of now anything. So if at all any patient comes, we intend to use sacral nerve stimulator.
So thank you, Dr. Raghu. So next I would like to invite Professor Milind Devgankar for his talk on occipital nerve stimulation.
I'll try to run fast through the talk, but I might go over time a little bit because this is one of the subjects I love. I started doing peripheral nerve stimulation in 2003 when no one else was doing it. Konstantin Slavin and me were the first one who published on PNS. So I'm going to talk about occipital nerve stimulation, but I'm going to cover PNS also. So peripheral neuromodulation basically is not only about pain. It's about functional electrical stimulation. We did FES, we put in the bions on the nerves to make the nerves move. It's a bladder ball function, sacral nerve stimulation, VNS, Motor stimulation, phrenic nerve stimulators, hypoglossal nerve stimulations, autonomic stimulation. We designed autonomic stimulators for renal stimulation and bronchial stimulation for asthma and hypertension. So I put in peripheral nerve stimulators everywhere in the body. My nurse had a chart of a humanoid, and whenever I put a PNS, she will put a stick on it, that little hat pin. And I was full of hat pins. So everywhere we put in peripheral nerve stimulation. Perirectal pain, testicular pain, inframammary pain, everywhere. And it works, pretty much everywhere it works. How does it work? Does it block the nerve? No chance, because Dominic Duran, Nilay Bhadra, and we did the experiments where we did muscle nerve preparation, tried to block it. To block a myelinated nerve, you need 4000 hertz, 4 kilohertz of energy. None of these commercial things can provide it, and if it provides, it will burn the nerve, so it will be neurotomy. So it doesn't block the nerve. Then what does it do? Probably closes the gate at that level, at the nerve level. More than that, it works centrally. Central neuromodulation in chronic migraines. We published a paper, and this was another paper. This was a occipital nerve stimulation paper, where they have shown that patients who had good benefit, all their pain areas, nociceptive areas were deactivated. And this was one of our RSD patient where we did the peripheral stimulation. This was when the stimulator was off, and this was when the stimulator was on. Look at the nucleus accumbens. The nucleus accumbens is completely deactivated. So it works centrally. It doesn't work peripherally. And that's why the objection was, should we call it peripheral nerve stimulation? So Konstantin Slevin and we had published that CNS volume. We started calling it peripheral nerve field stimulation. You are actually not stimulating the nerve. You are stimulating the skin or the dermatome supplied by that nerve. So that dermatome closes the gate, if it closes the gate, because you get vibrotactile, just like TENS machine does. But TENS machine does to the surface. What we are doing is going below the subcutaneous area and catching the nerves coming from vibrotactile receptors. So we started calling it peripheral field nerve stimulation, and we did another experiment in occipital nerve stimulation. I'll tell you about that. So this is a simple solution for a very complex problem. These localized focal pain areas are very, very complex problem. And these pains are rarely over a defined nerve. Sometimes in hernia, if they tie ilioinguinal nerve, you will have that in ilioinguinal nerve distribution. But otherwise, they are kind of in general distribution, like around the ankle, around the knee. So first few we did, we put in the paddle leads. That time these specify leads were available with 4 contacts. One contact, one lead above other over the nerve, stitched it. And Amit was then my fellow, so we published also this. But this was too cumbersome, too big a procedure. So we started just putting in the leads in the vicinity of the pain, below the skin. And we have these 1700 patients, 15 patients with paddle sandwich leads. Average duration 9 years, range from 1 to 27 years. Number of surgeries in past, average 2.5, range 0 to 11. And these are the different locations that we have done. Maximum is occipital neuralgia, supraorbital stim for migraines, complex craniofacial pain, low back pain, mid-thoracic pain, neck pain, neuralgia paraesthetica, inguinal neuralgias, peroneal nerve region pain, pudendal perineal pain, pudendal neuropathy also, it works very well, arm pain, shoulder pain, hand pain, post-herpetic neuralgias, post-thoracotomy pain, even post-craniotomy pain, abdominal pain. For pancreatic pain, we have done that. So, occipital nerve stimulation, the main indications were occipital neuralgia, episodic migraines, continuous migraines, cervicogenic headaches, cluster headaches, otalgia. Sometimes otalgia also responded. We had to put one lead in the front and one occipital lead. Fibromyalgia, all these responded fairly good. Now when I say good, Well, beforehand, we used to tell the patient before the trial, 50% will get benefit, and benefit will be around 50%. And most of our patient, I mean, on an average, we got about 60% or 70% trial to conversion ratio, trial to implant conversion ratio, because our neuropsychologist was very strict and she wouldn't let any patient pass. So, most of them had more than 60% benefit. We always did surgery in 2 stages: trial placement, 5 to 12 days trial, then internalize, and then pain medicine, then programming, and then pain medicine reduction. And this is a general cohort. We had published of around 800 patients. Old slide. This was, I think, 2012 or 13. So after 10 years, we still had a good benefit in all those patients. Location-wise, face pain seems to respond the best. Trigeminal, post-trigeminal, post-intervention trigeminal neuropathic pain responded best to peripheral stimulation. In general, craniofacial pain is not different than other pains. It still responds the same, slightly better, but not statistically significant. Duration of pain also not very statistically significant, though longer the pain lasts, there is less reduction in the pain scores. Gender also not significantly responsive difference. Complications, we had migrations in 2 in all these patients, infections in 3, erosions in 3, loss of efficacy leading to removal in 2. So what we did to optimize the outcome, especially in ONS, just going to talk about ONS, patient selection. In ONS, in occipital neuralgias, unilateral occipital neuralgia will always respond better than bilateral occipital neuralgia. If it's a migraine, then just don't put only occipital stimulation. You need a C2 stimulation. Along with that, you need a trigeminal stimulation. So 2 supraorbital leads, I used to go from here, 1 supraorbital, 2nd supraorbital, 1 occipital, 2nd occipital. If you get both the systems stimulated, the migraines will go away. The migraines respond very, very well. Neuropsychology, of course, needs to be clean. Lead location in occipital neuralgia, there are a lot of people think lot of things. There are 9 ways to skin a cat. You can put a lead horizontal, or you can put 2 leads going that way, or you can put 2 leads going that way. The only thing you need to remember is your leads need to be above C2. That's where the occipital nerve comes out. So above C2, your leads need to be, and you need to be very close to the midline, because the midline contacts are the best contacts. Doesn't matter if you stimulate laterally, the stimulation will go in your ear, but your migraines won't go away. Unless you stimulate in the midline, the migraines or headaches or occipital neuralgia will not go away. These are some of the pictures. So like I was saying, these both systems need to be stimulated. So 2 occipital leads, 2 supraorbital leads. And these are 2 V2 maxillary leads. And these are just plain simple occipital leads, 1 on either side, 1 on this side. So initially when I used to use C-arm to do this, I'll go from the odontoid process to mastoid on either side. Odontoid process to mastoid. So 2 or 2 centimeters before the mastoid you stop. So your contact 0 remains in the center, and 2/3 of distance to mastoid. Then I just stopped using X-ray also. This was a post-craniotomy pain, so we put in leads around the craniotomy site. And this was the lifesaver. This is what made us do all these cases. On-cue tunneler. This is a tunneler for pain buster pumps. Those pumps they put in for post-operative pain control. And this tunneler has a very, very soft tip and has a sheath which you can peel off. And it bends any which way you want. So you want to put it here, you put it, you bend it, you put it. The tip will always remain in subcutaneous plane because it's soft. It's not sharp. Sharp will come near the skin, then the patient will start having burning or will go down, then the patient will not have any benefit. So we used on-cue tunneler. This is just how we used to put the on-cue tunneler through a small incision, lift the skin up, put the tunneler in, put the leads in. This is how we used to mark the area of pain. So rather than focusing on the nerve, we used to focus on the area of pain. We would either bracket the area of the pain if there is lot of allodynia, sensory loss, or we will put it through the area of pain. And these are some other leads that we have put in various types of peripheral stimulations for neck pain, for central pain, for neck and shoulder pain, for median nerve injury, for non-specific abdominal pain, for post-thoracotomy pain, for again back pain non-operative, and this is post-herpetic neuralgias, and this is post-herniorrhaphy inguinal pain. You put in leads right over the inguinal nerves, the pain goes away completely. Shoulder pain, leg pain. So you have to anchor those leads. Programming is very, very important. The rate cannot be above 40 or 50. Peripheral nerves cannot tolerate rates above 50. If you make the rate 20 or 30, it will be thumping. So thump, thump, thump. At 40 or 50 will be pleasant. If you go to 100, it will start burning. So always peripheral nerve stimulator, 40 or 50 rate. Pulse width 60 or 100. You make the pulse width bigger, you go too near the skin, and again it starts burning or pinching. Use minimum number of cathodes. Use large bipolars. Don't put in cathodes. That's why some of the systems like Boston's, where there is fractionated current, is not good, because it creates globulates of currents. We need to have a smooth bipole. And guarded cathode is not useful. You guard the cathode, it will basically drive the stimulation in the skin. It will start burning and pinching. So ONS in general and PNS, as I said, is safe and minimally invasive, has excellent therapeutic benefit, acceptable combinations, complications, and can be used for difficult area pain. We used it in perirectal pain, in patients with bad pudendal neuralgias, where you cannot do anything. We already did the pudendal canal decompression, they still had pain. So in inframammary pain, now how are you going to treat it? You can put in DRGA, but DRGA is too much invasive, and I'm always afraid of DRGA. It doesn't matter what Dr. Dureja says. I'm always very, very afraid to put. This was one of the trial we did, sub-Q stim. Autonomic, this is the one that you were talking about, our company that stopped producing it. And then the idea was to put in stimulating rings in the bronchia, in the trachea, and then stimulate when you have asthma attacks. That way they stimulate the sympathetic and attack goes away. So focal autonomic neuromodulation by peripheral stimulation. Same thing in the kidneys, like patient comes in a shock, you put a stimulating stent, so there is sympatholysis of the kidneys, rest of the body sympathetic tone remains high, but you don't get into acute renal injury. And once they come out of shock, pull it out. So these were some of our patents. And this is a book written by me, Borrowed Pen. It's a poetry book available on Amazon. So that is my hobby, pain. That's why I do so many pain surgeries. Thank you for listening.
Excellent talk, Professor. If I may ask a basic question, like you mentioned occipital neuralgia as an indication. So how do you compare that occipital nerve stimulation to RF ablation? And how do you select the patients for those?
See, I would always go with the occipital block first. Occipital block helps, great. 3 blocks at the interval of 2 months, that is 6 months. At the end of 3 block was getting benefit, but the pain is coming back, I'll go for RF. If RF takes away the pain, but RF is notoriously inaccurate in occipital nerves, because occipital nerve, if you ever have done open decompression of the occipital nerve, you know there are so many muscle bands and layers over it, that so after all this is done, then I will go to occipital nerve stimulation. And even the blocks don't help, I'll still go for occipital nerve stimulation, because the mechanism of a nerve block is completely different than what you are doing. And that experiment I was telling you, St. Jude's before had come up with a percutaneous paddle lead. So it was like a percutaneous lead, 1.8 millimeter in diameter, but contacts only on one side. Other side was completely plastic. So we started putting those leads for ONS. And the leads, when the contacts were on the side of the nerve, had less benefit. When the contacts were on the side of the skin, had more benefits. So we started thinking, this is now, we're not stimulating nerve, we are stimulating C2 dermatome, and that is causing central inhibition. So did that answer your question?
Thank you.
Okay.
Any more questions?
So it's not mandatory to have a block first before ONS?
No.
You can straight away go ahead.
But it's a good idea to do a block. If block helps, then why so much thing? If block helps and the pain comes back, then do it second time, third time, fourth time, nothing, and do RF. So this is all said and done because I can do it, I like to do it, but it's not good for patients. They have a system in their body. And with PNS, because it's off-label indication, no one will do a MRI scan. Because SAR values are not very high, but companies are not ready to say these are MRI compatible, because this is off-label use. So you are making them not able to have MRI for rest of their life.
But ultimately you will then tend to have a block first to see whether it works or not. If it's not working, then you go ahead with ONS, and if it's working, you continue with the block. That is what is the
Correct.
process. So what about peripheral neurectomy?
Peripheral neurectomy is amazing. I mean, before this, I remember in 98, 99, 2000, I done bunch of supraorbital and occipital neurectomies. Very good as far as the immediate result is concerned. And then almost 60% of patient, within 3 months, deafferentation pain will come back. And that deafferentation pain is worse than the original pain. It happens in almost 60% of patients. Better than that, Jeff Janis was a plastic surgeon who used to work with us. He used to do these microsurgical decompressions of occipital nerve and different areas, buttocks areas in the scalp. There are muscles below our scalp, and he used to do microsurgical decompression of the small branches of scalp nerves. That works very well. But neurotomies, no.
One last question.
Yeah, I agree with you. I think our algorithm is we would do 4 to 6 GON blocks, doctor guided and high volume injection. The block is not only to relieve the pain, but with each block the muscle relax and it allows the nerve to heal and recover. So if you do 4 to 6 series of blocks, after that you'll see that the occipital neuralgia has resolved actually, so you don't need anything to do. But if it still persists, we would do the PINS procedure, which is it doesn't ablate the nerve, it's only stimulating the nerve at alternating frequency. And again, if you do 4 to 6, the effect is cumulative, and that also acts like a trial for ONS. So after all this has passed, that's when I would implant a occipital nerve stimulator, and we always use a paddle implant for the ONS because our lead migration rate is almost minimal with these, whereas with any cylindrical leads, the migration rate is almost 50 to 60%.
Not ours. The only reason was we used to put battery here. With battery here, leads don't migrate. With battery here, they will not. If you put the battery on the back, then they will migrate because there is arc. So we'll always use 60 centimeter leads, though this is less than 30 centimeters, and loop them and loop them and loop them and loop them, and then just bring them to the front, put a battery here. So very, very less.
I mean, in literature, I've always been doing paddle because of that, because all the literature review says that it's almost 50 to 60% with cylindrical leads. You put the battery there or in the back. So we do from lateral and then go this way, put 2 paddles.
And the other thing is our belief that it also stimulates the skin, not the nerves.
I mean, it's a field stimulation. It's not a nerve because.
So with paddle lead, you will just get the stimulation of the nerve inside. So cylindrical will stimulate both nerve and skin. So.
But you know, at the cost of migration. But we get very good results with the paddle leads actually.
Yeah, I mean, I tell you, whatever you put in there, you put an external stimulator also on this, it will be good. So I think the devices are all the same. You just have to put it in the area of pain and things get better. SNM is a cylindrical contact, so it stimulates both. SNM is exactly like SCS lead, the old SCS quad lead, but with tines on it. Exactly, so that's even better. It will not migrate. So only SNM has a limitation of frequencies, but this needs low frequency. So that can be definitely used. Only the SNM is not long enough. They are only 28 centimeter wires here, not longer than that. SNM makes 28 and 40 centimeter, but 40 centimeter is not available in India. So you will have to put battery somewhere here so that it doesn't come down. Yeah. But SNM is a good idea for peripheral nursing. Yeah, it's not available. DNS is not, but SNM is there. So yeah, we used SNM sacral neuromodulation for phrenic stimulation. Yes. Because there is no phrenic stimulator available in India. And this Medtronic lead keeps on moving. So I said tines. So we put it right on the phrenic nerve, cortex graft around it, tied it, and it worked.
Okay, thank you, Professor, for the enlightening talk.
So now I invite Dr. Jitin Bajaj to share his experience on migraine surgery.
Thankful to Professor Ramesh Dhulamani for inviting me. So I'll be presenting on surgeries for migraine, particularly peripheral neurectomies. We have vast experience on that. We all know that migraine is a global disease, and many of these patients are drug refractory. You require some interventions for these. There are two theories. First is vasodilation theory, we all know, and second is trigeminal cervical theory, which says that there are peripheral triggers in the scalp which releases neuropeptides in and around the dura mater, and that causes the central sensitization. So central sensitization because of peripheral triggers. This is the summary of this theory, and it has been supported by many electron microscopic studies. And also we know that many of the drugs have come, like AC inhibitors, which are given for migraine. Botox is given for migraine. These all acts on the trigeminal cervical theory. And we all know that both direct and indirect costs have to be borne by the patient whenever they are suffering from chronic migraines. So the definition of migraine has been defined by the ICSD-3 criteria. I will not go into the detail. We only do intervention for chronic migraineurs. That means whenever patient has migraine headache for 15 or more days per month, more than 3 months, and for at least 8 days per month. However, we can do surgery even for patients who are not fitting exactly into this criteria. For example, a patient if is having 2 or 3 episodes per month, but still having very severe causing disability to his life, then we can go for surgery. There are abortive therapies, which includes medical therapies, NSAIDs, triptans, lasmitan, etc. There are prophylactic therapies. And then when these medical therapies do not work, we apply Botox injections or blocks, and if they are effective, we advise them to go for surgery. The options of surgery include neurolysis, neurectomies, RF pulse, and neuromodulation. Definitely the neuromodulation has a implication of high cost, and it may not be suitable for many of the Indian patients. And for these, neurectomies or neurolysis are very effective. The problem with RF pulse in my scenario was that RF during the impulse, as these patients are generally done under awake conditions, that short period has it was very painful for the patients. And many of the time the nerves are having a varied anatomy. So in my series, I do neurectomies only, and we have shown our results in the randomized control trial. So this is our flow chart. The patient comes, we take appropriate history, we ask her or him from where the pain starts. Now initially the patient will not tell from where the pain starts in the first go. You have to repeatedly ask him, and then you palpate the scalp for his tender points, palpable pulses and scar marks. You have to exclude other causes, for example refractive errors, pneumolar headaches and osteomas. So you have to exclude them, even patients who have hypertrophic turbinates. So they are the patients who are not candidates for this type of surgery. Then you apply a block. If the patient is having pain in your OPD, you apply a bupivacaine block. If not, you apply a Botox injection. Do not tell the patient what is the duration of the effect of the drug. And when the patient is having good efficacy of the block, then you go for surgery, either neurotomy or neurolysis. If there is no benefit for the block, you search for other causes and continue medical management. Approximately 50% of patients fit, they can be selected for the surgery. So there are different indices to rate the patient: migraine log, visual analog scale, PSEQ. I will not go into the details of these indices, but these are very helpful to compare the baseline versus the follow-ups. So briefly about the innervation of scalp. The frontal headaches are because of supratrochlear and supraorbital. Temporal headaches are because of zygomatic-temporal nerve. This nerve supplies the hairless area of the temporal region. The hair-bearing area is supplied by the auriculotemporal nerve, which is just alongside the superficial temporal artery. The back area is supplied by the lesser occipital nerve, and the midline areas are supplied by the greater occipital nerves. The frontal headache is because of these three muscles. Actually, this surgery, it was devised by one plastic surgeon who was doing eyebrow surgeries for females, and after the eyebrow surgery, the pain got resolved. So you need not to remember very much about these muscles. You need to know the anatomy of the SON and STN. The SON can be in these different types, and you need to be aware of these anatomical variations. The supratrochlear nerve also has is under the muscle, so it is not superficial; it is under the muscle. This is one short surgical video. So the incision is very small for both of the nerves, 0.5 centimeter, 1.5 centimeter. These are the anatomy from the midline, and you need to go underneath the muscle. And this is important for localizing nerve also, and it's also important to bury the nerve beneath the muscle. This is thus you avoid the neuroma formation and the deafferentation pain. And regarding the deafferentation pain, we all know that if you bury the nerve, the cut end of the nerve inside the muscle, and we often, many a times we do large craniotomies, large scalp incisions, and many of the times these nerves get spontaneously cut during the surgery, mistakenly cut during surgery, and hardly these nerves produce deafferentation pain in the postoperative phase. So the surgery is easy. Only thing is you have to little bit pull the nerve and cut it. You can also apply incisions in the hair areas and go endoscopically and do proper neurolysis or neurectomies. The temporal migraine, as I said, the hairless area is from the zygomatic temporal nerve. This is the landmark of this is 16 mm lateral to the lateral canthus and 6 mm above it. The nerve arises from the temporalis muscle and it travels below the superficial temporal, below the deep temporal fascia. So the one important thing is noticed to avoid injury of the facial nerve, which is between the superficial and deep temporal fascia. So this is an example of auriculotemporal neurectomy, which travels along the superficial temporal artery. So you can palpate. All these surgeries are done under local anesthesia, so you can reproduce the pain during your surgery. So there was a clear-cut neurovascular conflict. This was easily coagulated and cut. Then the zygomatic temporal neurectomy can be done endoscopically because the pain site is at the hairless area. So you do not want to make an incision over there. You apply incision on the in the hair bearing area and then go beneath the deep temporal fascia. So you again palpate it and reproduce the pain, and then you can cut after coagulation. The surgeries are very simple. The greater occipital nerves, they are around 1.52 centimeter from the midline, and these are beneath the trapezius fascia. So this is important to remember. If you search above the trapezius fascia, you will not find the nerve. And again, you can do either a neurolysis or neurectomy depending on the choice. We do neurectomies and we have good follow-up now. Lesser occipital nerves, you can find them 1/3 distance from the mastoid process to the external occipital protuberance, and these are very notorious. This lesser occipital nerve are notorious for being in variation in anatomy. So you need to properly see them. You need to find and see them, cut them. So this was a study when we compared the medical management versus surgery. So this was VASCOR. So this red line is the medical arm and this is surgical arm. You can see considerable reduction in surgery. The second is the migraine headache index. The third is MIDAS index. We can see good improvement in the disability in the surgical arm compared to the red line of medical arm, and similarly improvement in the pain self-efficacy questionnaire. These results were at 6 months. And these are the preoperative status of all the 4 things. And you can see in the surgical arm, again, there was good improvement in the MIDAS, PACQ, and MHI. Patients, however, still may require SOS use of analgesics. However, they all become free from the prophylactic propranolol and other treatments. There can be numbness over the scalp. However, it is more when you do proper examination rather than patient complaining of that. The results are durable. At 5 years follow-up, patients have 29% patients, they become completely migraine-free. The improvement is sustained in 88% of patients. So there is immediate improvement that reduces spontaneously in over the some months, but still at the 5 years there is good degree of improvement. This was a multicentric study in 2023 which compared this peripheral neurectomies versus targeted Botox injections. And they found that there was lower pain intensity and work-related disabilities in the surgical group compared to the Botox. Also about socioeconomical analysis, the surgical treatment of migraine trigger sites is a very cost-effective modality even compared to the medical treatment. So to summarize, this peripheral neurectomies for migraine is an option, and these have high chances of success in appropriately selected patients. Of course, you need to also have proper burying of the nerve inside the muscle or below the fascia. There are hardly any major complications, and this surgery is underutilized. I mean, there are many patients in our society which can be benefited from this surgery. Thankful to my teachers.
Thank you, sir. It's wonderful talk. The session is open for questions.
Do you try CGRP and receptor antagonist?
So this has recently been come. So for abortive therapies, we generally rely on naproxen and other sumatriptans and other things. Yes, we can give lasmiditan for abortive therapies. You are right, sir. But again, that's also a very costly tablet. That's 50 rupees per tablet, and many patients require twice a day. And suppose they require for considerable years of time, that becomes very costly for the patients. No, not that.
Thank you, very interesting. Any prognostic factors to say who will respond to surgery and who won't?
Yeah, biggest prognostic factor is if a patient is neuropsychologically fine and he is responding to the blocks. So if he is responding to the blocks, he will respond to the neurectomies. Yes.
Are you doing 1 or 2 neurectomies or multiple neurectomies also, and how much is the sensory loss?
Yeah, mostly patients require 1 or 2 neurectomies. We did 3 neurectomies in a single patient, in only one patient. Patient doesn't complain of numbness per se. However, if we examine, then yes, they will complain. Otherwise, patient they are happy with the gone of pain.
What's your recurrence rate?
Sir, in our follow-up of 5 years, yes, the patients have started SOS use of analgesis again. But prophylactic, they have all stopped.
So any dysesthetic components? Or
No.
such?
I'm surprised actually. There are no dysesthetic complaints in our patients, and many of the patients we know that we do craniotomies. We have some. I think the scalp has some different property than the other body structures. We do scalp incisions, but hardly any patient come with the dysesthetic pain, even in very long follow-ups. Yes, sir.
Those patients which we give scalpel, they don't have this migraine. But patients with migraine have a complicated, there are two subgroups.
Yes, sir. That's what in the initial slides I said, sir. Only 50% of patients we selected for the surgery based on the rigid criteria, sir. Not all patients are suitable for this.
So again, just to understand, so you think there's a neurovascular conflict between the vessel and the artery, and if you coagulate or cut the artery and prevent it, wouldn't that be also?
Scalp has a very rich vascular supply, sir. If you
Question is, like trigeminal neuralgia, is there a neurovascular conflict at the center?
yes. In one case there was.
Yeah, instead of cutting the nerve,
Yeah.
coagulate the artery.
Yeah, you are right, sir. You can do that. Actually, you can do that. However, since we are going in and we do not want to have a redo surgery sort of, so we do the whole procedures itself. We do both the things.
Any technique to localize the site of conflict?
Yeah, you apply a bupivacaine block if the patient is having pain in your OPDs.
Conflict.
Neurovascular conflict, the exact location of a neurovascular conflict?
No, we localize the trigger site. That neurovascular conflict is generally an intraoperative finding. Yeah, it cannot be hardly. Yeah, you can do palpation. If it's a surface vessel, then you can palpate it. If it's a deep vessel, you cannot.
The local trigger site always gives you a
So thank you, sir. Wonderful talk. Now I invite on Dr. Vaishnavi Lingareddy for sharing her experience in the role of intrathecal drug delivery systems for pain.
Good afternoon, everybody. I think I'm the odd man out here. All of you are neurosurgeons. I'm the neuroanesthetist, obligated to be a pain physician. Now I started embracing it. I practice in Hyderabad at AEG hospitals. So why do we really need an intrathecal drug delivery system when we have a drug that is orally available and as well as intravenous drug is available? So why do we need such an invasive system which actually needs intervention into the intrathecal space and actually pose a risk of meningitis and other infections locally or systemically? So the answer is, sorry, the image is very shabby because it was a retracted pump from a patient, unfortunately expired, and it is a targeted delivery system. The drug is directly delivered into the intrathecal system, and where the drug acts is the dorsal horn of the spinal cord, and the drug is directly delivered into the system. And here the most important thing is the pharmacodynamics of the particular drug. How hydrophilic or how lipophilic is the drug? How much is the absorbability? If it is the uptake is very good, then it is not a good choice. Then a minimal systemic load is also a good indication for putting an intrathecal drug delivery. That means if a patient is requiring Liofen more than 100 to 200, or even some patients are actually taking more than 400 BD, in those kind of patients, intrathecal pump is a very good option. And it is programmable. That means the dose can be variable throughout the day. And I'll show you how to program also. In that it is very clearly visible. And in the closed loop capability, recent times the pump is not so capable of giving a closed loop system, and here it is telemetrically programmable is what they are telling, but no, we need to program the device through Bluetooth. and the Bluetooth should be obviously near to the device. So indications means according to the illness, the indication differs. Mainly the chronic malignant pain, non-malignant pains. In the CRPS type 1 and type 2, not very sure how morphine actually helps. And even the persistent spinal pain syndrome, SCS, is the gold standard of care. And even the neuropathic pain, peripheral nerve stimulators and as well as spinal cord stimulator is the modality of choice. But post-herpetic neuralgia, I would say that intrathecal drug delivery system will be an overkill. It will be just dealt with the DRG stimulation. We don't have to have an invasive device that is in situ for the lifetime. So mostly the cancer-related pains or the non-cancer-related pains and the severe spasticity comes under the gold standard indications for the intrathecal drug delivery systems. So common intrathecal drugs, though I have mentioned everything here, I have experience only with morphine and baclofen. Ziconotide, which is a non-opioid analgesic, is not available in India. Hydromorphone also is not available in India. And the bupivacaine is a local anesthetic which doesn't actually release the spasm because the local anesthetic action is completely different. And fentanyl, which is a very short acting and which is highly lipophilic drug, doesn't actually make sense to use such a short acting drug for a intrathecal drug delivery system. So the patient selection, before patient selection, obviously like everyone told, there is a trial period. So when there is a trial period, when the patient you feel like it is, he or she will fit into your criteria for, say for suppose morphine, you call the patient and then make sure that naloxone is available and then do a trial administration, start with 0.3 mg and see the VAS scores. Usually the onset of pain relief will be around within 1 to 4 hours. But in case of baclofen, I would suggest the intrathecal catheter insertion and continuous infusion because the spasticity of may differ actually from time to time and the response to the physiotherapy also we need to assess. So these are some scenarios where we have implanted morphine. It is a 60-year-old female with known case of CA breast with well-controlled primaries, but patient had brachial plexopathy, which is very refractory to pregabalin, gabapentin and all the conventional analgesics. Then we have tried intrathecal baclofen on day 2 as 0.3, day 1 as 0.3, day 4 0.5, and we have given a drug holiday for a week to know whether the patient is actually having a relief, because initially once you start with 0.3 they will have relief, and once you give 0.5 they will expect immense relief, and that when that will not happen they will again complain. That is where the neuropsychology part is very important. So you give a drug holiday, you get their pain scores back to their baseline, that's when they will realize the minimum 0.3 was actually helpful. And it is another case of 68-year-old male with CA rectum with rib mets, which was not actually responding even with the intercostal nerve RF ablation. And another case is a non-oncogenic pain for chronic pancreatitis, where I work is it is a mainly gastro center, and we have huge input for gastrointestinal problems. So this is a patient with chronic pancreatitis, and he was having pain scores of 8/10 all through the day, not able to have food, and here also we have inserted the morphine pump. So whatever I have told you till now, it is like patient preparation and single shot bolus and monitor the vitals. The risk of respiratory depression always has to be observed at least for 4 hours after giving morphine, and keep naloxone in hand. And the positive trial is anything baseline score 50% reduction is considered to be a positive thing. So I know the image is shabby, and I'm sorry that the tablet that we work is also broken. The Medtronic thing. So here you can see the first image is showing the concentration of morphine, that is 1.8 milligrams per ml. In the second image you can see the settings, that is 0.7 mg is actually being delivered in a day, that is 0.03 mg per hour is what we have set. And this is how the basic screen of the device will be when we communicate with the device, that is how much mg per day we have actually asked for, and what is the serial number, and how much is the battery life when they have to change the battery, and the pump volume. So coming to the baclofen, so these are the case scenarios where there was a successful baclofen pump insertion. And it is a 22-year-old male with sudden onset of dorsal transverse myelitis. Patient had sudden onset of spastic paraparesis of both lower limbs, and he was not able to walk. He was given medical management with rituximab and pulse dose steroids, after which slowly the changes of the spinal cord actually did not resolve though, but they were static. But he was having residual severe spastic paraparesis. And in the picture you can see a 11-year-old child with this bifid cord, and you can see the resting attitude of the limb. The left limb is actually more flexed than the right one, and the patient is having both bowel and bladder symptoms as well. But we gave a trial, and he's having a scoliotic spine as well. We gave a trial of intrathecal baclofen here with a continuous infusion, but unfortunately the patient is having differential Ashworth grading for both the limbs. So even with the minimal dose, that is less than 0.2 mics per kg per hour, also developed a flaccid limb of the left leg, because of which he was not able to walk. And other thing that was noticeable here in this case was the patient lost axial balance, truncal balance, even with that much of minimal dose, maybe because of his spinal cord anatomy. And here is another case of 38-year-old cervical spinal cord injury with spastic quadriparesis. And here what could be the challenge? Here the patient is having spastic quadriparesis. The problem is the catheter tip placement. Usually the advised level where we place the catheter tip is around D8 to D10. But if we really want the upper limb also to be involved in the baclofen thing and to release spasms, the tip should be little higher up. And when we go little higher up, the disadvantage will be again the same thing, the truncal balance and the diaphragmatic palsy. So to avoid that, it is very difficult to titrate the doses and to titrate the catheter tip placement. So this is how the baclofen ampule that looks, and you will refill the pump clean, that is 500 mics will be coming in 20 ml, and the pump capacity is 40 ml, and so take 2 ampules of baclofen and just refill it. And this is the grading, modified Ashworth grading. Any grade that is actually, there are 2 criteria whether the trial is successful or not. One is the subjective criteria and the other one is the objective criteria. In the subjective criteria, obviously the patient improvement, and the objective criteria in the modified Ashworth grade, anywhere the grade improvement of more than 2 is considered to be a positive trial. And after the positive trial, you are going to send the patient for the neuropsychiatric assessment for fitness for getting an implant done. So this is again the same thing, tunneling, catheter placement, and make sure the catheter tip is there at the desired level using C-arm and create a pocket. And in the second image you can see that doctor is filling the diaphragm. That is how the diaphragm looks. So whenever I do the refill, the simple technique that I follow is use a 22 gauge IV cannula, remove the silicone tip, use the steel one because it will be very sturdy. So press the diaphragm and go and hit the bottom of the diaphragm as well. That means you have to go through and through so that the needle is not disturbed, so that you are actually filling the pump, and keep aspirating in between. That is one of the important troubleshooting thing, because if you deposit so much of baclofen in the subcutaneous area or morphine, then it is going to be a disaster. So this is how the baclofen programming is going to look like. If you see here the timings, we have in the night, in the morning you can see the doses are less, whereas in the night, that is 12 AM, the 6-hour period, the dose is more, because this patient particularly had more of nocturnal spasms which were not making him fall asleep. So again we can actually modulate like continuous baseline infusion we will keep like 0.25 to 0.5 mics per kg per hour, and intermittent boluses like when the patient is about to go to physiotherapy or any other activity, and 1 dose prior to sleep. So this is how it is going to be. And if at all we are supposed to give a manual bolus just to check if the patient is again complaining of spasticity with this particular dose, we can actually manually give the dose. So what are the complications of the system? Catheter tip granulomas are mainly with morphine. Kinking can be there with any of the device, and pump failure mainly with the battery failure, and here infection, PDPH, and drug overdose or withdrawal. Whenever you are switching a patient from intravenous baclofen to a baclofen pump, make sure the patient receives oral baclofen before implantation or the trial, because sudden withdrawal can lead to rhabdomyolysis and hyperkalemia, which is a life-threatening complication, and opioid hyperalgesia is also another complication, and contraindications are same. So when a patient is having a loss of analgesia, how do you troubleshoot? There might be a disconnection from the catheter to the pump, and CT is the best modality to tell whether there is any disconnection, overdosing or underdosing. And whenever you fill, always communicate with the technician and make sure the technician send you a screenshot how he has filled and the concentration of the drug is correct or not. Otherwise, overdose can kill the patient, and there are incidents where that happened. Any questions?
Any questions?
So especially programming is necessary not for morphine patients. So whenever the disease is progressing, then if we actually give some gabapentins or pregabalin and even then the patient is having pain, then yes, we increase the dose of morphine. Regarding baclofen, the patient specifically complains when the physiotherapist comes, I am not able to cooperate with the physiotherapist. That's when we actually tell the patient to fix the timing of the physiotherapy, like particular day, and we have, in that particular day, what we will do is 1 hour before, say for suppose the physiotherapist comes to the patient, like usually home visits at around 10 o'clock, you program a bolus dose at around 9 a.m. so that by the time the physiotherapist arrives, the patient is actually ready for cooperating for the physio and the spasticity levels are less. In that way, overdose is less. But they have to follow the schedule, because once it is programmed, we can't change. I mean, we can change, but once it is programmed, again, they have to communicate with the device before changing it. So communicating with the device is the issue. Remotely we can't. We have to need a Bluetooth device and we have to be present with the patient and then communicate with the device.
So that optimization you do at the hospital?
Actually, nowadays we are giving the technician number to the patients. They will be in contact with each other, but the problem is we always check whether they have programmed, and if so, to send the screenshots. The screenshots that I have shown is, that's how they communicated to me, and when I say yes, then only they will start the pump like that.
For baclofen, how frequently do we have to?
So it depends. So this particular young patient, 22-year-old, his spasms were becoming more and more, where we actually increased even up to like 60. We started with 30, now it is 60. So that means the pump will get empty frequently. That is, the pump that used to come for 90 days comes for 60 days. So they have to come more frequently for the hospital for the refill. And that also has to be done very aseptic precautions.
So like every 3 months
we try to make it like longer as possible so that the concentration is more. So we never dilute the drug, give clean. Morphine we dilute. So morphine, what I do is I take 5 ampules, that is, one is 15 mg and dilute it to 40 and then give. Baclofen is a clean.
and any wound issues related?
Very rarely, sir. Once it is healed, no, sir. Because that's why 22 gauge steel needle will not cause any injury. Hardly it bleeds. Even the patient who is on antiplatelets or coagulants, there is not an issue because it is a subcutaneous pocket. So it's not an issue. But finding the diaphragm is very important. So repeated aspirations while pushing the drug is also important. When you find the space, make sure that you aspirate the remaining fluid, because when they program, they have to document it as 40 ml. So if the pump is actually already having some amount of drug, say for suppose 0.3 ml, even then also the calculation differs. So we aspirate, make it empty and again fill it with 40 ml of clean drug.
This is done by technician?
No sir, I do.
What is the battery life of this product?
Battery life will be 10 years.
10 years.
It will be given in the Medtronics thing, and they will actually given. They claim for 10 years, sir. As of now, no, none of the patients lived beyond that. So we need to see. Baclofen patient is actually alive.
6 to 7 years.
Okay, if there are no further questions, we conclude this session. Thank you, Dr. Vaishnavi, for such an enlightening talk. So we break for coffee.
So not only coffee, Nihal, we still have the program. So we definitely, yeah, we break for the coffee because 2 long sessions, but interesting. And still the hall is packed, that's a good thing. So we break for coffee. After that, we have a hands-on DBS. So there are 2 stations there. One is the Medtronic and on Boston Scientific. So Professor Girish, Professor Milind and Professor Ido, all 3 will be helping us like demonstrating the frame fixation first. We have the Vantage frame, so that is what is commonly used now, and then we all have to be well versed in it. So we'll start with the Vantage frame fixation, and then we have the programming stations where you can learn from the experts. You want to look for the targets for the PD, for pain, so they are here to help out, both Dr. Milind and Dr. Girish and even Dr. Ido. So after the coffee, we'll meet at the stations. Yeah, you can have a coffee and pick it up and then you can just watch it. But don't spill on people. Thank you very much, and has been a great day. Sir, वो एक ही system है. There's only one frame. ठीक है sir.